I declare open this hearing of the Senate Community Affairs References Committee's inquiry into the provision of general practitioner and related primary health services to outer metropolitan, rural and regional Australians. And I want to start by acknowledging the traditional owners and the land on which we meet. I'm here in Melbourne on Wurundjeri country, but wherever we are, we're on First Nations lands. And I want to acknowledge and pay respects to elders past, present and emerging, and to all First Nations peoples and any First Nations peoples who may join us today. I'm Senator Janet Rice. I'm the chair of the References Committee, and I've also got with me Senators Green, Patrick and Askew. So these are public proceedings and a Hansard transcript is being made. The hearing is also being
broadcast. Sorry, Janet, Holly's here as well.
Oh, thank you, Senator Hughes. Great. Yes, and the hearing is also being broadcast via the internet. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It's unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also contempt to give false or misleading evidence to a committee. The committee prefers all evidence to be given in public, although the committee may determine or agree to a request to have evidence heard in private session. If a witness objects to answering a question, the witness should state the ground upon which the objection is taken, and the committee will determine whether it will insist on an answer, having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. Such a request may also be made at any other time. The committee understands that all witnesses appearing today have been provided with information regarding parliamentary privilege and the protection of witnesses. Additional copies of this information can be obtained from the Secretariat. And finally, I ask everyone to check their mobile phones to make sure that they are either on silent or switched off. So, and now I welcome via video conference representatives from the Royal Australian College of Practitioners and the Australian Medical Association. Thank you very much for appearing before the committee today. So to start off with, can I please ask you to state your name and the capacity in which you appear for the benefit of the Hansard transcript. So starting off with the College of General Practitioners. Oh, are you on mute, Karen? Sorry.
I have the T-shirt to prove it. I beg your pardon. Dr. Karen Price, President of the RACGP. Thank you. Good morning.
Good morning. I'm Dr. Michael Clements. I'm Chair of the RACGP Rural Faculty.
Thanks, Dr. Price and Dr. Clements. And now from the AMA.
I'm Dr. Chris Moy. I'm the Vice President of the Australian Medical Association, and I'm a GP from South Australia.
And Dr. Peter Maguire, I'm the representative from the Council of Rural Doctors for the AMA, and I'm a GP in Narrogin in Western Australia.
Thank you, Dr. Moy and Associate Professor Maguire. So, look, can I ask when each of you speak, if you could do your best to speak clearly and identify yourself each time you speak to assist with the recording and the broadcast of these proceedings, and hopefully the technology will hold up. So look, I now ask each of you to make a brief opening statement should you wish to do so, and after that I'll ask the committee members to ask you some questions. And just noting that we've read your submissions, so if you want to keep your opening statement very brief, it will give us more time to sort of have the conversation and the questions and engage with you. So the college, do you wish to make an opening statement?
Yes, I'd like to acknowledge the land on which I'm on, which is Boonwurrung land today, and I'd like to pay my respects to elders past, present and emerging, and acknowledge their spiritual connections to country. So thank you, everybody. Dr. Clements and I are here today on behalf of the RACGP, or Royal Australian College of General Practitioners. We'd like to thank the committee for the opportunity to give evidence. The RACGP is Australia's largest professional general practice organisation, representing over 40,000 members working in or towards a career in general practice. Dr. Michael Clements here today represents the chair of the rural faculty, which represents 20,000 GPs, of which 10,000 are providing general practice services across rural and remote Australia. We'd like to note that 80% of rural doctors are RACGP members. We do need a system that supports general practitioners. We know the issues: chronic underfunding, increasing complex care means GPs are working harder or less, and we need to see doctors as people who want portable leave entitlements, flexibility and attractive remuneration. We need to address the Medicare compliance burden and regulatory pressures which make general practice a less attractive option for the future workforce. Supporting general practitioners is supporting the communities that they serve. We need an MBS system that supports longer consultation times and supports the changing needs of consumers with the rise of chronic and complex conditions. We don't see just one issue at a time. We need a system that trains and supports GPs to go rural and to stay rural. General practice is a fantastic career, both Michael and I can attest. We need to get the distribution priority areas right. We need the right frameworks to support international medical graduates. We really do want the best trained GPs doing the best work in the right location. To do that, we need a nationally consistent training program, and we have been working tirelessly to enact our vision for a college-led training. We will be training the future workforce to ensure they have the right mix of skills, control over their career journeys, and the best possible supervision and support, without which this program won't work. We know it is community-based. Our rural GPs love their jobs. We want future GPs to love it just as much. This inquiry is an opportunity to look at how we can encourage current and future GPs to discover the joys and challenges of this highly rewarding career using the best evidence available. Thank you again for the opportunity to appear before you. We look forward to answering your questions on our program.
Thanks, Dr. Price. So the AMA, did you wish to make an opening statement?
Yes, thank you. I'll probably adapt my words, and it'd be rather informal after what Karen has said, which probably does cover many of the things we're going to cover. So I'd like to firstly acknowledge the traditional owners of the lands on which we meet and pay respects to elders past and present, and thank the committee for the opportunity to appear today. I'm appearing with Dr. Peter Maguire, who's an experienced GP with many years of rural practice behind him in West Australia, and is also someone who's been really deeply committed to training the next generation of general practitioners and rural doctors. Look, bottom line, I live this, and so does Peter and all four of us here. General practice is the humble foundation of a world-leading health system in Australia, and we provide exceptional care and coordinate access to the rest of the health system, and have done this incredibly cost-effectively for many years now. And through this whole pandemic, there's been a tremendous effort to first up care for and advise a nervous population, adapt to telehealth and new technologies, and that's been quite an amazing effort, really. And also to lead the vaccine rollout, which, despite what you may hear, I think general practice has been the one that's actually been the bedrock of the vaccination program. In all this, I think the thing that has become clear is the central role of general practice, but it's also shone a light on the significant challenges faced by GPs as successive governments have failed to address in terms of resourcing. Investment has not matched the increases in the costs and demands that general practice has really needed in terms of support to provide high quality care, in terms of rebate freezes, and also inadequate indexing. And I think the other thing is that there's just been quite a change in general practice, as Karen has said, in terms of the fact that we're looking after much more in terms of aged, complex care, chronic disease, and mental illness, for which the funding model currently may not fit and is not as adaptable. So while the Medicare fee-for-service model really needs to be maintained, we do need to look at new models and evolve general practice in a way to be able to care for a new population, just as we've adapted with things like telehealth. The issue then is that I know that I understand that the scope of this inquiry may have actually shifted slightly over time, because I think it's really found the fact that although that the matters of outer metropolitan and rural general practice and the problems you're seeing there are really greatly due to the fact of the inadequate resourcing of general practice as a whole. And these are exacerbated in outer metro because of the fact that there's increased socioeconomic disadvantage in outer metro areas, increased needed to bulk bill, increase therefore inability to provide the sort of resources needed in outer metro, and also increased demands on the general practitioners having to travel, but also increasing pressure on them because of the reduced resourcing that they're under. And I think then we extend out into the rural areas where I think everything is even more severe, where you've got obviously distance, reduced support, reduced economies of scale, but I think also reduced support for not just the doctor themselves, but the potential family units that are out there. We're talking about families that actually need to go out there, and the lack of support for them has to be kept in mind when considering future changes to support rural general practice. AMA is in strong support of the sort of work in rural generalism and the rural generalist program, but we see that really general practice as a whole, but particularly rural general practice, has become less and less attractive because of the reduced support for general practice as a whole. So while we support the moves in that area, we do think we need to do things now. And there's desperate need to start to make changes now, and that really needs to get to the heart of things like recognition of rural doctors, their working conditions, and looking at remuneration, and also just thinking about the things that would support a general practice and a general practitioner out in the community, and their families. We do have current sort of classification systems and components to try and increase incentives into the country, but they're sort of blunt instruments, and we need some flexibility to keep rural practice going and to support the future of rural practice. So look, I think ultimately what I'd say is general practice as a whole has done an incredible job recently. I hope that's now appreciated. We do need support for general practice as a whole, but particularly the lack of support over time has really magnified the problems, has been magnified in outer metro and rural areas. And for that reason, we need to consider increased general support for general practice as a whole. And if we don't do this, the health outcomes will deteriorate for both the general community, but those in outer metro and rural areas. Thank you.
Thanks, Dr. Moy. Okay, we've also had Senator O'Neill join us as well. So we've got 6 senators on the line, so plenty of us to ask you lots of questions now. So I'll ask Senator Green to begin.
Thanks, Chair, and hopefully we've gotten past those technical issues we had the other day and everyone can hear me okay? Fantastic. Thank you so much for joining us today and kicking off the public hearings of this really important inquiry. And can I also start off by thanking you and all of your members for their efforts over the past 18 months, or almost going into 2 years now, over this COVID pandemic. Certainly I live in a rural and regional area in Cairns, and so I certainly appreciate the efforts from our local GPs here in managing COVID-19, not just testing, but also now administering the vaccines. We really do appreciate it. I moved the motion in the Senate to establish this inquiry. There's a lot of policy reasons, but also from a personal point of view, it's very hard locally for us to be able to get access to GPs at the moment. There's another story in the Cairns Post today about the lack of access to GPs and the impact that is going to have. So I've got some questions, I guess, about the extent of the issue and some short-term issues that may be arising, but also long-term and specific issues about training. So to begin with, I think I've been out around regional Queensland for the last 6 months talking to people about this issue, and I had a doctor in Emerald who should probably be retiring very soon, but can't because he's one of the only GPs in Emerald. And he turned to the people in the room that I was in and said to them that this is a dire situation, was the words that he used, and really tried to impress on the people in his community that this is something that needs to be fixed now. Is this a crisis? Are we in a crisis of shortage of GPs around the country, particularly in outer metropolitan, rural and regional areas, and something that needs, I guess, urgent attention from all of our governments?
Well, the short answer is yes, and I think you might be referring to Dr. Ewan McPhee. who's
Yes, I was.
yes, of course, in Emerald. Look, it is a dire situation. General, this is really the pointy bit of the sort of things that Dr. Moy was just talking about in terms of a decade of underfunding, but also we've got a maldistribution in particular. And so trying to draw that out, we've had temporary fixes like IMG, recruitment into rural areas and bonded medical schemes, which are good for short term, but they're not really a sustainable solution. We do need, as you would attest, living in a rural area, and I know Ewan's area, a rural and remote infrastructure to support doctors in place who want to be there, who are committed to the community. And this is a long-term program, which is what the PLT is going to be addressing. I've noted in various submissions referring to the PGPPP program, which is developing a pipeline of rurally interested students right back from medical school. In fact, we're even talking about developing talks for work experience students in high school so that we get rurally interested students engaged in that community focus and engaged in the communities on a long-term basis, so they know the people and they know the relationships around them. This is a really critical part of developing that pipeline through into a sustainable model. We've also got to be mindful of some of the workload on rural practitioners and making sure that there is relief and support for their educational needs and so forth. But it's much more complex than just providing a pull through money. It is, as Clements noted, it's also about family, it's about education, and it's about those complexities.
A complex but urgent problem. Difficult.
An urgent problem that's been a long time coming, Senator.
Mm-hmm. Yeah. Dr. Moy, did you want to add to that?
Look, I've felt this in South Australia. We've got a particular crisis in South Australia at the moment.
Right.
In the news already, and I was just recently the South Australian president, and just ended that job, and which started off negotiations with the various rural doctors. Look, what I sort of found after a while is that certainly there needs to be long-term solutions, and they come back down to starting at medical school, flowing right through training, and really trying to align, making sure we've got enough medical students who actually come from rural areas, following them through, supporting them right through, making sure they're aligned, to particular areas, they can go back to where they came from potentially, with the right skill mix for the populations that they have there, the sort of long-term things, and to really favour them, in fact, actually, right through both, medical school and through training. And they're the long-term solutions. But then you've actually got to consider, what's going to attract them to do that and to stay there. And they are matters of things like relative remuneration, understanding that they do not have the economies of scale out there. Not just so far, not in terms of not just financial, but we're talking about in terms of support, which is becoming worse and worse because we are talking about a different population of doctors over time. Many may not be prepared to be on call 24 hours a day, 7 days a week now, and we do need to take that into account. We do need more support, not just for the individuals, but their families, and we do need to consider things like support for housing, schooling, things like also support for employment of partners who may be going with them, so that they're more likely to stay. All those things are things to consider over time, but also obviously support for infrastructure and matters like that over time. Now we've had some blunt instruments such as the areas of workforce disadvantage and things like that, but we probably need to be. Think one rural GP said to me, think about how come one of the mining companies, what does it take to get them to get a family to go out into a rural area, and start to think smart like that and be flexible like that in actually trying to consider what would it take.
I'm just going to, I do have more questions about training, and I really want to get into that because there's a lot of, evidence about if, you train someone who's from the bush, they're more likely to stay in the bush. So I want to come back to that, but I do want to understand, the short-term difficulties that this problem is creating right now, because this is something that you deal with day in, day out, but really, I think that people in government and in departments and possibly even in the public don't appreciate what is actually happening on the ground right now. One question, I don't want to get too far into COVID, but I think that it is relevant right now. I did want to understand if you could let the committee know how the GP shortage right now in rural and regional areas particularly will impact, I guess, the plan that we have to live with COVID, particularly hospital in the home. And what we've seen in Cairns at least is that a lot of people are being turned away from GPs and ending up in our emergency department in our hospitals. That's a short-term sort of impact of the crisis, and I've got some questions about the longer-term impact that will have on the well-being of Australians. But really, I think I've tried to explain this to officials and ministers in estimates last week, and it just didn't feel like they were understanding how immediate the issue is. Dr. Maguire, I think, has a response. You might be on mute. Oh, there you go.
Mute. Yes, there you go. Got it. Yes, thank you, Senator, for the question. So I work in a small town of 5,000 people in WA. We are desperately under-doctored as it is, and patients wait 2-3 weeks for appointments. We have difficulty staffing our emergency department regularly and rely very heavily on locums who drive in from Perth. So if we add to that mix COVID, we have seen the impact even with the vaccinations that has significantly cut down the number of appointments for patients. So there's only so much time that our GPs have, and we certainly are concerned about what's coming. And you mentioned hospital in the home, and the idea that many COVID patients who are not particularly unwell, but who need monitoring and who may deteriorate, will need monitoring, and probably by telehealth. And that's going to impact severely on the already stretched business as usual, just looking after patients' acute problems and preventive care. So there is a very real impact, and we've seen this for many years now in our town, that we've struggled to recruit. Like my colleague from Emerald in Queensland, I'm very close to retirement, and in fact, out of our GPs, three or four of us in my stage of our careers, and we've struggled to recruit young doctors. So the situation really is dire, and unfortunately, as we've discussed, there are no quick fixes. There's no single solution. We've been trying this for years, but we really need to. It is a crisis situation. I agree.
In terms of COVID positive pathways, it needs to be an integrated solution for sure. And in rural and regional areas, it's very complex because of the need for more infrastructure in terms of how to manage. Some of the recent initiatives have been helpful. Telehealth will be helpful. We're hopeful with the increased vaccination rates, although they're lower in some of the rural communities, that we will mostly see mild COVID. And we're having to recalibrate our practices to handle infectious disease, which probably 50 years ago they were doing. But now we've got more information about how to manage this. And it is going to require some infrastructure and support in reconfiguring how we actually work with infectious disease patients. So in a rural community, of course, that's critical because you have much less reliance on staff. So we're going to need increased support for nursing staff and allied health to help us manage, as well as continuation of telehealth, but also the infrastructure within practice. And that includes Medicare benefits to support doctors being able to see these patients.
Thank you, Dr. Clements. I think you wanted to.
Yep.
Thank you. And I'm from Townsville, so I've got two general practices in Townsville and one on Magnetic Island.
Feeling the heat the same as me at the moment, probably.
It's coming. The heat is coming. So we certainly are in a crisis, and I think, if we think of GPs as the bridge for a community to better healthcare, if we help them get better healthcare, which makes strong, sustainable communities, we've been on fire for a long time, and COVID's really fanned that, has given oxygen to the fire. Our GPs are burnt out and are leaving. Julia Creek lost its only doctor this year. Woodner is in South Australia, is in the papers in the last couple of days. Their doctor just resigned, their last doctor. You've got a swathe of the middle of the Eyre Peninsula where one doctor is responsible for whole regions. In the midst of COVID, this is very dangerous. GPs work best in collaborative models where we're working within teams and we're providing oversight and support, using telehealth, using nurses, using nurse practitioners, Aboriginal health workers. But if we don't have the doctors there leading that team, there are people that are going to be missed. There'll be people that are sick from COVID that don't get the assessment that they need. There'll be people that can't access a GP. And just don't think about just the COVID infections itself. We're looking at an epidemic of long COVID coming, and we know that they're going to require extreme support from their GPs. We know that long COVID mimics some of the other chronic diseases we've seen. And if you're in a rural and remote community without a GP, your risks of not surviving COVID, number one, are higher, but also the management of your long COVID symptoms is going to be a lot worse.
Thank you. And I guess that certainly does lead into my next question before we head on to talk about training. The doctors that I've spoken to around regional Queensland particularly, but in other parts of the country, talk about their concern around the long-term impacts of their patients. So because there is a lack of GPs in an area, people are less likely to come in for preventative health appointments, maternal health appointments as well. I know I'm right now actually being kicked by a 24-week-old pregnancy. So, and I know it's really hard for me to go and see a GP. So sometimes if there's something I'm a bit worried about, I might skip it and wait till the next scan. What are sort of the long-term impacts on health and particularly for government, the cost of that on the budget? Departments and officials like to think about the bottom line. By not investing in our GP practices and our primary health network, are we actually costing the budget more in the long term?
I might jump in because I was the last person to speak. Only to say, sorry, Karen, just to quickly say, listen, we got a taste of it. So we got a taste of what it's like when people don't see GPs with the COVID lockdowns. I had 60, 70, 80-year-olds too scared to leave their house for months that didn't come and see us because of the COVID fear. And we saw what happened. What we saw was later diagnosis of cancer. We saw people with abdominal pain for 4 months present with metastatic colorectal cancer. One of my GP friends, a partner, is a pathologist, and said, oh my gosh, I've never seen such advanced cancer. Normally I see cancer much earlier. Now I'm doing pathology samples on things that are a lot further. So we are seeing the health burdens. We are seeing cancer increase. We're seeing the mental health burden. When people don't have access to GPs for that preventative aspect, we are seeing it already, and that's just going to get worse. Sorry, Karen.
That's what I was going to say, that yes, across all the cancer streams, it's not just rural, of course, but if there's an access issue that will be exacerbated, but there's 10 different cancer streams where there's been, from Cancer Australia stats, a delay in presentation and a dip, and we know with chronic disease also. And we've got a PricewaterhouseCoopers vision for general practice, which we can deliver for you if you like, which talks about the ongoing savings that having these chronic diseases managed in primary care, and particularly in primary care teams, and having access to vital primary care as well as general practice really saves the forward costs onto the hospital system. So we've got a whole range of initiatives within that shows that billions of dollars of savings that occur over the forward estimates for investment in primary care. And we know that other countries have done it successfully and turned around some of that ongoing cost into chronic disease. But we need to act now, that's for sure.
If we can move to training, I know there are a lot of senators who have questions for you, so I won't take up too much time. But when it comes to training, what are we getting right and what are we getting wrong? That's a very broad question, but the doctors that I've met sort of talk about the fact that they did part of their training or most of their training in a rural practice. They were attracted by the different type of work that is involved, and that's why they decided to stay. But the stats show that that's not happening enough. We don't have enough doctors who are choosing to stay or even to study in rural areas. What are the sort of key things on the recommendations that you've made that you want us to concentrate when it comes to training GPs to become rural and regional practitioners?
Nita, what a great question. And the answer is one that you don't often hear in the Senate, but that is one of community-based relationships. And we know that the supervision relationship between a supervisor and a registrar is one of the key determinants of how well that registrar learns, how much they enjoy their experience, and how likely they are to stay. Having repeated exposure to rural communities is a dose-dependent relationship. There was a recent article from the Mabel data that demonstrated that. We know that this primary relationship of learning really helps to engender that passion for rural practice. We also know that gaining advanced skills, we know that rural origin, rural clinical schools, these sorts of things are all going to contribute. What we would like to deliver is a nationally consistent program which overcomes some of the limitations of having 9 different jurisdictions. And that means that there are people who can actually transfer from, from Western Australia, sorry, Peter, over to Queensland or back again, because they've got flexibility. And what they are looking for is flexibility, a really good training experience, and a broad scope, as you say, that's intellectually challenging. But parallel to this, and it can't be neglected, is that only 15.2% of graduates are considering a career in general practice, and that's related primarily to the remuneration and the status that has been sadly degraded. Even though I believe general practice is the most intellectually demanding, we are the general diagnosticians of the health system. So there's a whole reorientation needed within general practice that relates to training, but also relates to funding and the attractiveness of the career. These are bright young graduates, and they're going to be able to make choices. So we want them to make choices that are headed in generalism, which has been throughout all of the submissions I've read, one of the prime concerns, and we want them to make that decision in a way that enables the rural and remote communities to have access to high quality medical care. Now, if they have a bad training experience, that may well colour them for the rest of their lives about rural and remote practice. So Michael Clements has demonstrated really ably on his practice in Magnetic Island, just exactly how he can turn around an area that had a workforce shortage. And I really like Michael to make that.
I know, please do, Michael, but just before you do, it sounds like also one of the issues is that we're getting a lot more women who want to study medical practice, but it's not an attractive workplace, I guess, for someone who's planning on maternity leave or managing a family. Maybe Michael might be able to comment on that as well.
I would really like to comment.
Of course.
Being an ardent previous chair of the Women in General Practice, look, absolutely, and the entitlements is a key issue, and I know that's a key issue of the young graduates. Now, back in the 2000s, a young registrar could leave the hospital system, go into general practice and experience a pay rise, and now that's not the case. So now they're talking about entitlements, which is, of course, parental leave is a big consideration, and those entitlements are needed to transfer across into general practice. And we're calling for an independent body who can hold those entitlements and travel with that registrar as they go through their training, so they don't make a decision based purely on the support they can receive. I don't believe there's enough support for working mothers, but that's another story and another Senate.
So thank you. I might jump in. So for Magnetic Island, we turned it from 0 doctors working on the island to 5 now. And that was through a commitment to training and general practice training and supervision. I've got a female registrar joining me next year. Her hospital salary as a 3rd-year doctor is about $150,000, given that she does overtime and weekends. When her first paycheck with us will be based on $90,000 a year, because that's what the minimum terms and conditions are. And that seeing only 2 or 3 patients an hour as a GP using GP rebates, that's all she'll get. So already she's facing a massive cut in pay. Also, she loses any of the maternity or paternity or long service leave entitlements by coming and joining us. So it's actually a big financial hit for this doctor to move out of the hospital into community general practice. But the other thing is we know that as a college, more of our trainees are female, which is great. They do great work, and the evidence is that they do carry a large burden of the longer consults, which also means they earn less. Medicare doesn't reward long consultations. But we also know that the average age of our GP registrars is not in the early 20s like it used to be. It's actually in the early 30s. So the people that are coming to us in general practice training now are more mature, largely because of graduate medical programs and people coming to medicine later in life. And so they're coming to us right at an age where they're thinking about family. They are actively thinking about and planning children, and a career in community general practice without access to those entitlements is a massive barrier. And I know AMA have got some thoughts there too.
So look, I'd like to say that I as SA president, I visited Port Lincoln and spoke to some of the GP registrars there. And what I was struck at is, I'm not sure we've been Port Lincoln, absolutely beautiful part of the world, and they all the registrars loved working there. But particularly the female registrars there said to me, but I love working here, but it's not worth it to me because I'll actually earn more money in the city. I won't have to deal with all the stress of all the on-call that they put me through with the hospital, and also all the other things that I've got concerns about in terms of actually schooling for my children and things like that are going to be far too problematic. And so in the end, they moved back, even though they loved where they were. The AMA's position, and I would ask Peter to just speak, is the AMA positions. We do need to work from both ends. We do need to work out what towns. We need to do much more workforce planning, which we've really unfortunately failed to do. The loss of Health Workforce Australia early on, we're sort of catching up now in health workforce planning. What we need to work out is what towns and rural areas actually need, work backwards. Also then link it to start from medical school, make sure at least a third of the graduates come from rural areas, follow them through, support them through, follow them through in terms of lining up what skills they're needed through, and give them a leg up through getting the right training to go back to those communities, keep them linked to those communities right through their training, so that they don't disconnect and then end up in another training program and go to Metro, and then just make sure that these disadvantages that they got to face, such as the things I've just said about, relative income disadvantage, lack of reduced support because they feel as though they're for their children and their family, and also relative increased stress and fatigue and concerns about being on call, all for less, have to be overcome, I think, and to tip the balance to keep them in rural areas. Peter?
Thank you. And to that, I would add that some of the successes we had in Western Australia in the past involved mentoring, identifying students who showed interest and mentoring them by someone who's got oversight through their late student years into their junior doctor years and then through GP training. And that was quite successful. I think it's important that we also look at the the first couple of years of hospital training are often done in metropolitan hospitals with very little opportunity to go and experience working in a rural hospital. While that's improving, there's a long way to go, I think, in that. And then I think that is an important transition from student to GP, is those first couple of years. So I think those are important issues. Yes, thank you.
I'd like to just say too that, going back to the gender lens, if I can, sorry, Nita, because it's a really important point that you raised, that it's not just about parental leave, it's also about a rural doctor being after hours, on call, all of those sorts of things. So childcare and spousal support is really critical. So this is, I do think a whole gender lens needs to be put upon this in terms of what we mean by work for, and how that translates into a family unit as well. Because, the traditional rural doctor, I always maintained, with no disrespect to my colleagues here, was a two-person job with a full-time male GP often. I'm talking about 50 years ago, guys, so you're off the hook. With a very, very devoted partner at home managing everything else. Now, that old model of work has gone, and we haven't really adapted into those areas. And I know that childcare, in particular in Western Australia, Peter, Janice Bell talks about this a lot, that childcare is one of the biggest needs of the registrars in that area because it gives them flexibility, but also considerations for on-call and after-hours commitments.
Thanks, and I'll hand over to my colleagues because I know they have questions. But before I do, Dr. Clements, congratulations on what you've been managed to achieve on Magnetic Island. It really was, having no GP at all there to building it up to what you have now. It's an incredible achievement. Thanks.
Thank you.
Thanks, Senator Green, and thanks to you all. Okay, I've got, I'm going to go to Senator Hughes, and then we've got Senator Patrick and Senator O'Neill, who've also got questions. So if we can try and keep it as short and sharp, we've got just over 20 minutes left. So I'll go to Senator Hughes.
Thank you, Chair. Can you just confirm for me, Dr. Price, how long it takes for someone to become qualified as a GP?
Generally it's 3 years full time once they enter the program, but there might be a few years of hospital training before that.
So if they do it no one's leaving university after 3 years though and going into a general practice, I'm guessing.
No, they usually spend 2 or 3 years or more in hospital. I would say average is probably 3 to 3 years or so to gain other experiences, particularly if they're going to go out, if they're contemplating a rural career, they may get advanced skills in obstetrics or anaesthetics before they leave, and then they go out into rural areas, and look, 3 years generally on the programs. For rural training, it may be another extra year on top for rural generalist training, but also for an FRACGP, of which many rural doctors are a FRACGP, they may bolt on other additional training. So it's 3 to 4.
So we're generally talking a minimum 6 to 7 year training program.
Yes. Yes.
Yeah, okay. And keeping in mind, similar to Senator Green, I went through 3 pregnancies in rural and regional areas, one in Orange, which is a particularly large specialist area, and they've done very well building a specialist network around Orange. But my next 2 were in Moree. So unlike Cairns with an international airport and a fabulous reef, Moree, I would imagine, is a slightly more challenging environment to attract people to. As much as I love broadacre farming, I'm not quite sure everybody else would find the joys in it, of the remoteness. But, I mean, I've had a look at some of the jobs that are open, and I've listened to what you said with regard to remuneration. And I've just had a look today on some of the websites of jobs that are open as rural generalists. And pretty much the lowest paying one was $2,000 per day. Would that be considered insufficient pay? And most of them were $2,300 to $2,500 per day in a rural and regional area.
That's a locum rate. That's not a salaried rate. So if you committed to that region.
Yeah. And they may well, it depends on whether they're paid in the hospital or paid through community general practice. So because there's a difference in which area you work in. Michael, you might want to elaborate on what that means.
So that 2,000, what we're seeing in South Australia is 2,600 a day. What we've seen in New South Wales is up to $3,200 a day. In general practice, in community general practice, we can only offer about $1,500 a day before we start losing money. So we just can't compete. So those are the locum rates, and people are now being drawn into those locum roles. Those roles, those pays work. So $2,600 a day or per 12-hour shift has worked in rural South Australia, but you're getting mercenaries that come and go from that town with no continuity. They don't have any ownership to the community, to the practice. They stop making discharge summaries. They kick them out of the ED as soon as they can because it's no longer their problem. So we have seen, and Port Pirie is a good example, and there's been some media reports and complaints about the service received at Port Pirie Hospital, which was reliant on locums because the locums just didn't, well, the reports are that they just didn't care. That's just the report. I won't say that that's true.
About that commitment to community, isn't it, Michael? Yep.
And I'll just add that just an experience, say, in Port Lincoln was very interesting because, they did get locums in Port Lincoln for the hospitals because the GPs, unfortunately, because of the amount of pressure and fatigue, but also a dispute with working with the local hospital. They had locums there, but then the hospital needed the local GPs then to still look after paediatrics because the locums couldn't do that, which just defeats the whole purpose of what you're trying to do there. And it just it's really not what you're trying to do. So this is not a model which builds continuity, loyalty, the foundation on which, and I think this is really important for a lot of towns, that having the doctor there is as important, or more important, having the bank or the post office there, because the healthcare is such a critical component of people wanting to stay in that town. So it's not just the healthcare, but it's everything else, as you probably understand.
Yeah, so, I mean, I guess this is one of the things that kind of not confuses me. I mean, I understand, but it's not just doctors. When you live in a small rural and regional community, absolutely every person that's working in that town, whether you're a farmer, a GP, a pharmacist, run a retail store, a teacher, every single one of those people is facing the same sorts of issues with challenges around childcare, challenges around education for their children, all those sorts of things that families look to make living in a particular area attractive. So, I mean, we're not suggesting in any way GPs, and I heard you talking about more support for them and their families and their partners. Are you suggesting there should be more support for someone who's a GP than anybody else living in that community? Because obviously it would be something that those communities need to focus on, towns need to focus on making themselves potentially more attractive people to live in long term. It's not just GPs affected by those shortages and challenges.
You're absolutely right, Senator Hughes. It is, back in the 1950s, there was Paris and the French desert, a description of how they need to do regionalised France. And I think this is what I've been talking about, that there needs to be a whole lot of regional and rural infrastructure development that, obviously supports general practitioners, but supports the entire town, because that also, it's a symbiotic relationship. If you've got a thriving town, you've got a thriving general practice, it all supports each other. So totally take on point what you're saying there.
Yeah, and my local GP when I lived in Moree, who also did a lot of rural generalist obstetrics, etc., his wife started our ballet school, so our little girls could do ballet. So they were definitely a part of our community and made it so. But they obviously, like lots of people where I lived, have to send their children away to boarding school. So it's not just the GPs.
What's happening in
community? I just want to move away from that though. With regards to the Rural Junior Doctor Training Innovation Fund, we have seen more junior doctors getting experience of rural general practice, and we've seen over 50 towns and 80 sites receive around over 800 rotations since 2018, and that's been increased to another 60 interns and postgrad doctors taking training in country practices. How important is it that those programs are working with, for example, the University of Newcastle, I know undertakes lots of rural generalist programs out in areas as far as Burke, Cobar, etc., because it looks after those areas.
Yeah, thank you. I might jump in there if that's all right, Karen. Listen, it's a fantastic program, and we're glad to see it and glad to see the expansion. We'd love that if every hospital was able to offer it, but the crucial key part is that it has to be a positive experience. If we don't make sure that the practices that they go to are well supported, RACGP led, with good supervision, good clinical education and teaching, it actually has been negative. So we have had people come back to us who have been in a churn and burn clinic, where perhaps they're trying to fit as many patients through the door as possible, and their experience under RIG-GTF has been a negative one. So it's important that we as a college work with those placements, and that we make sure that the places that they're going to are well funded and supported, so that it turns into a positive experience.
That's exactly
right. I mean, we've obviously heard in previous inquiries some stuff around bullying within hospitals in the medical centre, students being burnt out. That's really a cultural thing more than numbers, isn't it? I mean, if kids are coming back with terrible experiences and not wanting to go back, that's sort of a broader medical cultural issue, isn't it?
That's right. Well, our program is enabled to try and manage some of that cultural change. And we know that it's not just geography, because we know, as Michael said, between Julia Creek and Cloncurry, there's a big difference in attractiveness. And, for instance, Goondiwindi, which has no problem attracting people, versus Tenterfield, which up until recently had some troubles. So it is often some, local issues that may be related to culture and personality, and they need to be, devised by and sorted out by local communities and people who can oversee that. So we've got some remediation in place for both supervisors and for registrars should that turn into a negative experience. We do not want to send young doctors or medical students into a negative training experience. That is a disaster for all of us.
I think also...
Sorry.
Go ahead, Pep.
Can I just add there that I totally agree that it's important that the young doctors get a positive experience. One of the challenges that and it really is a dilemma, is that those parts of Australia that are most have the worst shortage of GPs are the ones where adequate supervision is difficult to provide. Many of those towns, the GPs who are there are so busy that it's very difficult to devote the time that the young doctors need for supervision. And in many cases, those towns have international graduates who themselves are under supervision and are not eligible to take on the supervisory role. So there is a mismatch between the need for the junior doctors and the ability to supervise them adequately and give them a good experience. So that's the challenge that we all need to work on, I think.
Just to put in perspective, the Innovation Fund provide, I think, about 800 rotations, as you said, but I mean, Australia graduates about 4,000 medical students per year. So to give you some perspective of how many we're missing out on. And I think the loss of the PGBBP at the 2014 really left general practice particularly is the only specialty unable to offer junior medical officers a really structured pre-vocational training experience before they make their career choice. So I think we do need to consider the relatively where we've been and where we are at the moment and where that fits overall, even though the 100 is obviously a positive thing.
Yeah.
Last question, Senator Hughes. We need to move on.
Okay. So I have one question which you might want to take on notice about all medical schools looking at doing rural rotations for their students so that they're exposing all of their students to rural environments, because we do know as people go out there young, quite often they meet their partner, et cetera, and decide to stay. But really, I mean, there's one thing talking about government responsibility, but isn't it really a broad responsibility of the RACGP to ensure that your fellows are investing in the next generation of doctors, that, there's some responsibility to make sure all of the fellows as a part of the RACGP are providing that positive experience. And so I'm interested to hear what sort of work that you're doing in that space to ensure that that is improving. Because I would have thought, speaking to my old rural GP and asking why he stayed, he was a Sydney boy, why he stayed in Moree, because rural generalist practice to him was more interesting than being a GP in a city, because he actually got to do other stuff. He was a GP, but he also got to deliver babies. He also got to do other things that if he was a GP in Wahroonga, he wouldn't have got experience of.
I think it depends where
But
you
shouldn't
practice.
the fellows be imparting that?
So I think you're talking about some of the burnout issues, and I have to say that we've that's a problem in medical practice generally, but also the remediation that we've built in. Our college hasn't had training for over this last little bit, so we are going to enable a pastoral care program to manage that particular issue of lateral violence within medical culture. James Brown, who's designed the educational curriculum, has focused very much on the relationship, which I talked about. We don't hear about it a lot, between supervisor and registrar. And my PhD, not yet finished, is also on the peer-related connections between doctors and how important that is to enable high-quality practice. So the college, by having training back with it, is going to enable that pastoral care development and mentorship that is so critical to develop not just the clinical education, but also the vocational education, the role modelling and the medical culture leadership, which is so necessary to enable our profession to deliver high quality care. If we have a negative experience in one of our students, then we've got a services model which is going to go out and investigate that and try and work out what's actually going on. So this is relationship work, and it's very, very important work. And I would dare say not just in medical culture, but in probably across Australia, we're seeing too much of the abuse of power and bullying and so forth in workplaces, which is detrimental to everybody.
Okay, thank you.
Thanks, Senator Hughes. Senator Patrick.
Yes, thank you very much. I'll try and keep this brief. I might go to Dr. Moy, seeing he's a fellow South Australian, and my issue sort of whilst general will focus on that. First of all, I have an engineering background, but I think it's the same in the medical world. In order to be able to fix a problem, you need to know what the problem is. And I have had a year of trying to get out of health officials who are great at obfuscation, and I'll take that up with them this afternoon, just trying to understand where the holes are. And in some respects, maybe this is a suggestion to your organisations. All I want is a map of South Australia that shows where there are doctors missing and how many there are missing. And that is just an impossible task to get out of health officials. But I think it's probably something that you guys could do. And maybe Dr. Moy, I'm perhaps asking a bit to take that on notice to be able to produce that. But that sort of picture, just a map with the number of doctors missing in each location, is a powerful political tool, which is why health departments don't want to give that to us. Do you want to comment on that, Dr. Moy?
Yeah, look, can I just say, when I visited the West Coast, which is where there is a crisis there at the moment, I was actually quite shocked about how few doctors there were there. And therefore, by that by that situation, the relative lack of care, but also funding that goes into health in those areas and how scared they were. But I think also the fact that when they I think it was something like 100 doctors in the entire west coast of South Australia was equal to the amount in Gawler, one of the towns in the outer metro towns in Adelaide, which just gave you some idea of how scary it was and how lacking they were in the number of doctors in that area. Yeah, I absolutely agree. And that then goes to the point of whether there is equality of funding there, because if you don't have the doctor there, then the services aren't being provided to that area, and therefore the funding to that area is less as well, because it's obviously follows the doctor to some degree. Look, South Australia is a particularly bad situation at the moment. There are a lot of things, I think Michael and I did speak yesterday and say it's an example of how not to do it, unfortunately. There is not the sort of level of support out there in there, and unfortunately, particularly the relationship between the doctors and the local health districts is pretty much toxic, unfortunately.
Yeah, well, I'll come to that with Dr. Lewis, but who I spoke to yesterday. But you know, is there a map from your side? Dr. Price looks like she's wants to say something.
I do. Look, that your big data map is something that we're looking at within the Heads Up tool and so forth to develop a map. But as you would understand, being an engineer, my son's an engineer, this is a complex system. So the data needs to be real time. So we're actually working ahead of schedule on our IT infrastructure to intersect with the workforce to develop that kind of real time data. Obviously, there's a big data map, but that has a lag on it. So some of that lag is what we can fill in with local community context. So it's the big data down, complexity theory, big data down, which you would understand as an engineer, and then we need the small data up to actually real time get some real understanding of what's going on. So has someone just got sick? Has someone just gone on parental leave? You know, this changes the whole data map instantly. So you may, even if you have a big data map, it may be wrong because you don't have the local context. We've got to have both sorts of data.
Mm-hmm. But in some respects, this is the problem I get when I get to the Department of Health. They say, "Oh, it's all too complex." You know what? I can tell you how powerful a simple map would be with locations that said, this is how many doctors are missing in that location, or in fact, this is how many doctors are in that location. That doesn't have to be an extensive IT network. You know, we can draw zero at Woodner. We can draw, I think it's maybe half or a quarter at Kimber. That's the sort of thing we need, and that is politically powerful. That is what we can present and shame our health officials and shame our ministers, but I just can't seem to get access to that information. So I'm wondering, just let's keep it simple. Let's keep it South Australian to start with, because that's a simple jurisdiction. Is it possible to get on notice a map of South Australia with the towns and the number of and you can qualify just saying this is the number of GPs as opposed to nurses or whatever. We can have another map for that, but
I'm sure we could work something out. We'll take it on notice, Senator, and try and get back to you regarding.
It would be really powerful. The second thing, Dr. Moy, I spoke to Dr. Lewis, who's left. He's announced he's leaving Woodner. I've had a bit of a relationship with him over time, trying to get NBN into Woodner, and he tells me, and I don't think I'm saying anything that's not public, is that his problem is his biggest frustration. He's got people in Adelaide who just haven't practiced remotely and are making decisions without consultation, just not getting the right amount of support. Dr. Moy, is that, and Dr. Price, is that something that needs to be addressed? Because this is about not trying to put doctors into regions. It's a worse situation where we've got the doctors and they're leaving.
This is, I can hear Scott's words, and they're not repeatable here, about what he thinks about some of the tertiary centres. And this is about being able to transfer critically ill patients and how There's often a very tricky intersection with the hospital, and that is, again, a cultural attitude towards rural doctors. And I'm sure that Michael has had that experience also in rural and remote regions. It's not isolated to Scott Lewis, who I know well.
Sorry, Dr.
So,
Wise.
understand that Scott, I mean, we worked a lot with Scott last year, and it's amazing that he's stood up to this for so long. Unfortunately, we've got this terrible situation in South Australia where there's been a lack of respect between the local health services and the local GPs, and a lack of real recognition of what they do, that they have to provide. They set up a private practice there, trying to provide services to the community at a private level, but the hospital services are required for emergencies and obviously care for there, but they haven't shown the respect that's required, both in terms of remuneration and understanding. For example, when Scott had to go across the road, call to an emergency, he had to leave all his patients in his waiting room. He'd have to wake up in the middle of the night and go see these patients. That he was fatigued, that he was leaving all these a waiting room full of patients, and not and the state health system, in terms of firstly remuneration, weren't actually covering any of that opportunity cost first up, and also the fact that his patients weren't getting care. Their demands on him were terrible. They didn't cater for simple things like making sure that he had access to a computer, for example, and priority to a computer, that he was supported properly with other staff. And that when the negotiations, and there have been negotiations because I was initially part of that, between AMA South Australia, the Rural Doctors Association South Australia, who have been working together trying to find a solution to get a better relationship between the local doctors and the state. And the local health areas. Essentially, the proposal that was put back showed absolutely no respect for their needs at all. And so there really has been, unfortunately, a long-standing terrible relationship between the local doctors and the local health areas, which has meant that really those doctors have got more and more tired, frustrated and angry, and that's what you see in Scott. And that's why it's come to a head. And I think, unfortunately, it's got to the point where, and you mentioned about the locums earlier, this discussion here, unfortunately, that's what's happened. So essentially, because it's been a standoff to a great degree, a terrible standoff, they're reverting to locums, which is just a terrible way to provide care, because there is that not that long-term sustainability and also loyalty to the local population, and is actually a much more expensive model as well.
So that most health in rural practice, isn't it? Because it happens throughout the medical system, where I've got a daughter working as a physician in Melbourne Metropolitan, and that kind of experience is also trying to transfer patients, because the system itself is under pressure, and that's what's happening, and it's most felt in the rural and remote areas.
Yeah, okay. So I'll just make a quick comment, because I know we've got to move on in terms of time. One of the other things that Scott mentioned to me is that the health department will pay a locum to fly into an area, lots of money on a daily rate, but won't direct that money towards people who are already there. Look, I'll just finish by saying, if you get me the map of South Australia that shows the lack of doctors, something simple that the people can digest, I reckon the advertiser will run it, and that will put pressure on South Australian officials. Don't worry about the complexity. Keep it simple.
Thanks, Senator Patrick. Look, I'll now go to Senator O'Neill just for a very quick couple of minutes before we wrap.
Thank you very much, Chair. Can you hear me?
Yes, we can. Thank you.
Thank you. So can I put in a request for the same map for New South Wales, because there's incredible denial there as well. Indeed, in the health submission, the health department submission, they make the point that Australia's primary care GP workforce grew from 24,737 FTE doctors in 2014 to 29,419 in 2020. They cite annual growth of 2.9 compared to an increase in population of 1.5% annually. And I guess we're supposed to swallow that and go, it's all good. But your evidence provides the reality of the crisis that is now occurring right across this country, and particularly exacerbated in regional and rural contexts. So I have two questions. Could you give me a sense of the PGPPP closure under the Abbott government in 2014, its impact on the training ground for GPs to meet Australia's need? And secondly, GPs have spoken to me for many years about the impact of the Medicare freeze on the sustainability of their business, which appears to be coming home to roost right now. So I have many more questions, but can I just ask about those things? And if you need to take it on notice, can I refer to hospitals in settings like Deniliquin in the seat of Farrer, Dubbo, and like places like Condobolin and Coonabarabran in New South Wales, the intersectionality of the GPs and the hospital staffing that you've spoken to, it seems extraordinarily defunct in New South Wales as well. So I'll leave my opening, consider more questions, and I seek your response.
Well, firstly, with the PGPP, when it was ditched, you would remember that general practice positions were oversubscribed. So since then, there's been a degradation, and we're trying to bring that back through having that end-to-end training. So beginning in medical school, we've talked about, so we definitely want that back on the agenda. And just on notice, we are really happy to come back and present in more detail our PLT model to you. So should you wish to have that presented, we're very happy to do that. And the GP's Medicare freeze, well, yes, that's been a persistent problem over many decades, and you are quite right, it is coming home to roost now because the infrastructure needed to even build the building, to even supply the allied health staff that we need. What's happening is we have got increased numbers of GPs, but we've got increased complexity of problem. When I started in general practice, could see 6 an hour, could do all the procedures, including X-rays and so forth, in my urban practice, out of seeing refugees and so forth in a low socioeconomic area. But now, you're pushing it, particularly the female doctor, to see 3 or 4 an hour because of the complexity of the presentations, the ageing population. And so our healthcare needs have changed over time, and that's contributed to what you're seeing now.
My short answer to it in terms of the loss of the PGPP is that it's left general practice the only major medical specialty unable to offer junior medical officers without a structured pre-vocational training experience. And that's critical because what it does is, bottom line, is it reduces the legitimacy of general practice as a legitimate way to go. And then what you've got is all the other specialties sucking up a lot of the graduates at that point. And then we're building a very expensive health system at the moment by people being, partly because of their futures being potentially better remunerated, but also not actually starting off at that point where they're going to end up as very highly qualified other specialists, which is going to be a much more expensive but less flexible and less generalist health system.
I think older and graduating with HECS debts too.
Thanks, Senator O'Neill. Look, if we can keep you for another 5 minutes, Senator Askew's just got some quick questions, and so we'll wrap after that. Senator Askew.
Thank you very much, Chair, and I'm hoping you can hear me. Thank you. Just first of all, I just want, during your opening statement, Dr. Price, you mentioned the fact that we're moving to college-led training. And I've just got a couple of questions around that, in particular, obviously being Tasmanian-based, have concerns within Tasmania with GPTT and the transitioning across, and they've had funding extended for the next 12 months. Do you believe, first of all, I suppose it's 2 parts, do you believe that they're ready to be transitioned across so that we'll be able to, the colleges will be ready to run the training from, I think it's 2023 it's due to start? And also, will you be guaranteeing that you retain the same sort of numbers of trainees that will be coming through the process? Because at the moment, GPTT are retaining about 75% of their trainees within the system within Tasmania. So I just wanted to make sure that you're ready to go and that we'll be able to retain those sorts of numbers. And I've got 2 parts. The other part of my question, because I only have 1 question, is regarding telehealth and how that's impacted and retention of the doctors within the rural and regional areas. Obviously, huge investment into telehealth over the past couple of years, and just wondering how that's impacted nationally. So they're my 2 parts.
So firstly, we are ready to go with our partners, KPMG. We've got 5,000 lines. As I said, on notice, we can come back and present that to you to give you some clarity on the timelines and our confidence in being able to deliver on those. And as regards and retention, absolutely trying to preserve the local community relationships and in fact enable them to better deliver for the communities, particularly in the northwest of Tasmania and so forth. So we're very aware of those issues. Telehealth is an adjunct to usual care. It has benefits, it also has threats, and it's a tool, so it all depends on how you use it. And we're trying to make sure it enables good quality, high quality care with the usual practitioner, and that's what we're really looking forward to embed. Michael, you might want to talk about telehealth in more.
Only to say that we've seen some novel models grow up where you've got a FIFO face-to-face model with in-between telehealth that's worked really well. That's a model that I do when I visit Corumba, face-to-face every 2 weeks in between telehealth, which has been enabled by the Medicare rebates. That's been a key enabler for the growth in health services in that town. So it's got to stay. And in particular, rural does need different rules and different funding. Most of my rural patients don't have access to video conferencing. They don't have satellites on their roofs when they're in the rural areas. So we do need to amend the telehealth Medicare rebates right now to respect rural and not assume that everybody's got NBN on their mobile phone.
Can I just add one more comment on telehealth? It certainly has been a great asset in many ways, and it has taken some of the pressure off rural GPs for after-hours care. The downside also has been, certainly in WA, we have an emergency telehealth system which has actually pushed the GPs out of a rural hospital in favour of telehealth support from the city. So as Karen Price says, there are positives, but there are also significant risks.
So my follow-up question to that then would relate to after-hours assistance. Obviously, when you're working in rural and regional areas, that 24/7 requirement to be available. In Tasmania, we run something called GP Assist, and I'm just wondering how that would fit into your view of going forward with the new trainings and so on, because GP Assist is a localised product which actually provides feedback, and they can actually ring the doctor locally and get them to go and see somebody after hours if necessary, but they're actually being managed by nurses on the end of the call. I know we have a national program to Health Direct, but I'm just wondering how GP Assist is viewed in your eyes.
So I was in Tasmania earlier this year and talking to the GPs. GP Assist sounds fantastic. I'd love it up here in North Queensland. The strength of GP Assist are the relationships with the GPs. The GPs trust them. The GPs, rely on them. It's enabled them to not have to get phone calls in the middle of the night for aged care facilities, but they trust that they're going to get contacted and have the follow-up, and that's the key. So I think GP Assist is a good model.
The only thing I'd say about telehealth is, and that's with any new service, you actually need to work in conjunction with any local rural health service and not undermine it. And that's whether that's telehealth or any other service, whether you build up anything put in there needs to be in conjunction with the local existing health service. Because what telehealth can do potentially is, if, for example, you have a general practice there which is actually is viable and actually providing face-to-face care as well as some telehealth. If telehealth is then provided from the city and actually, I'll put it in simple terms, does some of the easy work, what happens then, it may actually affect the viability of that practice there. And then you've actually got a problem. So when considering all these things, you have to get the right balance and understand exactly as Karen has said, that telehealth is a tool. It doesn't replace face-to-face care, which is required. And you've got to keep local face-to-face care, if it's there, is supported to the greatest degree, because in the end, you cannot, some things you just cannot replace by telehealth.
So I just say there that continuity of care has to be enabled in general practice, and we don't want white anting of a rural doctor who's built up a community over time by someone who wants to come in and just cream off what is considered to be easy, but in fact are opportunistic abilities for a local GP who knows their patient space well, to actually often intervene opportunistically in things that may seem simple, but in fact are quite complex. So I totally support that continuity of care model through telehealth.
So the GP Assist, just to clarify, is an after-hours service. So it actually supports the rural doctors after hours. So they're not on that 24/7, but they also understand that if somebody needs urgent attention during the middle of the night, they will get the call from GP Assist, but only in that situation, which from my understanding in Tasmania has helped retain quite a few doctors over the years in the regional and rural areas. Yep. Obviously, it's a smaller model. That's the issue, to try and see how it would fit across the country.
It's a triage system that's been locally developed. So, that's the key, having those local solutions developed by the GPs on the ground who know what they need.
and they have that relationship with each of the doctors around the state. So I think that's something we could look at, and I know the chair's looking at me anxiously to say, please hand back. So thank you very much for that indulgence.
Thanks, Senator Askew. And look, thanks all of you for your very useful evidence to the committee today. And thanks so much for hanging around and being with us for, almost an extra quarter of an hour than we had you scheduled for. It's been really valuable. So thanks very much.
We'd love to talk more, of course, and present our training model to you should you wish. So please contact
Thank you.
us.
Thanks.
Thank you very much.
Okay, thank you. So look, I now am welcoming, again via video conference, of course, representatives from the Rural Doctors Association of Australia and the Australian College of Rural and Remote Medicine. I'm sure many of the things we've just been discussing in the last hour, we will continue this discussion in this next 45 minutes. So thank you for appearing before the committee today. I'm Senator Janet Rice, I'm the chair of the committee, and we've also got with us Senators Green, Askew, Hughes, Patrick and O'Neill. So lots of people interested in this very critical issue. So to begin with, can I please ask that you state your name and the capacity in which you appear for the benefit of the Hansard transcript, starting with the Rural Doctors Association.
Good morning, and it's great to be here, and thanks for having us. My name's Dr. John Hall, and I'm the immediate past president of the Rural Doctors Association.
Thanks, Dr. Hall.
Good morning, I'm Dr. Megan Bello. I'm the president of the Rural Doctors Association of Australia.
Thanks, Dr. Bello. And now the Australian College of Rural and Remote Medicine.
Good morning. My name is Dr. Sarah Chalmers. I'm the president of the College of Rural and Remote Medicine.
Good morning. My name is Associate Professor Ewan McPhee. I'm immediate past president of the Australian College of Rural and Remote Medicine and Emerald GP in Queensland.
Thanks, Dr. Chalmers and Associate Professor McPhee. So can I ask that when you're speaking, if you could do your best to speak clearly and to identify yourself each time you speak, to assist with the recording and broadcast of these proceedings, and hopefully the technology will be kind to us. So look, I now invite each of you to make a brief opening statement should you wish to do so, and then we will, all the many committee members we've got here will ask you some questions. And if I could stress, if you could keep your opening statements brief, it will give us more time to ask you questions. So the Rural Doctors Association, did you wish to make an opening statement?
Thank you, Senator Rice. So I'll be speaking on behalf of the Rural Doctors Association with our opening statement. I'm also a rural GP of 20 years experience, a GP obstetrician by trade, and I've worked for many years in rural Queensland, in rural maternity services and in private general practice, and I've had the opportunity to work in many states, including remote Western New South Wales and remote Tasmania. So I bring some broad experience, as do my colleagues. I'd like to acknowledge the traditional owners of the land on which we meet today, pay our respects to the elders past, present and emerging. I'd like to start by saying that, our reason for being, the Rural Doctors Association is here to support rural communities and their health outcomes. We're not just a doctors' industrial organisation. We have a very strong will and vision for better health outcomes for rural and remote Australia. And this is the blight on Australia's health system that exists today, is that we still have significant disparities in health outcomes. And it's not just the Indigenous divide, this is the whole of rural Australia. A third of rural Australians have poorer health outcomes. That includes shorter life expectancies, significantly higher rates of serious chronic disease and worse health outcomes from those, but also worse health outcomes from things like cancers where people can't access care. We'd like to highlight the fact that there is a significant underspend per capita in rural and remote health today. The National Rural Health Alliance published in its pre-election literature before the last election a $4.1 billion underspend per capita. And that's real money. And that's because rural Australians can't swipe their Medicare card. They can't see a healthcare professional to access their health insurance, their national health insurance. And that's a travesty. And this is about access to care. And again, it's not just about doctors, it's about access to doctors, nurses, allied health professionals as well, the whole multidisciplinary team. We have significant access to care, and we have good data that shows that this maldistribution exists. Today in Australia, we have enough doctors, we have enough healthcare workers. They're seriously maldistributed and they're concentrated on the eastern seaboard and in our major cities. We have data that we could give you sort of more sort of grainy data, and this is in our submission as well. But today there's about 440 doctors per 100,000 of the population in metro and regional. When you get out to Triple M4 and beyond, there's 200. So there's nearly half the number of doctors per capita in rural and remote Australia today than we have in metro. And that statistic is real, and we can give you more of a breakdown on that. There's also a maldistribution of skill, and this is why we focus so much on training, and we see the existence of the College of Rural and Remote Medicine, who train towards a rural specialty, which includes procedural hospital practice, emergency and critical care, which are essential services in these communities. That's why we focus so much on training, because not only is there a maldistribution of doctors, there's a maldistribution of the appropriate doctors, the doctors with the right skills in the right place at the right time. And I'd like to back that up by saying that when we have appropriately trained doctors in rural and remote healthcare, particularly our rural hospital system, we provide exquisitely safe care. I'm going to read out some statistics about the safety of rural hospitals and rural services when done properly. We have a study from Queensland that goes from the period of 1991 to 2009, nearly 20 years of data that shows that in functional rural maternity units, this is babies being delivered, caesarean sections being done, services being provided by GP obstetricians and GP anaesthetists without any specialty services on site, provided their rural communities with a perinatal mortality rate of 8.5 in 1,000. The national average at that point in time was 10.5 in 1,000. So that's a statistic that shows you that healthcare can be delivered very safely, and we have longitudinal data to back that up. I think one of the unfortunate outcomes of the media and some of the circumstances, particularly in New South Wales, that highlight the issues in rural health is any implication that rural healthcare is less safe. It's less safe when we don't have the staff on the ground, but when we have functional services, they're very, very safe, if not safer than many of our metro hospital counterparts. What we need going forward to fix this is joined up systems from state and federal, so that we can actually get these doctors, these rural generalist doctors with skills in primary care and general practice, but also additional skills to support their hospital services and maintain that range of service in these communities, ensuring that services like maternity care can be delivered as close to home as possible. And to get there, we need this joined up training, and we need government investment that is intended for rural health to go to rural health. So one of the things the RDAA have been working on closely with the Health Minister over the last 12 months is a workforce plan. And we were tasked to look at what was being spent and look in a nutshell, in a quick summary, we found that nearly half of the money that's being intended to be spent in rural health is being spent in regional areas and in metro areas. So what we need, we don't necessarily need additional money. We need to make sure that the money is going to the right place as well to support the healthcare teams in those areas, but also importantly to make sure that we have strong training pathways and pipelines. And we see the College of Rural and Remote Medicine to be the college for rural generalist training, because it has a curriculum that trains doctors into that hospital space. I think it's really important that we do not conflate issues around access to care and health outcomes with regional. It's a real problem in this industry and in this conversation that many of the fringe issues in our regional centres are seen as rural, and there is a unique and discrete problem in rural when you get beyond the regions into small rural communities and rural communities that have their own hospitals to very different context. And that's something that we've been able to put to government, and we've been able to get recognition in the last budget for rural to be defined as Triple M 3 to 7, which is really clearly defining where rural is for funding purposes and for program purposes. I'm going to wrap it up there, but I'll just say that RDAA is agnostic of all things. We're essentially care about collaborative, solutions-based advocacy. And certainly we represent, many of the rural and remote doctors out there that have raised these concerns with us. And thank you for the opportunity to speak today.
Thanks, Dr. Hall. The Australian College of Rural and Remote Medicine, did you want to make a brief opening statement?
Thank you, and thanks for the opportunity. I'd like to start by also acknowledging the Aboriginal and Torres Strait Islander peoples as first inhabitants of our nation, and pay our respects to owners of lands across Australia, and pay respect to their elders past, present and future, and also extend respect to any Aboriginal and Torres Strait Islander people listening today. My name's Sarah Chalmers. I'm the president of ACRRM, and I am a GP and rural generalist of around about the same vintage as Dr. Hall. Some 20 years I've worked predominantly in the remote Northern Territory, so across Arnhem Land, but also in Central Australia, and I'm currently now working on a fly-in, fly-out contract to parts of Western Queensland. So ACRRM is a medical college that's dedicated to securing equity of access to high quality continuity of care for people living in regional, rural and remote areas. We welcome the inquiry and we hope that it will lead to strong, sustained positive action to rebuild access to healthcare for rural and remote Australians. You'll be well aware of the unacceptable burden of illness, injury and death experienced by rural and remote Australians. These people record greater levels of healthcare need, and yet there is an estimated national health budget underspend in these regions of around $2.1 billion every year. The disparities of the health system of Indigenous Australians and those of remote Australians are intertwined, with the general lack of services likely to be exacerbated for Aboriginal and Torres Strait Islander peoples living in these areas by the well-documented negative health impacts of colonisation and intergenerational trauma. Our college submission provides a more detailed analysis of the key contributing issues to this current state of rural health services and puts forward some recommendations to address these issues, but I would like to emphasise some key points. The first being that immediate action is required. ACRRM received an unprecedented amount of feedback from members during our consultation to inform this submission. Unfortunately, many indicated that they feel they may be forced to reconsider their future in the absence of some immediate action to address their professional, economic and workforce challenges. Our members are typically stoic and they have a strong commitment to their communities, but for too long this commitment has been taken for granted and the skills and contributions of rural doctors have not been adequately recognised. Rural doctors and their health colleagues have been significantly impacted by the COVID pandemic. COVID has unmasked the lack of resourcing, the lack of care and the lack of interest in rural and remote health systems. Rural doctors are providing all levels of COVID management, so patient education, testing, vaccination and unwell patient care. And they are still providing their quality primary care, acute care and inpatient care. And they're doing this largely in the absence of their usual locum and other relief support. The imminent decreasing of restrictions and opening of state borders has the potential to decimate an already overstretched workforce. We need more than Band-Aids. In addition to some immediate relief, there needs to be a longer-term commitment to reform, and this must be adequately funded and designed and implemented in collaboration with rural doctors and rural communities. The key components of this reform should include the National Rural Generalist Pathway, new funding models for rural and remote practice, coordination of state and national health systems, and some innovation, flexibility and respect. ACRRM is the home of rural generalist medicine. ACRRM exists to recruit, train and retain doctors, a fit for purpose and more bang for your buck rural and remote medical workforce. ACRRM trains and assesses doctors within the rural context to understand and embrace the practice of medicine in resource poor and isolated practice with an increased scope that encompasses primary and secondary care. ACRRM's Rural Generalist program should be considered a key solution to better provision of primary care, with nearly 80% retention of fellows at 5 years and 75% at 10 years. No other training program, no other incentive program, and no other workforce initiative has achieved this. Thank you again for the opportunity to appear before the inquiry. ACRRM is very passionate about improving the health outcomes for rural and remote Australians, and we look forward to working with all stakeholders to secure these outcomes.
Thanks, Dr. Chalmers. Look, I'll hand to Senator Green.
Thanks very much, Chair. And thank you, everyone, for joining us today. We really do appreciate your evidence. And I must say, your very substantial submissions that have provided us a lot of detail. So thank you for that. I have, before I ask some questions about some of the policies that are in place at the moment and how they could be improved or changed, I just wanted to go first of all to Dr. McPhee. It's lovely to see you. I know a lot of senators on the line have met you before, and we're very appreciative of you joining us today. Could you just give us an overview of what you're experiencing in your practice right now, how that's impacting the community there in Emerald? And then I've got some questions for you about some of the policies and recommendations.
Thanks very much, Senator Green, and thank you for the opportunity to be here as part of the Akromati AA team. Look, I guess to answer the question directly, we're at a point, and to capture with an example, I met with the local Director of Medical Services on Monday to say, look, we may not be here in January if we become critically disabled by COVID and the COVID response. I have a practice that had 15 full-time equivalent. We've lost 8 of those clinicians in the last 18 months through attrition, through people wanting to get back closer to the cities as they complete their training with the Royal Australian College of General Practitioners, and we're about to lose another 3 through various means, people wanting to return closer to family and closer to home. Leading to extended periods of delay for chronic and complex disease access of up to 2 to 3 months to see me. So we are at a critical juncture. We have been the primary COVID response so far in this community. Our practice has vaccinated over 11,500 people, yet Central Highlands still only has 50% double vax rate. So we still have an enormous amount of work to do. We've run the GP respiratory clinic and seen an inordinate number of people with febrile illnesses. This has taken us away from our ability to deliver usual care. The opening of the borders will lead to critical stresses on our practice and to major implications for patients, and patients particularly with chronic and complex disease, but also patients falling through the cracks with acute illness. So I might leave my initial opening comments there about what's happening for me.
Thanks, Dr. McPhee. I really do appreciate that. Now, going to the submissions that both of your organisations have made, I note in your submission, the Rural Doctors Association of Australia, the pretty stark warning that rural health in Australia is currently in crisis. There's a range of recommendations that you've both made to the committee, but I wanted to ask you if you could elaborate on how the current policy settings can be changed or made better. There's some suggestions there that they need to be evaluated and implemented appropriately, and I'm talking particularly around the stronger rural sorry, I've forgotten the name of it now, but there's a few there in the Monash model as well. How can we make sure that these policy settings that are in place are actually implemented properly? Because I understand there's some concerns that they might not be as effective as the press release that went with them when they were announced. Dr. John Hall, I think you know what I'm talking about. Do you want to kick us off?
Yeah, look, thanks, Senator Green. Yeah, look, we saw some progress in the budget and we saw some commitment to some of these policy levers. And probably the key one for us is this recognition of rural as Triple M 3 to 7. And I'm not sure if the broader group is aware of the Triple M model, but at 1 and 2 are cities and regional, the rest is Triple M 3 to 7 is rural. And in the past, many of the government programs have included Triple M2. And as you heard in my opening statement, there are enough doctors in regional centres around Australia today for the most part. There are some pockets of disadvantage, some pockets where they're isolated. But when you look at the broad statistics, the real lack of doctors is in those areas, Triple M 3 to 7. And often that gets conflated because there's larger populations, there's more political gain in the larger populations of the region. So often big regional centres and even some of the outer metro areas get want to join the bandwagon when it comes to accessing some of the rural funding and the rural programs, and that leads to this situation where we find the majority of a lot of rural spending or rural intended money is being spent in those areas. So we thought it was a significant achievement to get the government to acknowledge Triple M 3 to 7 as what we call real rural and align programs going forward to that. We don't want disadvantage in the regions. We don't want regional doctors to be disadvantaged. We're just saying that going forward, any new programs that are new or under review, that there be that delineation that if we're setting levers to attract doctors to rural areas, to actually recognise that they're doing difficult work in austere circumstances, often in understaffed circumstances, doing more of the heavy lifting and after hours, that they need to be recognised and supported for that, but also recognised and supported for the fact that they are working in the hospital sector. So one of our other policies that we put forward, which we firmly believe in, is the Workforce Incentive Program reform, or the WIP reform, which actually underpins recognising and funding rural generalist practice through the MBS, through the Medicare funding system. As I mentioned earlier, the problem that we have is that doctors are partially funded through the MBS and partially through state-based awards if they're working in hospitals. We at the moment there is not many mechanisms whereby doctors working in primary care and general practice will get any advantage for that additional work through the MBS, and that's why we're looking at that workforce incentive program reform, which is tied to the skills that doctors have, but also the amount that they do after hours and on call. But further to that, we want to see a joined up system where we could have a single employer model where you could actually bundle up what they get from the state with this leveraged or premium package through the MBS, so that we could go to market and say, if you're going to do this hard work, this additional work, this work that requires more skills and more of it, then we can go to market with some premium packages recognising that work.
Okay. And I think, Dr. Chalmers, in your submission, you made reference to the Medicare rebate freeze as well and how that's impacted on rural practice.
Yeah, so that's a significant issue. If I can go back to your original question about how do we make policy better, because we absolutely welcome policy and incentives to assist in encouraging people to work in rural and remote areas. But I think the issue that we have is that we've got perhaps people who don't completely understand exactly what it is that we do and how we do it. The policies need to be designed by the people who actually know what happens on the ground. I'm a big believer that, if you want a solution for a rural or remote area, ask a person who lives in a rural and remote area. Ask somebody who works there what will work for them. They know their practice. They know their community. They know they will tell you how to attract somebody to come and work with them. And I think that, if we had some more input into just exactly how these policies, how the processes that are required to access incentives to make this work better, if we had more input into that. In terms of the Medicare freeze, I'm actually old enough to have started general practice when I earned more as a GP than I did in the hospital. And our hospital salaries have increased, just like everybody else in the world's salaries have increased over that time. And the Medicare rebate freeze has had a significant impact on the ability for all GPs to earn a reasonable income. And we're not talking billions of dollars. That's not what that's not what GPs are here for, and that's not what rural and remote GPs are here for. But nobody else in the world has nobody else has had their income cut. frozen for a full 10 years. The other issue that brings specifically for rural and remote health is that the business models for rural and remote general practices need to be different to those in urban areas, and so the Medicare freeze had a more significant impact on rural and remote practices.
Okay, thank you for that. And just, I know I don't have a lot of time, so just on training, which is another issue that everyone has raised, and some concerns about plans to change training models. Just looking back though, I understand the PGPPP model. Everyone's nodding their head. I've heard good things about that model, but that was overtaken by the current circumstances that we had. And also the John Flynn placement program. I've heard good things about that, but that was abolished as well. What was good about those programs, and what should we consider making recommendations about bringing back parts of those programs or things that we used to do well and might not be doing as well anymore?
If I can start answering that, I know that Megan and John and Ewan will all have comments. So PGPPP, was a great question to ask, because remember how I said ask a rural doctor how to fix it? PGPPP was designed by ACRM, and it was the idea of it was to, as you know, was to give junior doctors the opportunity to experience general practice. And in the rural and remote areas, we actually were able to give junior doctors the opportunity to experience rural generalism, because primary care services go across, general practice and hospitals. So great program. Really sad, really disappointed actually that it doesn't exist anymore. The John Flynn Scholarship program was also, I think, a really good design. I had the fortune to be one of the original John Flynn scholars, and so N equals 1. Great program. It really works. I think the John Flynn program existed before the rural clinical schools, and now the universities have other ways to encourage students. And I mean, the John Flynn program did give people the opportunity to have a little more flexibility, I guess, where they undertook their program. There were, other rural clinical schools require you to stay within, your own region. So, I think both really great programs, but the John Flynn placement has moved from medical students to junior doctors. And so, now we've got rural clinical schools able to give medical students those opportunities, and the John Flynn moving into the junior doctor program, the junior doctor placement will, extend the opportunities that those young and aspiring rural doctors have to experience rural practice.
Sure. And Dr. Hall, you want to see that program expanded, I understand. I'm sure others will want to jump in on that too.
Yeah, absolutely. We're looking at, there's currently 100 placements funded a year. We're looking for that to be expanded up to 400. As you've heard, there's a large number of junior doctors that graduate every year, interns, and at the moment, very few of them get any experience of general practice at all. Under PGPPP, we saw doctors experiencing general practice that didn't think they wanted to do general practice or rural, doing it and then going on to train in it and stay in it. So these programs where you're giving good exposure early on certainly do have an impact, and the data, from that supports it. But I think Megan was going to comment on that as well.
Yeah, thank you, John. Senator Green, can you hear me?
Fantastic,
yep, thanks. So I had the pleasure of doing a GPPP program, and it was amazing. And it was quite sad to see that it's gone. I think it's really important that we actually get our medical students and junior doctors to have rural rotations from the beginning. And I really think that the Rural Junior Doctor Training Innovative Fund is something that we definitely need to invest in. to allow for the junior doctors to have that rural exposure, because that will also impact on our non-GP specialist colleagues as well, to get exposure and to have that understanding of rural and remote context. And even if they go back and become a paediatrician in Melbourne or a surgeon in Brisbane, that they actually have a true understanding of what it's like to work out in the bush, and to have that mutual respect, so that, you know, the rural generalist is seen as the true specialist that they are. Yeah.
Thanks. And Dr. McPhee, I know you had some views on training, and then I'll hand over to my other colleagues because they're keen to ask some questions.
Thanks very much. Look, I know I painted a dim picture or grim picture for my practice, but I just wanted to identify that I've been taking interns under the Junior Doctor Training Innovation Fund since its inception. I've been managed to introduce on a 10-week rotation young doctors to a fantastic career, and I've actually seen transition of a number of those clinicians to the Rural Generalist Training Program with Queensland Health. So I think that as a mechanism, that is an important mechanism to support and to grow. There are other policy levers that you can look at to further enable visibility of general practice. That includes incorporating general practice as a professional and an academic discipline within our rural clinical schools very clearly, and within our health services. It also talks about, with the Stronger Rural Health Strategy, the More Doctors to Rural Australia program, which is just looking at locum international graduates, actually open it out to doctors in the health system. And we know there are 7,000 doctors who will never fellow in anything, who are cannon fodder for the health services, who are looking for alternative careers. Now, there are mechanisms that we can shift to make that work as well. The PGPPP program worked well where it worked well. It didn't always work well. It was co-opted at times by certain agencies, and it was an expensive program. So whatever we do, we need to do it better, and to understand that it had hairs on it. So look, I think that we can do things well, and some of these current policies can be improved very clearly to better enable it. But general practice, primary care has been academic discipline. It needs to be seen as part of the training program for a junior doctor. So embedding it within the intern program in the first 2 years of training is critically important. So comments there. And the second matter is, obviously, we haven't talked about transition to college training because there's fantastic opportunities. You've heard from our industry partners in this space about what the potentialities of that could be. So I'll leave the further comments there, except to say that the strength of the Queensland Rural Generalist Program, the strength of the Australian College of Rural Medicine Program does mean that I have, over the last 5 years, trained 21 Australian College of Rural Medicine Fellows, and 17 of them still are in this community, but they all work for the hospital, and I think there's a conversation to be had there. Thank you.
Thanks, Chair. I'll leave it there.
Thanks, Senator Green. Senator Hughes.
Thank you, Chair. And I will come back to that hospital question and that hospital point in a second, because I do think it's an important one. But really for you, Dr. Hall, I noticed on your website that you welcome this inquiry, but that really we do kind of know what the issues are already, that there, and to quote, is the good and much needed work that's already underway to address this nationwide issue. What would be some of your concerns around this inquiry that might inhibit those programs, and maybe just give us a bit of a brief overview. What are some of the good and much needed programs already underway?
Yeah, look, thank you for the opportunity. We did have some concerns about the inquiry from the get-go. We've seen inquiries come and go, investigations, and it's more sort of looking into a problem that we know exists. What you've heard from our group is we need immediate action. We don't need more inquiries. We know what the problem is. We know what the solutions are, and you've heard some of those solutions. But really, we need an acceleration of the National Rural Generalist Pathway. We've been calling for that. It was an RDAA policy platform. We basically learnt from the experience in Queensland, albeit not perfect, but Queensland launched its rural generalist program in 2006, and it saw a massive injection of highly skilled doctors into rural and remote Queensland. And what we saw through that is the reopening of 3 maternity units and the expansion of many of those hospitals to maintain their services, which without that, they would have been lost. Now, so I think that's probably the key platform, and we've put to government what the solutions are, but the progress of the National Rural Generalist Pathway has been painstakingly slow, and it's being bogged down by things like this: additional consultation, asking questions, redefining problems that we know exist. We need to move beyond redefining the problem. We've seen this in the Closing the Gap issue with our First Nations people as well, where they've made comments that are similar, that inquiry after inquiry doesn't fix the problem. We need action from government. We need people to be assertive and courageous within the department to move forward on programs, despite, how politically unpalatable they might be for your Metro colleagues and your Metro constituents. I think we've been held back by the politics of much of this. As you've heard, we need, for rural generalism to be successful, we need recognition. So in Queensland, there was legislated recognition of rural generalism as a specialty, essentially, and the remuneration matched it. These doctors are doing caesarean sections, they're doing anaesthetics, they're providing critical care, they're flying people out with serious illness. They're doing this high-level care. That's why we talk about them as specialists. But today in Australia, they're not recognised as specialists, and they're certainly not paid as specialists. We need, we don't just need that to exist. We need funding for the training, the joined-up training, the pipeline, the entry, the marketing, and the whole package. We've presented solutions to this, and what we need now is for government to work on it.
So, Dr. Hall, maybe just really quickly, for those of us that don't understand, what is the difference between the rural pathway versus just having a rural curriculum as part of GP training?
So we have been critical of the rural pathway in the past. The rural pathway is a part of Australian general practice training that unfortunately has seen a selection process whereby those doctors that perform really poorly or least well in their selection process were streamlined through the RACGP into the rural pathway. And the rural pathway is geographically constricted, so when they get into the rural pathway, they can't come back to the city. But it's created a 2-tier system where there's a feeling within the industry that if you choose rural, you're choosing substandard. And as you've heard, from me, to work across hospital and primary care, you need to be, you shouldn't be, you need higher level of standards, like some of the more competitive specialties in specialist, non-GP specialist practice are really difficult to get into because they require really high level of skills. We feel the same about rural generalist practice. To practice across a number of disciplines at high level of skills is challenging. And so at the end of the day, unfortunately, and I don't think this was intended, the rural pathway has created a system whereby essentially doctors are conscripted into rural as their only option if they can't get onto a premier metro pathway. Obviously we like the concept of having a designated rural pathway, but when it's got selection and entry points that denigrate that and give the impression that rural medicine is substandard, then it's not fit for purpose.
Yeah. Is the Australian Medical Council helping or hindering the rural generalist program?
Well, we've had a submission, a joint submission to the AMC to recognise rural generalist practice as a subspecialty of general practice. And it's being really bogged down. It's going very slowly. It's a very clear and simple question to answer. We don't know where that's going. We don't really know what the progress is, but certainly we need them to act more quickly, because it's one of the key pillars of the success of rural generalism is recognition of rural generalist practice at specialty level, really robust and strong training, and then funding and support and remuneration to back that up as an endpoint.
Yeah, I mean, look, I couldn't agree with you more with regards to the general, with GP rural specialisation, as someone who's been through obstetrics in Moree, but also had a very bad car accident with a broken back. was also treated in Moree Hospital by one of the GPs who works in the clinic in town, then called into the hospital. It is innovative what happens in rural and regional towns. And I'm not talking out of metro and large regional centres. I'm talking rural and remote areas.
Yeah.
They are very innovative in the way they staff things. Is there an issue with the state governments not providing enough doctors in their state-run hospitals that GPs within towns are then being called in to be, basically in the EDs or perform obstetrics, etc., within the hospital system? And what can states do to help boost this?
Oh, look, I've worked in Moree as well. I've done caesareans in Moree, and I know my colleagues there well. Used to work with Scott Finlay at Frome Street, so I know the context well. No,
He
look, in the
would
rural
have been my GP, and his wife was our ballet teacher.
Yes, I know them
So
well. I
I
used to
know
work
Scott
with them in
well.
Stanthorpe. Yeah, great people. And again, Moree's a really good example of a functioning, high-level, rural hospital when they've got enough staff. This is not about the states filling these hospitals with specialists who do obstetrics only. Rural generalist practice, by definition, are GPs that are trained with these additional skills, and it works the best when they are based in their general practice and then they provide VMO or visiting services to the hospital. And if we get that system right, we'll avoid this problem of doctors being employed only by the hospital or only by the general practice. And when you do that, it splits the workforce in these towns. So what the states need to do is recognise rural generalism properly. New South Wales has a very clunky and difficult funding model for paying rural doctors to do their work. It's fee for service, it's clunky, it's difficult, it's not attractive to doctors. So we need the state to reform their industrial arrangements around rural generalist practice, and it needs to be competitive with other specialties. And if they do that and they work and they come up with a collaborative model of employment, a single employer model where they can employ them across general practice and the hospital, we would see a much better situation across the nation.
Thank you. Look, just a final question. One of the things we just heard from the RACGP was around substandard and not significant supervision of junior doctors. So if junior doctor places were expanded, what can the RDAA and ACRM do to ensure that the experience is positive, that these junior doctors aren't just sitting in the corner of a consulting room watching a GP for 3 months, but that they're actually engaging and getting a full experience that encourages them to either consider it as a full career or definitely expand their time in rural medicine?
Did you want to talk to that one, Megan?
Thank you, John. Thanks, Senator Hughes. Just to go back to Moree, if I could just make one extra comment, is that John mentioned about the rural generalists in Moree and functioning at the hospital. If anything, you probably need more rural generalists to make sure that the workload is shared and everyone gets to do their obstetrics and have their regular anaesthetic lists, and that the workload is shared and the on-call is shared, and that there's adequate time to also be in private practice to provide that GP care for their patients. So I think it's about actually having more rural generalists in a hospital like that as opposed to another model. Getting to being a junior doctor and making sure that we have a good experience for them in rural and remote is definitely paramount to attracting them to either come back to that region or have a career in rural. And so I think what needs to happen is that there needs to be those designated positions for them to go rural, but also there needs to be adequate funding for supervisors to have the time to actually do the teaching, to take them on ward round, to take them in to assist to do the Caesar, to get them to help when you're doing an intubation, or, to actually get that hands-on experience. That's like, as a rural doctor, or just as a doctor, that's what you crave. That's what we love about medicine. So I think it's about making sure that the systems are robust, that there's adequate time, that there's an adequate remuneration for that to happen, and that you also look at the social side of things of being in a rural and remote community, so that there is that that other element, because essentially what we are selling is a lifestyle. And so it's important that they also get a good experience from that perspective as well. You know, that they're engaged in the local netball team if that's what they'd like to do, or, you know, if they like arts, that if there's something to do so around that. So I think that's really important.
All right. Thank you. I'll put anything else on notice. Thank you so much, Chair.
Thanks, Senator Hughes. Senator Patrick.
Thank you very much, Chair. Just to Dr. Hall, I just wanted to let you know that whilst we have many inquiries and you know they are tiring, they are useful for informing senators who can then seek to get change. So whilst you may well know the problem, it is good for us to hear that, and it is good for us to hear multiple perspectives. So I apologise. I'll say this is more about us than it is about you. Okay, so just in terms of very, very quickly, you probably heard me talking to the previous witnesses about a simple map. Again, in your submission, you talk about numbers, but it's not easily digestible about to the average punter, who is the person we need to put pressure on, or a person we need to the people we need to inform, such that we can put political pressure on governments. Do you have anything, or is this something you might want to cooperate with the previous witnesses to get to the committee for South Australia and Senator O'Neill says also New South Wales?
Yeah, look, we do have additional data that we can provide. The numbers I provided were from the Australian Institute of Health and Welfare, and they were for all doctors, not just GPs. So they were all doctors, regardless of specialty. Those numbers showing, you know, half the number of doctors per capita in rural and remote. We do have breakdown on general practice across the ASGCRA classifications, which we can provide, which gives you numbers across that as well. There is a commercially available tool called Gap Maps, which actually maps out all general practices in Australia. It basically pulls their data from provider numbers, but also from their websites. So, and that's commercially available, and you can look at a map, you can drill down to each practice, how many doctors are there. So I could provide that link to you, but it's a very useful tool at looking at who's where, and it's not complete. It's a commercial product that they're using the data that's openly accessible, but it certainly gives you a really good idea of where the practices are and sort of how well staffed they are in the first instance.
Yeah, thank you. I mean, I don't mind if it just talks about GPs rather than specialists, because most communities connect with the idea of a GP and they understand the importance of a GP. So, look, thank you. If you can help in that regard, again, maybe talking with the previous witness to come up with something very simple, that is powerful in terms of changing the political narrative or guiding the political narrative. In your statement, Dr. Hall, you talked about funding, and I think you said it was sort of MM5 through 7. Half of it was going to the cities, and half of it was only half of it was going to the regions. Firstly, can you just make sure I've got that right, and then can you unpack that?
Yeah, so Triple M 3 to 7. So that's pretty much anything beyond anything beyond large regional centres is what we call Triple M 3 to 7. And I think it was about $2 billion annually that was being spent through government programs. We found about $1 billion of that was going to Triple M 1 and 2. So there are a number of heavily funded programs that are based on training, one of them being the specialist training pathway that was heavily funded. And we found that the majority of that money was being spent on training metro specialists who went into the program with an intent to go rural but never actually landed. And much of the funding that's gone to a number of the key sort of non-government organisations and stakeholders in this industry for rural programs, they all start off in the city, and not many of these programs are held to account on an outcome where that body then actually ends up in the bush. So that's why a number of this rurally intended monies has basically sat in Metro, and I think it needs reform. One of the key things we could do is actually hold organisations to account. So I'm talking colleges, universities, we're talking workforce agencies, regional training organisations, and hospitals. If we held them to account, that they're not only on process measures, not that you've got someone starting in a program, but that body actually ends up working in Moree, working in Stanthorpe, working in Burke. You know, if they don't actually end up moving to Triple M 3 to 7, then we spend all this money on rural communities. It doesn't end up supporting rural communities.
Dr. Paul, are you saying the system's being rorted?
No, I don't. I'm not saying this is all malicious intent. There are a number of reasons why people might start on a rural pathway and go sideways, and many of them are meeting partners that want to stay Metro, or they change their mind about the specialty that they want to do. So we know that in any good rural training pathway, there's going to be natural attrition. A number of the doctors that start on the pathway to training towards rural generalism might do a year of training in obstetrics and then decide they actually want to be an obstetrician, and then they would go sideways. So there will be a natural attrition, but I think we would push more of this funding into genuinely providing rural workforce if we held the organisations to account on outcome measures, not process measures.
So in some sense, the money gets directed at a medical outcome, but perhaps some of these institutions are quite comfortable with receiving the money and not necessarily chasing up whether the outcome becomes of real benefit. So not a rort per se.
And the KPIs included. The KPIs include a lot of the KPIs for these programs include Triple M2, which is large regional. So if you place someone in a large regional centre, you're ticking the rural box and getting your rural funding.
Okay, thank you. That's very helpful.
Can I just add a quick comment, which is the other part of that is the actual training. So the success that ACRM has is because we actually focus on rural training. So the experience, the training, the supervision and the assessment and the context that they learn in is to actually work in those places. And whereas if you take a metro program and try and stick it in a rural or a regional area, it's not fit for purpose. It's not specific, and it doesn't take into account all of the differences that occur. So I mentioned, initially in my opening statement about resource poor practice, about isolated practice. Even for somebody who's working in a smaller, say a regional hospital, doesn't have access to all of the same services that their colleagues have in the big cities. And if you don't actually train them to practice medicine in that resource poor environment, then it's a bit of a setup, I think. And, so rural specific training actually needs to be considered as part of the solution. You don't just take a metro program and dump it in a rural area. You actually have to, it has to be specific for the context that you're training people in.
All right, thank you very much. I just have one question, and maybe this needs to be have a collective answer here, and that goes to the effect of not having a doctor or losing a doctor in a non-medical sense, whether or not there's been studies in relation to this. So, not having a doctor in a community, I think, turns people away, other people away. We know, if Senator Hughes' doctor leaves, suddenly there's not a ballet teacher in town, or things like that. Can I just get some sort of commentary, because I think it goes beyond the medical effects to other problems that are generally found in these rural communities. So maybe one from each of the two groups.
And if we're going to have very quick answers, because we are desperately short of time, and I've still got Senator Urquhart and Senator O'Neill that want to ask quick questions.
May I start? Because I've actually experienced this. So I used to work in a small remote community where a general practice had been there for some 40 years and for various reasons was in the process of closing down. And the impact that that had, so the businesses around town were actually came to tell us that they were unable to recruit people to move to town because everybody knew that the general practice was potentially going to close down. So that was, that was teachers, that was, there was a military, like an army base in town. They had people there who were less keen to come to town because there was looking to be no general practice service. There were quite a number of people in town who said, if you guys close, we are leaving. So it goes across the entire community. And for rural generalists, if you, it impacts the entire health service as well, because if they are GPs in town, they are, also working at the hospital. So, is that then the birthing service is going to close down? And then even more people don't want to come to town because they wouldn't be able to have their babies there. There's a massive, ongoing effect. It's huge when, when a doctor leaves town.
Maybe quickly from the Rural Doctors Association. Thank you.
Thank you, Senator Patrick. So I have to definitely echo Dr. Chalmers' sentiments there that, yes, when a rural doctor does leave town, it has a huge effect on the rural community. Even when a rural generalist stops from practicing his or she's advanced skill, it has a massive impact on the community. Where I work currently in one of the places, one of the local GP obstetricians has just recently stood down, and essentially we have lost our birthing service. And for me, as the GP anaesthetist that has moved and bought a farm locally, I'm absolutely devastated because I love doing maternity anaesthetics, and our women of the region have missed out, and it really has that ripple effect. So what's next? Do we lose our urgent care centre? Do we lose our theatre capability? And so, there is that real threat of our small rural hospitals being turned into nursing homes, and that's what they are, that's what they then end up as. But then, yes, you will see a degradation in the rest of the community. You won't be able to attract teachers for our high schools and our primary schools. You won't be able to attract further businesses to come to the region. You'll see factories close. Like this is actually a reality, and so it is really important that this is acknowledged.
Thank you for that important evidence. Thank you. Thank you, Chair.
Thanks very much. Senator Urquhart. Can't hear you, Senator Urquhart. Still can't hear you.
Maybe if I get rid of
that's
is that better?
Yep.
I didn't like the earplugs, obviously. Look, I just wanted to touch on a number of the areas that, and can I first of all say that I really look forward to the breakfast of the rural doctors coming back to Parliament House, because I think that's somewhere where we get the opportunity to talk to you, doctors from rural areas in a setting where, we have that opportunity, and it's been really good. So I really look forward to welcoming you back when we get post-COVID and we have the doors open. I just picking up from a number of the submissions, things that I've sort of pulled out of there. And I think, Dr. Chalmers, you talked about in your opening statement, rural doctors not being recognised. I'm not sure what context, but I also, there's been sort of comments, and some of the submissions talk about the value of the work, bullying and harassment, those sorts of things. I guess what I'm interested in, we've heard a lot about the Medicare rebate freeze, the opportunity for programs, training, how difficult it is for recruitment. In terms of that sort of mental health of doctors in rural areas, rural and regional areas, can you tell me what can and should be done to help alleviate the issues around that, and what support can be or should be provided? I'm really not fussed as to who kicks off. And it's a big question, and I know we're really short of time. So Thank
Yes,
you.
if people could be quick, please.
Yeah, if I can start. So the recognition process, we've what I was referring to is that we're not recognised for the skills that we have. To be a doctor in a remote area, you practice medicine differently to what you do in an urban area because you don't have the specialists nearby. You don't have access to tests. I used to work out in a really remote community where it took 3 days to get a normal test result, whereas in a city you can get that back in an hour. We do actually practice differently, and that we are our skills are not recognised. The scope of practice that we practice in is not recognised, and what that does is it just adds another layer on to what is already quite a difficult job. And I'm really grateful actually that you've mentioned the mental health of rural and remote doctors, because it's a big issue. And certainly, as I mentioned, as we're facing the COVID pandemic, moving out into rural and remote areas, which we've been mostly protected from, with the exception of places in New South Wales and Victoria. We've got a group of people who have not had access to holidays because they can't get another doctor to come and relieve them. And if they go on holidays, they actually will leave the town without adequate medical services. And, the commitment of these doctors is that they have stayed, despite all of those issues. And we do worry about, the mental health of our colleagues very significantly. How do we make that better? We've mentioned, through the recognition, so of rural generalism as a specialty. We've talked about, better remuneration. And actually we need to, the last thing that I would say is that, and I think it goes to one of the comments that John made earlier about, the problem with inquiries and things like this is that, we're really talking about failure. We're talking about the bad side of rural and remote medicine, and it's the most rewarding and incredible career. And one of the things that's really important that I really wanted to say today is that there's 4 really committed rural and remote doctors here talking to you today about, and we do what we do because we love it. And we want to support our colleagues. That's why we're in the positions that we are. So I'd like to invite my other colleagues to add to the answer as well. Thanks.
Very quickly.
Sarah, if I could just quickly make a point to Senator Patrick's previous statements. Imagine the effect of a doctor approaching retirement age, knowing that there's no one coming in his place, and what that means to the legacy he's going to leave behind and the gap he's going to leave. That is an incredible problem for doctors such as me approaching retirement age. To comment on the mental health, one of the key enablers that I see is the Rural Generalist Program, the identity, the camaraderie, the collegiality that has delivered to young female doctors who are substantially, over 60% of graduating medical practitioners are female. I have the most wonderful colleagues I work with who work in the Emerald Hospital, and they will live and work there because they have maternity leave, they have family leave, they have sick leave. None of those are available to them if they enter general practice. We have had about 7 babies born to female doctors in this community, but they know if they step outside that protective framework, they will have nothing. They will have to bow and scrape for every dollar. And those women have husbands, they have families. And, I was in theatre on Sunday night assisting a young doctor who I honestly think could be a top specialist in the middle of Sydney, but she chose to be a rural generalist, and she's doing an awesome job looking after women in this community. But she needs that wraparound support. Now, I've seen those clinicians when they have a terrible event and they made the wrong decision or whatever, how quickly that collegiate community can wrap around and support them. Now, we're at a critical juncture in our community, and I'm working very hard with our state and with Minister Darth to address that by looking at the whole pipeline, looking at how we elevate, support and enable our rural clinicians, that we don't go down the path of the band 11s, which is where, you know, if you got rural in the current training capacity for our industry partners, that was the consolation prize. You weren't good enough to get a Guernsey in the city. Now that's just not good enough. So we have to acknowledge that there is a way to fix this, and our college clearly and our industry partners have joined with us in a clear mandate to deliver that. But we need to get on and do it, and we need to do it yesterday. To speak to supervision, there's not many of me left out here to supervise, and if we don't do something now, there's going to be no one supervising young doctors because there won't be anybody. So thank you.
Thanks, Dr. McPhee. Are you able to put the rest of your questions on notice, Senator Urquhart, because we are already 20 minutes late?
Fine, I'm happy. If there's any other responses that either Dr. Hall or Dr. Bello would like to put in relation to that question, or anyone else, I'm happy to get them on notice. Thanks.
Thanks. And Senator O'Neill, you said you had one burning question. Can you?
I do, and it's about
quickly.
international medical graduates. Can I just clarify first if we have any international medical graduates amongst the people giving evidence today, or are they all Australian homegrown?
I think we're all Australian medical graduates.
Okay, thank you very much. So we do know that there's been an incredible reliance since Mr. Abbott was the health minister on the reliance of international medical graduates as a workforce for rural, particularly rural and somewhat regional Australia. And many of those have actually been conceived of as really forced placements as the only way to get a provider number. Now, my experience of meeting these doctors has been very varied, some really good, some absolutely not meeting the community, but most of them kept their families in the city, and they just sort of did an endurance test of staying out bush as long as they needed to and then returning to the city on the weekends as often as they could. Not in all cases, but in too many. So my question is, given the fact that the number of international medical graduates in Australia has increased from 48.2% of the total GP full-time equivalent since 2014 to now 52% in 2020, and that the most recent data shows that only 15.2% of final year medical graduates are listing their preference as GP. What is the damage of the IMG program, and what needs to be done to fix it? Because it looks like it's not going away and the problem seems to be getting worse.
I'm happy to answer that question if the others are happy. Look, our international medical graduates have done a lot of the heavy lifting in the last 20 years in rural Australia, and we owe them a massive debt of gratitude. We've had some amazingly skilled and talented colleagues that have gone into rural practice and they've stayed there, and they've provided some great support. But as you pointed out, we don't think that the 10-year moratorium or forcing doctors to go rural is the solution at all. And it's not about where they've come from. And we would say the same about Australian trained graduates. It's about having the right doctor with the right skills in the right place. And we want doctors that want to be there. And we want doctors working in rural communities that have got the skills to provide that range of service. Many of our international medical graduate colleagues have come from overseas with different specialties. So they might have come over to Australia with an orthopaedic qualification. They're an orthopaedic surgeon. They can't get recognised in Australia as an orthopaedic surgeon. So their only option is to work as a GP in a remote town. Now, they do some great work, but that particular doctor is not fit for purpose for that community. They need to be trained in general practice. They need to be trained in, the maternity care and the hospital care that we spoke of. So it's actually not about where they've come from. It's about having the right doctor with the right skills. That's why the Rural Doctors Association have spoken openly against the 10-year moratorium. And what we'd like to see is a really strong training pathway that would make it attractive for these doctors coming into Australia to train in rural practice, to see how good it can be and want to go there. And a number of our really good and functional international medical graduates have done that through the ACRIM independent pathway, through RVTS, and they've gone and stayed. And the ones that have stayed are the ones that have trained themselves up to that skill set. And you know, as I said, many of them have stayed and lived in those communities. So I think it's definitely part of the solution, but it needs to plug into our existing training pathways that exist and make sure that they're trained to purpose and then recognised for that skill set when they're adequately trained.
Thanks very much. I think we'll need to leave it there unless there's any extra burning things that people need to add in answer to that question. Given that we're now 20 minutes over time, but that's okay. It's been really valuable evidence for the committee. So thank you very much for your evidence and your submissions today. They're great value to us.
Thank you.
So if you do wish to add some extra information in terms and answers to any questions taken on notice, if you could get them to us by the close of business on Thursday, the 18th of November, that would be really appreciated. So the committee is now going to suspend for a break and we'll recommence at 12:10. Thanks very much. And the Rural Workforce Agency Network. So thank you very much for appearing before the committee today. So to begin with, to kick off, could I please ask you each to state your name and the capacity in which you appear for the benefit of the Hansard transcript. So starting with the National Rural Health Alliance.
Thank you. Gabrielle O'Kane, the CEO of the National Rural Health Alliance.
And I'm Claire Fitzmaurice, Policy and Data Analytics Officer at the National Rural Health Alliance.
Thanks, Ms O'Kane and Ms Fitzmaurice. So now the Rural Workforce Agency Network.
Good afternoon, Chris Mitchell. I'm the Chair of the Rural Workforce Agency Network. Thank you.
And Edward Swan, Executive Officer, Representation and Engagement for the National Coordination Unit supporting the rural workforce agencies.
Thank you, Mr Mitchell and Mr Swan. So could I ask each of you to do your best to speak clearly and identify yourself each time you speak to assist with the recording and broadcast of these proceedings. And the technology has held up so far this morning, so let's hope that it continues this afternoon. So look, I now invite each of you to make a brief opening statement if you'd like to do so, and after that the committee members will ask some questions. Now we are pretty tight on time, so if you could make your opening statements brief, that would be appreciated. We have read your submissions, so thank you. So starting with the Rural Health Alliance.
Thank you, Gabrielle O'Kane. So the National Rural Health Alliance thanks the committee for the invitation to attend this hearing and welcomes the opportunity to speak with you today. The Alliance comprises 42 member organisations that brings together health consumers, healthcare professionals, educators, students and service providers, and the Indigenous health sector. We are committed to improving the health and wellbeing of 7 million Australians living outside major cities by working towards our vision for healthy and sustainable rural, regional and remote communities. The Alliance notes that this inquiry includes outer metropolitan areas in its scope. However, consistent with its remit, the Alliance has focused this submission on rural, regional and remote Australia. While the Alliance recognises the importance of holistic care provided by the full range of health professionals, again consistent with the terms of reference for this inquiry, this submission focused on general practitioner services and other primary health services closely linked to general practice. People living in rural Australia have poorer access to health services. The number of health professionals decreases as geographic isolation increases, and the shortfall in health providers and services means there is an annual deficit in health expenditure. Despite the myriad of government programs and initiatives seeking to address the maldistribution of the health workforce across Australia, there is little evidence of significant improvement to the health outcomes or workforce challenges in rural Australia over many decades. We must address this by ensuring policies and programs are evidence-informed, their impact thoroughly evaluated and learnings widely shared. Proactive, innovative and whole-of-system change is required to address the challenges of delivering primary care services in rural settings. Policies that target the medical training pipeline as part of the Stronger Rural Health Strategy are supported by a strong body of evidence, selecting medical students from rural backgrounds and enabling students and trainees to undertake training in rural areas during both their entry to practice qualification and postgraduate training pathways have been shown to improve rural workforce retention. Full implementation and embedding of the National Rural Generalist Pathway, along with rural generalism trainee employment models, such as the Murrumbidgee model that's currently being trialled, have potential to support this training pipeline to address rural workforce issues. Once these training pathways are complete, offering employment models that provide team-based care in rural communities, bringing together GPs, nurses and a range of allied health professionals will also help to address the critical health workforce shortages in rural Australia. The Alliance proposes a well-developed, secure, ongoing employment model for rural primary care workforce, the RACHO model, detailed in our submission. RACHOs will be block funded in a similar fashion to ARCHOs and will offer services that are place-based and adapted to suit the needs of every community. The Alliance also continues to recommend that the Australian Government take the lead in developing a new National Rural Health Strategy with a focus beyond workforce, setting out a comprehensive integrated approach to improving rural health outcomes with the inclusion of outcome measures, targets and an implementation and evaluation plan. We'd be happy to discuss with the committee any issues raised in the Alliance's submission. Thank you.
Thanks very much, Ms O'Kane. So the Rural Workforce Agency Network.
As famous words spoken are, getting off mute now. So good afternoon, I'm Chris Mitchell, the Chair of Rural Workforce Agencies, coming from Yagara and Terrible country today. I'm joined by Edward Swan, the Executive Officer, Representation and Engagement of our National Coordination Unit, which supports the Rural Workforce Agencies, and he's from Nipaluna land. Thank you for the opportunity to present today. We're presenting a shared view of the rural workforce agencies across Australia. And whilst that's a shared view, we'd stress the significance of the variation in communities across jurisdiction, which you're well aware of. And partly that's due to the jurisdictional arrangements. We'd encourage you to, haven't seen the dates for all the hearings, but it's important to understand the context of jurisdictional level. It's not vanilla, as you know, there's a difference, and the difference is really important to the work and the outcomes for individuals and rural communities. The workforce agencies are not-for-profit agencies funded by the Australian Government, whose singular focus is to ensure remote, rural and Aboriginal and Torres Strait Islander communities have access to highly skilled health professionals when and where they need them, now and into the future. As workforce agencies, we've had more than 20 years' experience working with communities and working with stakeholders to address health workforce shortages and to assist the rural health workforce and support them. Our work includes conducting an annual health workforce needs assessment that supports the targeted work to develop place-based work solutions to thin markets or market failures within remote and rural communities. We work with communities and all interested stakeholders, of which there are many, to develop solutions to deliver improved services to community or improve supports for the health workforce. In this case, we're talking about general practice, but it's broader than that as well. And this is done within a range of Commonwealth grant programs. We are at the coalface of the implementation of government funding and policies, and we see firsthand the collective impact of the government funding and policies and the realities of the lives lived and the experience for the rural health practitioners and the communities they serve. The inquiry is well aware of the considerable challenges facing remote and rural communities, specifically in relation to access to quality general practice and primary healthcare services, in particular connections to acute and tertiary. Maldistribution of general practice remains the single major barrier to access to services for remote communities. I'd now like to hand to Edward.
Thanks, Chris. So Edward Swan, continuing for the Rural Workforce Agencies. So there are 5 key points that in addition we'd like to highlight today. The first is we're concerned that any changes made to policy levers to address outer metro areas could negatively impact on rural and remote communities. So please don't rob rural to address outer urban challenges. Secondly, a more joined up model is required to address distribution issues for GPs and improve the return on investment for Commonwealth programs. The joined up model would provide clarity of the various pathways for general practice and span from undergraduate to retirement. 3, non-traditional models of healthcare service provision are required with collaborative regional and local planning, including public, private and non-government providers with community input based on health needs, support innovative practice and new ways of working. 4, the rural workforce agencies, that's us, can play a more significant role by contributing more to and working more closely with government on future policy and funding changes to provide real community level perspectives of the likely changes to health workforce and resulting service and outcome implications. We're working on this. And finally, we're keenly aware of the need for change, improvement and innovative and responsive primary healthcare services for rural Australians. We look forward to the implementation of the GP training funding reforms that are in progress, the primary healthcare 10-year plan and a range of health workforce strategies for which there is much promise and potential. Thank you.
Thank you. Thanks, Mr Mitchell and Mr Swan. So look, I'll now go to Senator Hughes to begin the questions.
Thank you, Chair. I was reading the submission from the National Rural Health Alliance and I was just a little surprised to see that you are estimating that health expenditure has a shortfall of around $4 billion. I mean, that would apply to PBS and Medicare, which are both demand-driven programs. Isn't it a little disingenuous to put those sort of figures in, which potentially could be making it harder to attract people to work there?
I'm not sure why it would make it harder for people to work there.
If they're hearing you say that there's a $4 billion underspend, when it's not, it's demand driven, aren't they then going to start to assume that the investment's not there, which is not the case?
Well, it's demand driven, but if you actually haven't got a GP to actually go and see, then you're not going to be drawing down on the MBS items nor the PBS items. So what it actually is trying to demonstrate in all of that is that we know that it's to do with the lack of access to healthcare. So you have to, for the demand to go up, you actually have to have a rural health workforce there so that you can draw down on those MBS items. So I think that's the way in which we've done our costings. We've also factored in the fact that in rural areas where there is no GP potentially, but there might be a rural hospital, they actually are being serviced by the EDs in those towns. So we factored in that, and despite some of increasing expenditure in the rural hospital space, there's also a lack of expenditure or inadequate expenditure through that primary care MBS model.
Because we've just previously heard from previous witnesses, and I'm not sure if you were listening, but that there are innovative ways that are occurring. In fact, it's more GPs that are working in local rural, and I'm talking rural and remote. I was very pleased to hear Mr Swan reference rural, not outer urban. But in a lot of rural towns, it's actually the local GPs in the clinics that are actually servicing the hospitals rather than the other way around.
Yes, look, it depends on the jurisdiction, and certainly in Queensland, and I'm sure that Chris will be able to speak to that more so than me in some respects. But the model in, like the rural generalist model in Queensland, it does appear to be that it's more likely that the doctors are spending more time in the hospital and doing less in the GP space, even though they can take advantage of the 19(2) exemption. Whereas in New South Wales, the picture is different. It's more of a VMO model, so they spend more of the time in their general practice, but then work some of the time in the hospital setting.
So it's not really that there's no GP, it's actually they're having to then cover hospitals as well. I noticed that you proposed I assume it's announced RACO model. have you got any concerns that it would actually become more bureaucratic? When you look at the list of groups that we're hearing from today, there's obviously a substantial number of groups covering rural health specifically already, let alone the RSCGP, etc., that by bringing in the RACO model, it's potentially going to be more bureaucratic, potentially more one-size-fits-all, and obviously what happens in Moree is very different from what happens in Arnhem Land, which is very different which happens in Cairns. Don't we need to have more flexibility than that?
Well, the four principles that we have underpinning the RACHO model, and we're calling it RACHO because it's similar to the ARCHO model. So you would be familiar with the ARCHO model, I'm sure. And so what we're saying, the four principles around that is about flexibility. So it needs to be very much grounded in the community, and it needs to be what we're suggesting is that the RACHO model is actually driven by the community. And that's going to be very different no matter where you are across the country. So there is no one size fits all, and we're very mindful of that. And so the governance also can be very flexible within that as well. So it might actually be picked up by the local government area. And there are examples of that around Australia already, which could actually be a RACHO model. In other instances, there are social enterprises that are currently doing that sort of work. They could potentially become a RACHO into the future as well. What it requires is block funding, though, and that's one of our other principles as well, in the same way that an ARCHO is. Because what we're actually suggesting out of all of this is that we also want an employment model, because we are hearing time and time again that many young doctors particularly don't want to necessarily go out and work into a rural area where they've got to put up their own shingle and potentially run their own practice and run the business side. Many of them want to have a work-life balance and they want to do the doctoring rather than doing the administrative side of things. So a RACHO would actually have that ability to do some of those things. We don't think it's going to be any more bureaucratic. We hope that it's going to be less bureaucratic than what's currently in the system. But it doesn't mean that it's all about collaboration. So in local areas, and a place like Claremont, I'm not sure of the pronunciation, in Queensland is a really good example of how that's all happened, that they've all worked together with the PHN, the local health district, the community themselves have all got together to actually solve the problem. And that's the way we see RACHOs operating as well.
But my understanding is that model is not supported by New South Wales state government. Two questions here for you with regards to RACHO, and then we can move on. What do you think the state governments need to do to help with the medical workforce shortage? And also, what would be the cost of setting up this RACHO model? Where obviously there's huge investment already occurring in rural pathways and generalist models. Wouldn't it be redirecting an awful lot of money into establishing another bureaucratic line rather than on the ground?
Look, it's not going to be so much of a bureaucratic solution. It's actually a model of care as well as being a business model. What is lacking in so many parts of rural Australia is multidisciplinary teams, and that's what people want to work in that space where they're working with other health professionals, because part of the reason people don't go to rural areas is because there's no professional support, there's no social support, as well as some of the financial issues that I'm sure everybody's well aware of. So what we're suggesting here is actually a service model that's going to service the rural communities themselves in a comprehensive way through team-based care. In terms of the cost, yes, we're thinking at the moment that we're looking at each of these RACHOs might be in the order of $2 million to run per year. But given that many of the different initiatives that have been put out there, there's not a lot of really good evidence to suggest that a lot of the incentives at the moment are producing the results that we want to get. So we're well, we have the view that we need to evaluate how well a RACHO operates and see whether it is going to be cost effective. It's my view that it will be. And I think the reason we need RACHOs as well is that in the past, community health centres used to deliver a lot of that team-based multidisciplinary team care. And at the moment, it's been sort of withdrawn, not entirely, but that communities aren't being well serviced by those models anymore. And we need to make things affordable for rural people. And at the moment, if we've got some allied health professionals as well as GPs that can't just do bulk billing because it's not financially viable, we want to have a model that's actually affordable for those rural people. And we think RACHOs are going to be able to do that.
Okay, because it was just interesting hearing Rural Doctors Association previously say almost the exact opposite with regards to some of the programs that actually are delivering, and they're reluctant to see a whole lot more conversation when we know what the issues are, and it's more about getting those pathways fixed as opposed to going back and trying to reinvent the wheel. Anyway, I know we're short of time. So, Mr. Swan, you did mention rural, not outer urban, and someone who lived in Moree is very much a rural and remote area as opposed to, a Wallandilly or a Newcastle or somewhere in Wollongong in Sydney. What are the dangers of health policy not acknowledging rural and regional as a very independent, separate kind of, way of looking at healthcare if it gets mixed up with outer metropolitan areas?
And that's your last question, Senator Hughes, if you could answer very quickly.
I'm done. I'm done.
Well, I suppose from my point of view, or from the point of view of the Alliance, that we do want to avoid that. And I guess that's why a RACHO model is a rural area community controlled health organisation.
I was asking Mr. Swan, because Mr. Swan actually said it in his opening statement.
That's right.
I beg your pardon, sorry about that.
So, Senator, I guess the way that we view this, and I will ask Chris Mitchell to make a comment too, we see it as a focus on distribution, and ultimately there is a single workforce in that sense. So, and we see it in terms of currently we have a range of policy levers, distribution measures that encourage the workforce to work in more rural and more remote settings. And so if there's a change in that outer urban setting, if you like, incentives to go there, that is likely to impact on the existing workforce as well as intention to work more rurally and more remote. Chris, would you like to add anything there?
Yes, just quickly. We've been here before. As a country, we had an outer metropolitan strategy. It did damage the very remote and remote communities and rural. The incentives were watered down, if I can use those words. The current arrangement, government policy, has a visa for GPs program, which does not allow doctors who are coming from overseas to go into M1. So we would have and remain concerned about any change that needs to happen in outer metro. And let's be clear, there's a differential between outer metro availability to service, not discounting the fact that those services are needed for those communities across the whole stream of primary healthcare. But there's a differential. So if you do something for outer metro, you've got to multiply it as you go up from 3 to 4 to 5 to 7 through to scale. It's really important. And connecting back to the comment before about the spend is due to the lack of service provision. There's a whole range of strategies to put more people on the ground, and it's just difficult. So that's probably a short answer there. Thank you.
No, thank you.
Thanks, Senator Hughes. Senator Green.
Thanks very much, Chair, and thank you all for your evidence today. I just wanted to ask about your thoughts or your views around the DPA classification. I understand it's a very new tool, but I did notice that you'd raised some issues around the transparency of how DPA areas are addressed. And then I guess going forward, because I don't have a lot of time, the second part of that following on is around our reliance previously on overseas trained doctors, and any views about what we should do post-COVID. One of the things that people talk about is, we've got a choice after COVID. We can go back to the way we were doing things before, or we can try to come up with some different solutions so we don't have the same problems that we had before.
So in short, the DPA arrangements are under review, as you know, at the moment, and there's an exceptional circumstance process that's being worked out, and we're having another briefing on that tomorrow. This actually allows a graduate to be placed, international Australian graduate, to be placed in a community, in the geography. So that's an important differential. If you are in an area which is non-DPA, there's a whole range of Commonwealth programs you do not have access to.
Yep.
And that sounds simple, but it isn't. It's complicated, and it goes through. There's 19AB, 19AA. So under those exemptions that it impacts, we would say a couple of things. One is the transparency of the current process, so a practice can understand in applying what does it mean, and where they are with the threshold and how that might be worked through. Now, having got to that stage, I then would say to you, the blanket DPA that currently goes from 7 through to 5, we think is fantastic. It's really good, saves a lot of paperwork and says there's a problem there, go fix it, and you have the ability to do it. And guess what? We haven't been swamped with doctors in those areas. We've still got difficulty in recruiting. As workforce agencies, we'd say we need to look at 4 as a blanket, and we'd have a look at 3 as a blanket as well. Remain with a view that, yes, a testing of the market in Triple M2 would be useful, and we'd say don't go into Triple M1 or outer metro.
Right, and I guess on the model that we had before, where we were, we had the Visas for GP program in 2019, where we certainly we were getting doctors to come from overseas. How can we sort of make that a better program post-COVID to make sure that, I'd love for these doctors to come to our community in regional Queensland, but I'd also love them to stay for as long as possible, and not force them to stay, but show them what a great opportunity it is to stay here. So I'm just wondering, we hear a lot that people come and do their time and then they leave after they've ticked the box, they head back to the city.
So I forgot to introduce myself again, Chris Mitchell. Just really quickly, the reliance on international graduates, I think is still required in the country. There'll be evidence presented during this inquiry that we have a maldistribution, and that's the issue. It's where we have them placed. And then it goes back to, so what are the attracting side of things, or what are the retention strategies? We've got a whole range of attraction and retention strategies, and a number of entities have presented today and will present. The issue is there is a cycle. Some of our training programs create a cycle, and then we've got to be really careful. And I hark back to a document called Labyrinth, Lost in the Labyrinth, which really outlined the system that we created and the systems after that document and those hearings. The system's actually worse, if I could say it to you. It's harder to get into the country, and you'd say you have to maintain quality and safety, but you also have to maintain distribution. So what is it that's attracting an Australian graduate to go to a number of towns I won't mention along the various coasts? So we've got to work at that level. What is that, and how can we help them? How can we encourage them to come, support them there and look after them? The regional training hub strategies, which you'll hear about in a moment too, that's awesome. It says put the specialist training in the regional centres, and we know if you put a few together, the critical mass can grow from there, and we've seen that across the country. And the long stay programs that we have in the various programs also does the attraction for the Australian grad. The bright lights of the city may not be too bright anymore given COVID, but there's still people who think the only place to be a specialist is in the city. We're interested in rural generalists. We're interested in GPs for the bush who want to work in rural, and we're interested in specialists who want to work in rural community.
It's Gabrielle O'Kane. Could I just add to some of that discussion as well, if that's okay?
Of course, thank you.
Yeah, I was just going to say that certainly from our research, forcing people into rural areas, which is what does happen with our international medical graduates, it doesn't seem to be an effective mechanism. But having said that, there are, doctors that are working rurally that say that without that international medical graduate coming into the system, that we'd be in a much worse situation than we are at the moment. But in terms of post-COVID as well, I think that the Murray-Darling medical network proposal, and already there's some students that have already started in that, I do think that there's going to be some real promise in that, because it is going to be picking up those rural people that then go into the medical workforce. And I think that that in time will have some benefits overall.
Great, thank you, Chair. I might leave it there. I know other senators have questions.
Thanks very much.
And we're kind of out of time.
We are out of time. So thanks very much, Senator Green. And I've just got time for a quick questions, very quick, from Senator Patrick.
Okay, thank you very much. Just very quickly, just to the Rural Workforce Agency, you're funded by both state and federal. Is it fair to say that's the dominant source of your funding?
Predominantly Commonwealth.
Okay, thank you. And what MMMs do you work with? Is it from 2 downwards or 3 downwards?
So a couple of programs go 2 to 7. Most of them go 3 to 7, and now we go worse first, so we go 7 backwards.
Okay, thank you. Look, if I was going to be brutal here, I've asked that a document be circulated as an answer from the Department of Health that was provided to me just recently under estimates. If I look at where the GP's FTE per 100,000 population across each of the MMMs, then I find that actually in most cases, and there are exceptions to this, the numbers have either been static and in fact and just recently have gone down. Standing back, I'd be saying to myself, if I were the Health Minister, why wouldn't I seek an alternate to the Rural Workforce Agency when I don't seem to be getting the outcome that I want, which is an increase in FTE in those MM7 through 3 or so forth. Why would I not go look elsewhere?
Yeah, thanks for that. So the context in which we work is Commonwealth programs and the policies that come and go. Some of those have been very helpful and activated attraction and retention. And as I shared earlier, that some of the outer metro things actually diminished over a number of years, diminished the work that we had done in early years in M 5 through to 7. Because you could go to Footscray, or sorry, I shouldn't say suburbs, you can go to outer suburbs, Footscray's not outer suburb, but out an outer suburb and be employed. And there were thousands went there, therefore the Visas for GP programs. We have good return on our programs. We have seen though, pre-COVID, related to a number of systems where bringing doctors in from overseas became tougher and tougher. And I already mentioned earlier about quality and safety, I understand that, but actually there were some curious processes in there, if I could put it that way. The second piece is that Australian graduate numbers have increased. Incidentally, in 1 year, the graduates seemed to evaporate somewhere. Where did they go? And when we looked at it, there was the number of doctors going to hospital and staying in hospital. In one state in the public teaching hospitals increased by 10%. The other one, which is a benefit to the community, is the Rural Generalist Program. And both the Queensland Generalist Program and the new National Generalist Program, that will have an impact as well. The issue in some of the states is that those doctors are GPs first and hospitals second. In Queensland, they seem to be hospitals first and GPs second. So the mix is important. We were talking about the mix earlier, Senator, and that was really important to the town. The control of all of that is both state and federal. The employment arrangements during the medical training, intern, etc., and most of the training, but not all, is state with federal funding covering off the end if you're doing general practice training.
Okay, but in terms of outcomes, I mean, in some sense, you're sort of passing the buck back to the states and the federal government. I mean, where's your submission that says these are the things we were going to do, but the government wouldn't let us. That's what I'm interested in,
Oh,
because
okay. Yeah.
I'm just a bit frustrated. You're obviously federally funded, and it's not acceptable to me to say, look, you know what, the states and the federal government are resisting ideas and things that we think are successful without you saying to this committee, these are the things that we're being fettered in doing. Again, the numbers look really flat, and one wonders. I mean, maybe you want to come back on notice, and you know, your argument might be that without you, the numbers would be worse. But I can't see where that is in the data. I can't see the value for money that we're getting from your organisation in respect of actual doctors out in the in rural areas. And I'd ask, and just to be fair, maybe you can respond to that particular question on notice and in detail.
Thanks, Senator Patrick. Look, I'll just a quick 1 minute response now, and then yes, I invite you to respond in more detail on notice.
Thank you, Chris Mitchell. So the response clearly is the tap for international medical graduates was turned off several years ago, and it made it harder to get in, full stop. Second one, and that was also for other graduates, international. And the second piece is that the attraction into general practice has been lower. And other presenters said that today as well, that there's been a reduction in the attractiveness, and there's a lot to be said on that. The other point is the attractiveness into general practice. We'll talk specifically about general practice. The business model is at risk, and the funding for that business model is also at risk. So the attraction factors are really clearly an important issue.
Thanks very much.
Thank you.
Thank you, and thanks, Senator Patrick. Look, thank you very much for your evidence today. It's been of great value to the committee. So if you do want to provide some more information in response to that question on notice, if you could get it to us by the close of business on Thursday, the 18th of November, that would be really appreciated. I'm sorry we're short on time. It's been a busy day, lots of stuff to get through. So look, I now welcome via video conference representatives from James Cook University. So thank you for appearing before the committee today. I'm Senator Janet Rice, I'm the chair of the committee, and with me I have got Senators Green, Askew, Urquhart, Patrick and Hughes. So you've got a good bevy of senators of hearing and talking to you today. So in order to kick off, would you be able to first of all please state your name and the capacity in which you appear for the benefit of the Hansard transcript?
Look, thank you very much, Senator Rice. My name's Richard Murray, Professor Richard Murray. I'm the Deputy Vice-Chancellor of the Division of Tropical Health and Medicine, the health and medical part of James Cook University. I have a group of colleagues here with me today who I will introduce more formally later, but if you'd like, we can get names onto the record now just quickly.
That would be great.
And we're hoping, of course, that this is going to provide you and your fellow senators with an opportunity to interrogate really a sense of what works rather than perhaps what doesn't work, because I actually think that's probably the most important insight and perhaps something we can give you a lived experience of. And in no particular order, we might just go around the room, around the virtual room rather, starting perhaps with Kane.
Hi, I'm Kane Langdon, a 6th and final year medical student at James Cook University, presenting from Cairns, which is Gimo Yidinji and Yuragananji country.
And Bryce.
Hello, Senators. My name's Dr. Bryce Nicol. I'm the Medical Superintendent of Joyce Palmer Health Service on Palm Island and a Senior Lecturer for James Cook University. Today, I'm joining you from Thursday Island in Kurrared Country.
Thank you. Peter Ann Teague.
Good afternoon, Senators. My name's Peter Ann Teague. I'm a doctor, also have a role with JCU as an Associate Dean of Strategy and Engagement, and I join you today from Roma in Southwest Queensland on Nalindinji country.
Katrina.
Good morning, Senators. I'm Katrina Felton-Bush. I'm the Associate Professor of Remote Indigenous Health, and I'm based in the Metapuni Centre out in Mount Isa. I'm coming to you from the Gulf of Carpentaria in Burketown, which is Gungalita country.
And last but not least in our group, Sabina Knight.
And good afternoon, Senator. I'm Professor Sabina Knight.
I'm the director of the Mapuni Centre for Rural and Remote Health with James Cook University, and I too am coming to you from Burketown in the Gulf of Computaria, Gungalita country. And our our Centre for Rural and Remote Health is one of the university departments of rural health, of which there's a national network of 16.
Great, thank you very much. And so, look, I now invite you to make a brief opening statement. If you could keep it brief, it will give us a bit more time to ask your questions.
Thank you. And so, look, I will, and I'll just try and give you a bit of context and look forward to the questions. You can see perhaps from the spread of perspectives that we've assembled for you today that there's going to be ample opportunity to interrogate lived experience, and I certainly agree that would be fabulous to have enough time for that. It's worth saying just at the outset that from my own part, I'm a medically qualified academic, general practitioner, what these days we would call a rural generalist. I've had a career substantially based in remote and northern Australia, the Kimberley 14 years, working with Aboriginal Community Controlled Health Services, and in northern Queensland for the past 16 years. I've been deeply involved in just about every aspect and worn most of the hats, I would say, in the medical and GP training system over that period of time. At JCU, I've got the privilege really of leading Australia's most successful university in producing doctors and other health professionals who go on to non-metropolitan careers, by far. We're one of a handful in the world with this level of achievement, but also Queensland's smallest public medical school, but nonetheless with just on 2,000 graduates to date, some pretty impressive actual outcomes that I heard spoken about before. And I have to say, I think outcomes are the most important thing to be discussing and focusing on at the moment. We're unusual at JCU in that we have both Australia's first entirely regionally based so-called end-to-end medical program established in 2000, but also Australia's only delivery of accredited general practice training on behalf of the 2 GP colleges that we deliver on their behalf, based entirely in the region and joined up. So it's this notion of end-to-end from the high school essentially right through till fellowship and beyond. And in that sense, we're quite unique and I hope can provide some experiences and explain some of our perspectives. Look, I think I might frame this a bit in terms of, we could talk about many things in general practice. We're deeply committed to the notion that comprehensive primary care should be the cornerstone of an effective healthcare system, more so in regional communities and more so in disadvantaged Aboriginal and Torres Strait Islander and other communities. It's more important than ever. And we see that the system, in a sense, is going the opposite direction. So we share your interest and commitment to the cause. We could talk about many things. We could talk about financing and viable practice models. We could talk about what comprehensive care looks like. We could talk about the interfaces with state and territory governments in a federation around public hospital systems. I'm not going to talk about those things. Instead, we're going to focus on workforce, because ultimately it doesn't matter what insurance schemes you have, employment arrangements you have, jobs that you've created. If there is nobody fill them, then there's no service at the level of community. Workforce is absolutely critical to this. And for us, looking at the fact that as a country, we graduate around 3,000 domestic graduates a year, around 600 odd international students also graduate from our medical schools each year, and a fair proportion of those stay on for some period of time afterwards. We, in addition, however, top up the country, particularly remote and regional Australia, from overseas to the tune of around 3,000 per year. We are, sadly, the highest per capita importer of doctors in the OECD. And we have been for a long time now extraordinarily reliant upon international labour to supplement mostly the regional workforce. And with that in mind, you can see that our argument that the single most important policy priority facing Australia as a nation, state and federal, is the supply of a domestic workforce who willingly pursue careers as GPs, rural generalists, and indeed regional consultant specialists in regional Australia willingly with incentives and the rest, but that is by far and away the most important thing. The problem with relying on importation, and my many very good colleagues and friends who are international medical graduates, is that one, it drains countries who can often ill afford to lose their medical workforce, and two, it's temporary. And so what happens is we recruit people into the regions. There's a couple of mechanisms by which people are sort of kept in regions for a while, but overall, with notable exceptions, but overall those numbers tend to percolate into the city, and then in a sense you need to press repeat and the whole thing goes on, and what you end up with is an oversupply, supply-led demand, excessive specialisation in major cities, undermining of general practice and primary care, while you have this itinerant and churning workforce in regional Australia. It's actually a completely crazy way to do a supply of medical workforce. I will, if I turn to general practice just quickly before we go then to opportunities to hear from others. I think we know what needs to be done to provide, it's international evidence now and experience. Around half the JCU graduates pursue general practice or rural generalist medicine within general practice. And that's very different to other graduate profile and destinations for the remainder of the country and indeed around the world. It's very unusual. And about 75% of our graduates overall go on and pursue training work in regional areas, and around 2/3 at any point of time based outside of major cities. The things that create, and certainly our experience affirms it, is selecting people from training in, with and for the communities where doctors are most required, and then providing the after professional entry training, clear supported pathways into, in medicine's case, vocational training in general practice, rural generalist medicine, or consultant medical practice, based away from capital cities to the greatest extent possible, thereby allowing people to make networks, lives, partner, and all the rest of it away from capitals. And these are the ingredients. It's well established internationally. We have innovative selection models, the way in which curriculum and experience is structured, the sort of experiences that students have, and I'd welcome your interrogation of both Bryce and Kane are students or graduates of ours, and you can get some sense of it. And I think these are the ingredients. I think what we'd really argue for is that after 20 to 25 years now of investment in what's substantially been, I think, good investment, Australia's, been quite ahead of the pack in relation to trying to invest in rural regional workforce. But what we suffer from now is a lack of clear objectives and accountability, and a lack of connectedness across programs, federal particularly, but also state and territory, with a common objective in mind. And I think perhaps this might be an opportunity to get a clearer bead on what some of that realignment might be, to focus on actual delivery of outcomes and accountability for that. I'll pause there, Senator. I hope that's set a scene, and I would now very much welcome either questions, or we could indeed proceed with a bit of a thumbnail sketch from folk, and perhaps starting with Kane, but over to you.
Let's go with questions, and I'm sure if we direct some questions to the whole team that you have assembled, I'm sure we'll get to hear from everybody. So I'll hand over to Senator Green.
Thank you, Chair. And luckily, my first question is to Kane. So, Professor Murray, thank you for the prompt there. Kane, I think you might be one of the only medical students joining us today, and we've had a few graduates, but someone who is currently studying medicine. So before I ask some more specific questions about policies and training, I just wanted to ask you about your experience. What made you want to study in a regional area? What your experience has been training in a regional area, and what do you think that means for your future career? Hopefully it means staying regionally as well.
Yeah, absolutely. Thank you, Senator Green, for that question. And I thought I'd start by giving you a little bit of background about myself. So I'm originally from Gladstone in central Queensland, a town of about 40,000 people, 6 hours north of Brisbane. And as I grew up, I worked with my mother, who was a local pharmacist, and found that my my interest and my passions were very linked to the medical area or as a medical specialty. And I thought that I was most aligned with treating patients in the capacity of a medical professional. And so because of that, I decided that I would go on to study medicine at university. And I just think it was a natural progression to then go to JCU to study that, because JCU focused on providing skills for me to then return to a regional, a remote, or a rural community, and then practice medicine in a way that appropriately appreciates the healthcare needs of those communities. So I went to JCU, and throughout JCU, I've had quite positive experiences, especially related to the rural placement side. So across our James Cook University degree, we have 20 weeks of rural placement. So it starts with about 4 weeks in second year, then 6 weeks in fourth year, and then recently I just finished 10 weeks in sixth year in Blackall. And so I think looking back as a graduate and then as a junior doctor, I think I'll look back, and of all my experiences at JCU, I think that the rural placement experience will be what stays with me for the longest. And I think that's because JCU selects supervisors and hospitals and regions that really want students. They're really passionate about both training up students and training and appropriately caring for the community at which they're in. And they just have a passion for rural health. And I think that by going through each of these rural placements and thoroughly enjoying all of them, I think that I've gotten a good sense of the importance of primary care, and I've gotten a good sense of how difficult and rewarding it is to work in that sort of area. And so I think going forwards from there, I would, because of my experience at JCU, I would be very highly likely to then move on into, staying where I am currently in Cairns and moving on to care in that sort of capacity.
Thank you, Kane. I appreciate that. And if I can go to you, Professor Murray, and obviously if there's other people that want to jump in, I guess I've got two main questions, and I'll get to some of the issues around the training, the future of the training program in a second. But first of all, you would have seen again this morning in the Cairns Post, there's more stories of GP practices closing down. You're training fantastic students like Kane, but there's going to be a gap, isn't there? I mean, I'm worried about the doctors that are retiring or need to retire and just can't, and the students that are coming through right now. How do we get through that time frame until we've got students like Kane who are actually training students?
Look, thank you very much, Senator. I guess, so first thing is, if only there was one big lever we could pull, then we would all pull it. And then the other observation I think I've shared with people is that just because it takes a while doesn't mean you shouldn't get going. I mean, the best time to plant a fruit tree is 20 years ago. The second best time is right now. And so in a sense, there is an imperative of investing in the future so that we do get it right. And you have a lot more domestic pipeline coming through. We will continue to need, as a nation, to rely upon supplementary labour from overseas. I think that needs to be very deliberately tailored and reduced over time as we scale up domestic supply. And I think that the scaling up of domestic supply needs to be done very deliberately and on a whole of government basis. One of the difficulties for us as a country is that in an activity-funded public hospital system, for instance, or indeed activity funding that occurs anywhere, be it fee-for-service or Medicare or whatever, there is a great perversity in that public hospitals, for instance, require a very large number of junior doctors to fulfil service roles. A lot of those are in major hospitals in urban areas. If you turn off, as we've done, acutely crank the tap off or substantially down of international supplementary labour supply, then you create, in a sense, a big sucking noise from the cities that's going to draw a lot of of domestic graduates into cities. So we do need to do something quite deliberately to reduce the reliance of our major city hospitals on junior doctor labour. I think we do need to, very urgently, I think, provide a obvious, attractive career option choice to, Kane's graduating this year, he'll be off into internship. They oftentimes, junior doctors in large hospitals, there will be, for one reason or another, a lot of influence brought to bear that will often persuade people away from rural and general practice. And so we need to make sure that Kane and his colleagues can see the light on the hill still whilst they're, on the wards. And so that's important that remains. For instance, typically in a second or third year out, not very far away, graduates would be looking at, maybe I might be interested in general practice. Here, I'll go into short-term employment with unfavourable remuneration, with no transferable entitlements, no maternity leave or benefits. Or I could stay in the public hospital system and do well-paid shifts in an emergency department and have all of the above. Why would I choose the former? And I think that is the sort of choice facing smart, ambitious people at critical junctures of their training and lives and careers. And we can and should be doing things now that tip the balance at least substantially towards making attractive employment and indeed life and work as a GP, and in our case as well, in regional Australia, the broadly skilled GP, the do-it-all rural generalist, a really visible and attractive career. And that's been our experience at JCU. Lining those things up really works. It's not it's not mysterious. The things we can do are quite practical and tangible.
Thank you. And I know other senators will ask you about why your program works. I want to kind of cut to the chase around a very important issue, and it's the transition to the college-led training system. There are some parts of that transition that I understand JCU is supportive of, but some that you have some concerns around. And I just wanted to ask, what are those concerns? What should we be considering in that national transition to make sure that we heard from the college this morning, and I appreciate their evidence and their support, but what we've seen through your program is that if a program is based in a regional area and compromised by people who've worked or talked the talk and walked the walk, we tend to get better successes. So what are some of the concerns around that transition, and what do we need to make sure JCU or other programs like yours retains to be able to be successful in the future?
Look, thank you, Senator. Look, I guess first thing to say is that at the end of just over 20 years now of the Australian General Practice Training Program, so it's been there a long time, we certainly agree that there was, especially in more recent times, a lack of clear focus on outcomes, and there were, and the colleges, the accredited professional colleges, RACGP and ACRM, were too far at arm's length from the quality integrity of their training. So I absolutely accept that, and to the extent that college-led training means colleges assuming their proper role under Australia's national law and the accreditation system to determine standards, curriculum, the trainee accountability for trainee experience and outcomes. I absolutely support that. I think the question, however, is what is that vis-a-vis the need to produce regional GP and rural generalist workforce? It's different but related. Our critique really is that the role of colleges is in the former role, curriculum, standards, systems, etc. It is not primarily, no specialist college in Australia is primarily in the business of producing workforce, people, individuals with the right skills, the right place, the right models and so on the ground. And so I think, in fact, what we would want to see out of all of this is some focus on outcomes, both for standards in relation to fellowship and what it means to be a specialist GP fellow of either college, but on the other hand, delivering on public investment, a substantial amount of which is actually meant to be for workforce outcomes, and particularly but not exclusively for rural, remote and regional locations where the workforce needs are greatest. We have, as I said before, clear evidence internationally and in Australia that by lining up what we would call vertically integrated from school through med school, through the junior doctor phase and on into specialist training in one or other college, including general practice, requires a regional infrastructure and connectedness. That is what the evidence suggests. That's the role we currently play, and that's what we would like to preserve. And to that extent, we're speaking with, obviously, department ministers and also the two colleges as to how we might preserve that critical element of workforce production in and for the regions.
And what's the time frame around that? And when will those sorts of decisions be made? You're in negotiations. When will you know whether there is a negotiation in place?
I would expect, so there's a grant opportunity out for the two colleges to take a place in a new system in a leadership role of general practice education training. The detail of how that's operationalised out on the ground is currently under consideration all over the country, but more particularly in the unique circumstance of Queensland, where there's a university, the only university, doing the whole pipeline. And so that's active. We should know, I would imagine, Senator, perhaps by the end of the year or early next year as to where that might land. Okay,
great. And in the absence of other senators jumping in, I think I'm just going to continue asking some questions. You've just through the sheer numbers of people that are joining you today from all parts of Queensland, very far and wide, all the way up to Thursday Island, I see. What you've identified, I guess, there is the network of doctors that aren't just teachers but graduates that help mentor students and also new doctors. I wondered whether Bryce might be able to jump in and explain what that network of support has meant to you. You seem to be working some quite isolated places, and we've also got, I see someone from Burketown there. When you're in an isolated place, it is a difficult work environment, but how does the network of GPs that JCU provides helped you get to where you are now?
Thank you, Senator Green. Yeah, we're very remote here, up here in Thursday Island, and also in my practice location in Palm Island, where I operate out of the hospital and the general practice there. We often work in a very remote environment. Coming from Cairns as well, you'd be aware of all of the very remote locations around Cairns and into the Torres Strait and into Northwest. One of the unique things that JCU managed to do is to prepare their graduates for working in a remote area during their undergraduate journey and then through their GP training journey. James Cook University does that by embedding rural general practice training through every element of its curriculum. It makes sure that it teaches students in a unique subject, rural, remote, Indigenous and tropical medicine in second year, the particular challenges that they'll have working in these environments. It then exposes them to those environments in fourth year and sixth year. And then through the GP training pathway, inoculates GP registrars to working in these environments by letting them operate in remote situations with off-site support or with on-site support, as well as a robust group of medical educators and medical trainers. That means as a junior GP, I had access to Peter Antigue, who took me for lectures when I was a second year medical student. When I was just emerging as a fellow, I was able to be supported by Katrina through my journey in Winton when I was the Director of Medical Services there. And now that I'm working on Palm Island, I have the support of senior academics like Aaron Hollands and Lara Wyland, who are able to support me through my journey as I go from a practitioner of medicine to a medical superintendent and work more in the education and training side of my business. Through every step, JCU, by having a vertically integrated pathway, has near peers, people who I can touch base with and talk to, as well as distant ivory towers of experience, such as Richard and Katrina and Peter Ann, who can support me through the easy decisions and the hard decisions. You only get people who stay in their jobs when they're embedded in a pathway which has support at every level. And one of the wonderful things about JCU GP training is it works as a force multiplier to state government initiatives and other federal government initiatives to keep people based in their location. If you're a GP working at TARS in Townsville, you can not only rely on your, TARS is the Townsville Aboriginal and Islander Health Service, you can not only rely on your colleagues working in that general practice to support you, but also a collection of peers at James Cook University, ranging from academics to doctors to nurses to allied health professionals, to be able to give you meaningful support in your role. Having that embedded and structural approach to training and safety is one of the real multipliers that JCU gives. And it's certainly been one of the reasons why I've stayed in North Queensland after going to James Cook University, after growing up in Childers near Bundaberg, and then doing my training in Townsville, Darwin, Alice Springs, and then going out west to Winton, and then going out to the islands on Palm Island. It is one of the unique things that we have in North Queensland that we must work so hard to protect.
Thanks very much. I just have one last question, and I'm sure others will have a view on this to jump in on. We've been discussing today with a number of stakeholders all the various types of Commonwealth training programs, the different initiatives. There's lots and lots of abbreviations that we need a little guide for to understand. But one thing you point out in your submission is that there's a lot of overlap from some of the Commonwealth health workforce programs, and they can be, I guess, maybe working against each other or a little bit confusing sometimes. So what do you want to see in terms of the programs that are being funded at the moment, and how can we better, I guess, streamline those programs to make sure we're getting good outcomes, as you say, Professor Murray, concentrating on those outcomes?
Thank you very much, Senator Green. Look, I think I won't recite all of the acronyms, but you'd be disturbed to know that I know them. And indeed, every new person into the Commonwealth Department who comes into a leadership, I try and get myself involved in inducting them in the complexity of their own environment. Look, it's nobody's fault. What happens over the years is that there tends to be an accretion of programs, and medicine's complex. There's things you can do during a student phase, clubs, rural training opportunities, all of which are scholarships, bonded places. There's a variety of things that are all useful to do. There are various things you can do for graduates, additional spots in regional locations for international fee-paying students who are graduates. How a return of service might work for the bonded places. How you might get a few of the junior doctors out of hospitals and having some rural and general practice exposures. How you invest in general practice training per se in about 4 different flavours. How you might provide extra skills opportunities to either develop or maintain. Look, all of these things make sense in isolation, but if you jumble them all together as the giant set of acronyms, which I could recite to you, they make no sense at all. There is a severe lack of an overarching policy logic. What is the end that we have in mind? What are we trying to achieve? If, as I argue, we are looking to have a domestic, a supply of domestic graduates who willingly pursue remote rural and regional careers as GPs, rural generalists, and consultant specialists, then you wouldn't arrange the program pieces in the way that you do at the moment. And indeed, I'm sad to say, we don't even measure the outcomes. We measure process, how many placement weeks, and then the part of a suite of portfolio programs. You'll have a primary care strategy that's currently under consideration and development. You would think that workforce, i.e. GP workforce, would feature large in a primary care strategy. You might be disappointed to know that it doesn't. These things tend to occur in silos. It's a sort of feature of the way either side of government, to be honest, that these things go. It is just time, with the impact of the pandemic as an acute on chronic shock to the system, to maintain or increase the investment, but have a much greater accountability and constructive alignment of these different program interventions to achieve a stated desired objective, which we have not articulated at this point.
Thanks, Chair. I'll leave it there.
Thanks, Senator Green. Senator Hughes, I think you've got a question.
I do. Thank you, Chair. I was just wondering, in light of some of the other evidence we've heard this morning, Just with regard to the training and where it's taking place or being delivered, and where the students are, with regards to, MM1, 2, 3 versus MM6 and 7 with regards to rural areas versus outer metro and regional centres. Have you got a breakdown of those figures?
So this is GPs. So these are medical graduates training to be GPs, Senator Hughes. Is that?
Yeah. So where is this training being delivered?
Yeah. So look, the structure of the main piece of the GP training program as that exists at the moment, AGPT, Australian General Practice Training, another acronym, Senator Green, is that, and it's long-standing, it goes back over 20 years, is that half of the training needs to be outside of major metropolitan areas, meaning remoteness area 2+, and that's in the aggregate. How that's achieved is by carving up a number of these training slots into what's called a rural pathway place or a general pathway place. And there's a sort of competition to who might get a flexible training spot. And look, to be honest, the tendency then is that the applicants to the program perspective is that those who do not do as well as their colleagues get allocated the so-called rural training spot, which is more constrained and conscripted and less desirable to junior doctors. So it's again more lead in the saddles for the attractiveness of a general practice career. A lot of that, and it's a point that's really worth understanding, is the unintended interaction between the overseas migration dependence I spoke of before and the general practice training system that results in a very large proportion of those who are effectively conscripted to train regionally are in fact international medical graduates who have no choice, and that fills those slots. But that is not ultimately tends to result in a retained regional workforce. Again, with greatest respect to my colleagues who trained overseas and without whom the bush would collapse. But as a design of a program that's quite unintended, I think it's really important, Senator, to look at the sort of, if you take just a sort of a snapshot of where people are spread in a point of time, you'll get a point of view. If you take out of that the international medical graduates who often don't have a choice, then ask the question, well, how many domestic graduates are pursuing careers? And then how many of those are able to stay on? It's a very different picture. You're quite right that oftentimes...
Professor, what I'm just trying to get a sense of, because one of the things we're hearing is that there's regional, challenges, and there's outer metropolitan challenges, but the real great challenge that's being faced is rural and remote, so areas that will be classified 6 and 7. And I'm just trying to understand your program, and I know it's received substantial Commonwealth funding to run, and it's obviously had some great success for Northern Queensland, but are we talking 10%, 20%, 30% of those undertaking this training, are they going into areas classified as 6 and 7? I'm just trying to get a bit of a ballpark figure.
So look, I can come back with you on a precise figure. I'm going to say that in RA 6 and 7, Peter Antigue, you might be able to help me here. I would have thought that probably numerically at any point in time, that would be perhaps 15% or thereabouts.
Okay. If you can just take it on notice, that would be great, because I just know that the pressures that we've been hearing about are particularly rural and remote, and so it'd be just interesting to see how the program is sort of lining up with that.
So that's true. The other thing I'd say is that we're also tracking what happens to people after they complete training. I think that's perhaps the even more important question. Where are people?
Step by step, yeah. Anyway, thank you, Chair.
Thanks very much, Senator Hughes. Look, I think we've got no further questions. Look, thank you very much, Professor Murray, and all of your team. It's been really valuable to hear from you at the coalface of training GPs for regional and rural areas, and your evidence has been of great value to the committee. So if you do want to add some further information and in response to questions on notice, could you please get them to us by close of business on Thursday, the 18th of November? So once again, you're on mute, Professor Murray.
Yes, the famous saying of the last 2 years. Look, the other things I might just flag, and we would certainly welcome it. I think the piece that we haven't really touched here is the importance of the Aboriginal and Torres Strait Islander agenda for us, for regional Queensland, indeed for Northern Australia and the country more broadly. It's an area in which obviously we're very deeply invested. Katrina Felton-Bush here today leads that component of the JCU program, both for general practice and also more broadly. I think there are numbers of elements of the GP training, and indeed we've had many of our medical graduates and indeed GP fellows who are themselves Aboriginal and Torres Strait Islander practitioners, but also just as importantly, ensuring that GP fellows and graduates have the technical and cultural competence to practice in, with and for local Aboriginal communities, I think is really important. Look, I just commend Katrina's perspectives on this, a very experienced and senior Indigenous academic, living, working and practicing and breathing this stuff, Katrina. You've got great perspectives, and I'm sure if the senators are keen to learn some more about, we'd be delighted to come back.
Well, look, I mean, I've just been told that our next witnesses, because we had said that we were going to continue with you until 1:30, that we're only just getting them online. So if you did want to share something over the next, just a couple of minutes now, that would be really appreciated. And thank you for bringing it up, because it obviously is a critical issue of great importance to this community.
Thank you, and that puts you in the chair, Katrina.
Katrina, you're on mute.
So I get to do the mute thing too. Sorry about that. So look, Senator, as Richard said, we're really invested in Aboriginal and Torres Strait Islander health. I've been working in this area for 20 years. I actually come from Mornington Island, and I'm coming to you today from my grandmother's country, which is Burketown. We live and breathe this stuff. I've worked rural and remote for most of my career with JCU. I think the important things are to think about the enduring disadvantage in our communities, and the fact that we need to have more doctors out in that's the biggest gap in our footprint, is our large communities. We've got Aboriginal community controlled health services that have been asked to do transition to primary healthcare, so they're taking on the bulk of primary healthcare work in these regions without a workforce, and so the costs of getting locums and trying to run these with other sorts of models is a real issue. So my job in GP training is to work primarily with everyone, obviously, but we have great partnerships. So partnerships is the key to a lot of the work that we do. So we have really strong partnerships with Aboriginal community controlled health sector in Queensland. We obviously service 20 plus Aboriginal community controlled health service throughout our patch. We have cultural mentors within those services that provide the cultural education and support for registrars, as Professor Murray said, to become more not only clinically competent in Aboriginal health as a discipline, but also with cultural mentors, the cultural capability that they need to do their job. So obviously, we also graduate Aboriginal. I think we've got 6 Indigenous fellows that have graduated through the GP program at JCU. We've got 25 of our Indigenous medical students coming through, and we work very strongly with schools and other areas of the university to get that pipeline that Professor Murray and everyone's talking about. This is the important thing. We need to get more kids into medical school and into GP training that can go back into our communities, understand the challenges and want to be part of the solution. So hopefully I'm covering off on lots of things that are really important about the work that we do. The research component, as these are things that we've already mentioned in our submission. We need to have more research in terms of the evidence to support what we're doing, but we know it works. We live and breathe. Most of us we're all the true believers. We live and work in these areas to provide that training. Happy to answer other questions.
Thanks very much, Associate Professor Felton-Bush. Yes.
I wonder, Chair, if I might just, I'd like to return to that question of Triple M if possible, just to say two things. The one is that the Triple M, the Modified Monash, whilst useful in many ways, doesn't actually tell the story that needs to be told, which is, for example, I'm in Roma in Southwest Queensland. We just had a workforce meeting this morning. It is classified as a 4, but it might as well be a 6 or 7. The workforce shortages here are acute and dire, and there is a cliff that this community is facing at the moment in terms of primary care services. So whilst I understand the focus on 6 and 7s, I sometimes worry a little bit that we're not necessarily being place-based about, what does this place need, this community controlled service, this, what's the wraparound that this community needs, no matter what the triple M, whether it's 3 to 7. So I just wanted to say that. And also to the other bit, this part 2 of that was that the more remote you go, the more the poorer served it is in terms of workforce, the more the burden of supervision is. And I know you will have heard that, but if you are 1 or 2 doctors in a town and you want to, as Bryce was saying earlier, you put your hand up, you want to support, train, mentor, to do that all the time is exhausting and takes a lot of time and takes you away from clinical care. And if you're not seeing the outcomes on the other side, which is what Richard was talking about earlier, you're not seeing the return for investment year on year on year on year. It's pretty dispiriting to community. So I think, not to end on a bad note, because Richard wants to be solutions focused, and there are solutions and there are ways of doing it. It's just trying to join it up to deliver it in a coherent national way that I think is our plea. It is stop the incoherence, stop the, bring it together, base it on evidence, and have an outcomes framework that is meaningful, that is not about processes, but it's about outcomes. And I think as the Senate, as the Commonwealth Senate, you have it's within your gift to really influence that. Thank you.
Thanks very much, Associate Professor Teague. And I think that's a very good point to end on. And yes, the value of this committee. So thank you again for your contribution towards this committee's work and this hearing today. Thank you. So look, I now welcome representatives from the Pharmacy Guild of Australia via video conference. So thank you for appearing before the committee today. Sorry, we're running a little bit late, but not too badly. So I'm Senator Janet Rice, the chair of the committee, and we've got Senators Green, Hughes, Askew, Urquhart, and yes, we've still got Senator Patrick with us as well. So in order to start, could I please ask you to please state your name and the capacity in which you appear for the benefit of the Hansard transcript.
Thanks, Senator. Simon Blacker, Pharmacy Guild of Australia, ACT Pharmacy Guild Branch President.
And I'm Claire Baker. I'm the Senior Pharmacist, Clinical Governance and Workforce for the Guild.
Thanks very much, Mr. Backer and Ms. Bakama. So can I ask you to do your best to speak clearly and identify yourself each time you speak? Although with only 2 of you, I think we probably can keep track a bit better than with some of our other sessions to help us with the recording and broadcast of these proceedings. So I now invite you to make a brief opening statement, and if you could make it brief, that would be really appreciated. We have read your submission, if you'd like to do that, and then after that, the committee will ask you some questions.
Thanks, Senator. Simon Blacker. I would like to acknowledge the traditional custodians of the lands on which we meet today. I pay respects to elders past, present and emerging, and today I join you from Ngunnawal country in Canberra. Thank you for the opportunity to address the committee on this matter. My name's Simon Blacker and I'm a community pharmacist and pharmacy owner. I'm National Vice President of the ACT branch of the Pharmacy Guild, as well as Chair of the subcommittee, Community Pharmacies for Rural and Indigenous Australia. I've grown up personally in rural Australia in Lake Ageligo, a country town of 1,500 people in the middle of New South Wales, where there has always been a pharmacy, but at times no GP. And I have worked in rural communities. I am a part owner with other pharmacists in pharmacies in Parkes and Dubbo in country New South Wales. And I understand the issues and challenges and opportunities for rural health and for the people and health professionals in rural communities. Today, I'm accompanied by Claire Beckemer, who is our Senior Clinical Pharmacist for Governance and Workforce at the Guild.
Thank you. So the Pharmacy Guild of Australia is the national peak organisation representing community pharmacies, owned and operated by registered pharmacists, and providing access to medicines and primary healthcare services to all Australians. The community pharmacy network is geographically dispersed with over 1,850 pharmacies in modified Monash model 2 to 7 areas. 66% of Australians living outside capital cities are within 2.5 kilometres of a community pharmacy. This makes them a vital component of the health system, especially in rural and remote locations where they may be the only health professional in town. And there are more than 400 pharmacies in towns where there is only one medical centre or none at all. Like other health professions, community pharmacy is experiencing significant workforce issues, most prominent in rural Australia. This is a major contributing factor to the lack of access to health services experienced by Australians living in regional, rural and remote areas. So we'd like to highlight two key elements from our submission. Firstly, the Guild believes that service gaps could be addressed by pharmacists working to their full scope of practice due to their extensive professional training, skills and knowledge. Pharmacists are being underutilised primarily by legislative barriers currently limiting their scope of practice. Rural pharmacists working to full scope of practice will contribute to increased access to medicines and primary healthcare services in areas where medical services may be overstretched, limited in hours or unavailable. With a shortage of GPs in regional and rural and remote areas, future strategies need to be comprehensive and adopt an approach that looks at a suite of solutions that is not focused on one health profession, but how local collaborative models of care, utilising all clinicians working to their full scope of practice, can meet the health needs of their community.
Secondly, the Guild believes there needs to be an equitable approach to support funding of rural primary health care workforce policies and programs. The stronger rural health strategy is focused on general practice. The Workforce Incentive Program practice stream provides support for a general practice to employ allied health professionals, including a non-dispensing pharmacist, potentially diverting the available community pharmacist workforce and risking sustainability of the local rural pharmacy. Whilst there are a number of community pharmacy workforce programs funded through the 7th Community Pharmacy Agreement, these are not in the same quantum as GP workforce programs. The Guild believes the rural workforce strategies need to be holistic and equitable across all health professions to ensure Australians living in regional, rural and remote areas have access to the breadth of primary and allied health practitioners and services as those in the city. Thank you. Claire and I are happy to expand on the issues raised in our introduction and answer any questions the committee may have.
Thanks, Mr. Blacker and Ms. Beckemer. I'll hand over to Senator Green.
Thank you very much, Chair, and thank you both Simon and Claire for joining us today. You wouldn't be surprised to know that one of the reasons you've been asked to join the committee today is to talk about scope of practice and how that could alleviate some of the pressures on GPs in regional and rural and outer metropolitan areas as well. First of all, I just wanted to sort of ask what the experience has been during COVID. I know pharmacists are now administering the vaccine, but that wasn't an easy process to get to that point. As I understand, there's a lot of negotiation to get there. What's been the experience so far, and how are pharmacists delivering the vaccine to people, particularly in these remote areas?
Yeah, so Senator Green, certainly you'd be aware that it was rural Queensland where community pharmacies were first involved with the COVID vaccination rollout with regards to AstraZeneca. And pharmacies have been involved since June with a wider range of pharmacies across Australia involved as of about August. Community pharmacies were excited to participate because it's our natural inclination to want to help our local population and community, and the accessibility points of community pharmacies. And in the early phases and late phases of the COVID vaccination rollout, the opportunity to have a potential walk-in vaccination rather than by appointment certainly allowed community pharmacies across the nation to help lift vaccination rates. There are a portion of our population who, for certain reasons, may not have a regular GP or particularly may not have access easily to a GP to get an appointment. And so pharmacies have filled that gap. And I suppose anecdotally, with the rollout of AstraZeneca being, somewhat controversial at times, or marred by certain themes in the media, we believe community pharmacies have helped turn that conversation around with regard to AstraZeneca, and have helped convince people that the first vaccine that you could access was the best vaccine for you, and we've helped lift vaccination rates as a result. Claire, was there anything you want to add with regard to the COVID vaccine rollout?
No, I think, as you said, pharmacies were really excited to be involved and to support their communities, and but they're tired, they're burnt out, and I think it'll be interesting to see how much we can continue to do. I just wanted to say we heard today 1.75 million vaccines doses given in community pharmacy for the COVID-19 rollout.
Senator Green, I can give you one example of just
I've got
the
a few
challenges.
Sorry, Mr.
My apologies.
I do want to, and thank you. That's an incredible effort. 1.7 million vaccines. You might be preempting my next question, so I just want to hope you're not doing that. I've got some questions about workforce for pharmacies generally, but we'll get to that. That's my third question. The only other question I have is on scope of practice. Where is it up to? I know that this has been a discussion around what was the COAG Health Minister's table. I don't know what it's called now under National Cabinet. In Queensland, as you know, you can get a UTI prescription over the counter, and that was a decision of the state government. But that isn't sort of a national framework. How are we progressing scope of practice, getting more prescriptions over the counter so that you don't need to go to a GP and get a script the same way at the moment?
So in recent times, the Pharmacy Guild have a scope of practice document or paper that is part of our national strategic plan. So we'd certainly be happy to share that document with any of the senators on the hearing. With regards to scope of practice, we are regulated at a state and territory level, of course. So we look as community pharmacists where we practice. We look to Queensland as an example where they have this trial happening. You mentioned the UTI trial for uncomplicated UTIs, where there's a process to follow to allow prescribing and the supply of antibiotics. So that a person who may not be able to get in to see a GP, a lady, is actually able to access that sooner. But it is a patchwork, to be honest, where you have different experiences, and even Queensland versus New South Wales versus the ACT, where you cross a simple border and you have different regulations. So we remain committed to having pharmacists operate at full scope of practice. We trail other OECD nations with what pharmacists can do. We look to places such as Canada, where they do operate at full scope of practice, and in regional but particularly rural and remote locations where there is a lack of workforce, the Pharmacy Guild believes there's a real opportunity for community pharmacies and pharmacists to play a greater role in looking after patients' health and to give patients that flexibility and choice, so that they may seek other options if they can't see a GP. An example personally, Senator, was as an intern pharmacist in Forbes in Company New South Wales, I was taught to use an otoscope to look in the ears of infants, and not necessarily newborns, but infants and toddlers for ear infections, because a wait time would be 2 weeks to see a doctor. And so we were taught to triage so that we could work more closely with the local GPs who had limited appointments. Certainly, if there was an opportunity for a pharmacist to provide a prescribed treatment that's better than what we can do now, that's an example of, I suppose, working to scope and assisting local population where there's a challenge to get in to see other health professionals. Claire, with regard to scope?
Yeah, I'd just like to add about your specific question about being able to extend a prescription. So continued dispensing has been extended now till the end of June, I think 2022, which is a great announcement, but we would really love to see it permanently. It's just one aspect of us being able to safely consider the person that's in front of us and solve their problem. If they can't get into their GP, if they can't access their prescription, we can make a clinical judgment as to whether it's safe to continue that for an extra month supply, if you like. So we would like to see that, implemented permanently. There are some limitations with that where some medicines aren't included. And for example, CTG scripts aren't included in that. So, Aboriginal and Torres Strait Islander peoples are actually being disadvantaged and don't have the same access through that continued dispensing program.
Okay, and just on the workforce issues, that's my last question, Chair. It's just, we've been talking a lot about not being able to find enough GPs and the pressure that's putting on current GPs. They're worn out. I hear the same thing about pharmacists in rural and regional Australia as well. It's really hard to get pharmacists as well. Is that what you're experiencing on the ground?
Yeah, Senator, that was always the case, and it's just been exacerbated through COVID with restrictions in travels across borders, but also people having to isolate from time to time, and just the continuous pressure of continuing to provide an essential community service in the pharmacy when there is COVID circulating. So, for an example, I speak to the owner of the pharmacy in Burke, Peter Carruthers, from time to time. My sister locumed for him quite recently, and Peter had chosen not to vaccinate with COVID vaccinations because he's the only pharmacy in a larger distance, and he viewed himself as need to protect the essential service he provides with regards to PBS supply and medicine supply and servicing outlying areas. So everyone's looking for a pharmacist, and I think that is going to continue to be the case. I don't see that changing anytime soon, and I suppose the Pharmacy Guild are keen to investigate areas where we can have funding opportunities to entice young or pharmacists from the cities to travel. There are a couple of pharmacies in Broken Hill that successfully attract workforce by targeting universities for pharmacy student placements. And they've remarked that with COVID and the lack of student placements through that time, that they are now experiencing a shortage of pharmacists. So the lockdown has had an impact, but we do have an ongoing issue, and we can't expect a different result by doing the same thing over and over again, and hence our submission to suggest that we do need substantive changes in regards to workforce opportunities for pharmacies in rural and remote areas. Claire?
No, nothing additional from me, thank you.
Thanks, Chair. I'll leave it there.
Thanks, Senator Green. Senator Hughes.
Thank you, Chair. Really needed kind of covered off a lot of the stuff that I was going to ask you. So just following on for that workforce issue with particular regard for rural pharmacies, do you think something like looking at a skilled migration program would be an option to improve workforce issues?
Senator Hughes, we are strong supporters of that. There have been changes. I might let Claire talk to that in a moment. There have been changes in that space, but whenever, certainly as a rural pharmacist previously, we rely on any avenue to find pharmacists to help with the work that we do in our communities. And I know of many examples where pharmacists who have immigrated from overseas are open-minded to go and work in regional, rural, remote areas. And I have a guild colleague from South Australia who has the pharmacy in Cooper Pedy, and her family's originally from Pakistan. He's now attracting colleagues from overseas to migrate to Adelaide and then go to rural South Australia. So you have these unique stories that help relieve challenges in certain areas, but we need more of that. Claire, with regard to immigration, did you have a comment?
Yeah, I'll just add to that in that currently the pharmacists are on the short-term skilled occupation list. Recently we were added to the priority migration skilled occupation list, which obviously just expedites that visa processing. But the short-term skilled migration does not really help solve the problem. The pathways to permanent residency are limited, and so therefore we're not attracting skilled pharmacists from overseas. So we really need to be on the medium long-term skilled migration list, and that's what we're certainly advocating for. So just opening up the options and the attractiveness of Australia for these skilled migrants. There is a pipeline issue as well in terms of the professional requirements that they'd need to go to be able to practice in Australia. So the benefits for the employer is only seen 1 or 2 years down the track, and because of the temporary nature of the current visas, they only get value for maybe 1 or 2 years beyond that. So we see that the medium long term strategic skills list is the only option to help us solve this problem.
Okay. And again, also following on from Senator Green, interested, you gave some examples of full scope of practice activities that would help rural communities access the healthcare when they need it. So I'm just interested in your take. I know the TGA has recently blocked the contraceptive pill being able to be dispensed via pharmacies, while the higher strength morning after pill is freely available. Just wondered if you had any comments on those sorts of medications that could potentially, particularly when someone was already prescribed it, be on sort of a continual prescription or an ongoing fill rather than requiring recurring doctor's appointments.
Claire, are you happy, as a female pharmacist, I'm happy for you to take that one.
Yeah, absolutely. I think we were disappointed with that, with the interim decision about the oral contraceptive. We've safely provided emergency contraception for years now, and often in that discussion, we talk about contraceptive options. The oral contraceptive pill to sort of continue that supply, in a safe manner through protocol, and referring back to the GP after a certain period of time to make sure that thorough risk assessment is done, or their health is maintained. That would all be part of that protocol. And also we to be able to prescribe or to suggest long-acting reversible contraception, is something that we do in the conversation, but to be able to then prescribe that would be ideal, and also give access to people to women early and when they need it, especially when they can't see their GPs.
All right.
Senator
Thank you
Hughes,
very much. That's all for me, Chair.
Thanks very much. Mr. Blacker, did you want to add something to that?
Thanks, Chair. Senator, I was just going to add to Senator Hughes' question with regard to scope. An example that's not so far. It's not rural or remote. It's regional. I'm aware of a prostate cancer sufferer who is in the end stages of life, who's required to travel 150 kilometres to Culburra to have an injection administered. A simple injection administered for their cancer treatment, because there was no prescriber near where they live inland of the coast, and it was a simple injection that a pharmacist potentially could give if our scope was allowing of that. And it's an example of looking at putting the patient's interests at the forefront and giving a local solution wherever possible through scope. And I think examples like that demonstrate where there's an opportunity in regional rural remote areas for pharmacists to do more to assist patients and to give better health outcomes, or an increased quality of life.
Yeah, well, considering you give COVID vaccinations, flu vaccinations, you'd think you could do that.
Yes.
All right,
Thanks very much. Thanks, Senator Hughes, and thank you, Mr. Blacker and Ms. Bakima. Your evidence has been very useful for the committee today. So, look, I think we're still waiting to get our next witnesses online, but I think we've got the Primary Health Network Cooperative, so we'll kick off, and hopefully we'll have the National Rural Health Commissioner join us very shortly. So I welcome, let's see if, yes, Mr. Matt Jones from the Primary Health Network Cooperative, and thank you for appearing before the committee today. I'm Senator Janet Rice, the chair of the committee, and we've got with us Senators Green, Hughes, Askew, Patrick and Urquhart. So, to start off with, can you please state your name and the capacity in which you appear for the benefit of the Hansard transcript?
I'm Matt Jones, I'm the CEO of Murray PHN, and I'm representing the Primary Health Networks today.
Great. So look, I'll invite you now to make a brief opening statement, and then hopefully by that's the end of that, we may have Professor Stewart with us as well, and then the committee members will ask you some questions.
Sure. Thank you for the opportunity of speaking to the inquiry. I think this is a really important inquiry into a really significant issue that I think has been part of the health landscape for quite a while, but the solutions haven't been readily available. In essence, I think we need a health system that recognises the different contexts of health need and capacity to address that need. I think that there's specific issues in outer regional peri-urban communities that require more coordination to address increased access given growing populations. That's a different context to the regional and rural areas where it's categorised by small populations with limited access to primary care services for a range of different reasons associated with the viability and capacity and scale. And that different again from the remote context, which is characterised by very small populations in small, very long distances away that make it difficult to have wholesale or significant health care. And there's a range of other challenges associated with that. We need a system that is more responsive to the health needs, that involves more coordination and the ability of being able to have more funding and policy that recognise the different contexts, because our Australian healthcare system seems to work best where we've got large populations in close proximity with economic capacity. And that doesn't describe much of regional and rural and remote Australia. Additionally, we need team-based care to address the needs of our communities. We've got chronic disease, mental health, a range of conditions that require the complement of the Australian healthcare system, which is extremely difficult to provide in locations of small-scale services, small populations and large distances from other areas. And additionally, the third part that I really wanted to emphasise, not only do we need team-based care, but we need team-based settings for the delivery of the care. We've got a changing environment for which healthcare practitioners are wanting to work. They're wanting the professional support, the career opportunities, and the ability of being part of a team. Again, very difficult to achieve in small-scale entities. We need to build scale at a regional level, not only to enable more access to the type of primary care services that our communities need, but to develop a model that enables the provision of a sustainable and viable primary care system, coordinated, organised according to the needs, but an attractive career prospect, one that's rewarding and enables the recruitment and retention of practitioners that we're finding so difficult in regional Australia.
Thanks very much, Mr. Jones. I noticed that we had Professor Stewart with us, who has just ducked away. Yes. You're back, Professor Stewart. You're on mute.
There we go, sorry.
That's okay. Look, and sorry, our timing is a bit, we're juggling things today, so thanks for joining us. So could you please state your name and the capacity in which you appear today?
I'm Adjunct Professor Ruth Stewart. I'm the National Rural Health Commissioner for Australia, and I'm here in that capacity.
Thanks very much, Professor Stewart. And did you wish to make an opening statement?
Yes, thank you. So I know that there are many people who have talked today about the maldistribution of general practitioners across Australia. We don't have a problem with the number of doctors we have in Australia. We have a problem with the maldistribution, both through which specialties our new doctors are choosing to enter and also where they're choosing to practice. I want actually to focus on the things that we know can make a difference, because the difference between now and 10 years ago is that we actually now have a lot of evidence about what will make a difference, and there are some easy things, there are some things that we could do that would make some moderately rapid changes, and there are things that we need to put in place to create a sustainable rural workforce. The things that we could do that would make a faster change than most interventions is to significantly increase the opportunities for junior doctors to have work experience, training work experience in rural and remote communities, both in hospitals and in community practice. Community practice in general practice and in rural hospitals. We know that about 35% of doctors, new graduates from Australian medical schools, say that they're interested in working in rural and remote medicine, but we're not seeing that translated into rural doctors. There's some very clear evidence from somewhat old data now from James Cook University, where they looked at their first cohort of first 5 years of students and said, where are they working? And they found that the site of internship had a profound influence on where doctors go to work. And you can turn a rural origin student who's had 6 years of rural medical education into an urban doctor by giving them a year of internship in a metropolitan hospital. Now, I put to you that we're hemorrhaging the investment that we're putting into the education of these young people by not providing them with rural internships and rural training opportunities. If we can significantly increase, double, triple the number of internships in rural and remote communities for junior doctors, we would translate that 35% into a much larger cohort of rural doctors within 4 to 5 years. Now, you might think that's not soon enough, but if we do any of the other options, you don't create a sustainable rural workforce, nor do you create the workforce that rural Australians need. There are particular skills. We've thought long and hard about what those particular skills are. We have a training program for it, and we even have the scope of practice. It's called rural generalism. We know that if a doctor is trained with the skills and competence to work and confidence to work in rural and remote Australia, they are much more likely to stay. So that's what I want to see. So if we can connect the pipeline from rural undergraduate training to rural junior doctor training to rewarded and recognised clinical practice as a fellow of a general practice college with the specific skills of rural journalism, we would have a very dramatic improvement in our rural practice, in the rural workforce that we have in Australia. So I would encourage you to look at those options, please. There's strong evidence to show that those interventions will work. There are lots of things that seem easier and faster, but there's not a lot of evidence to show that those rapid things will actually make the sustainable difference and will provide rural people with the care that they want and need. Sometimes I hear students and junior doctors saying about their rural practice, everybody just keeps saying, how long are you going to stay for? And it's sort of told as an anecdote. It's a bit funny. Look, like many of you that I'm talking to, I'm rural born and bred. I've worked, for all of my career as a rural doctor, and I know the impact it has if somebody stays on and gets to know the community and their patients. I think it's the absolutely most rational question that patients can be asking of a new doctor who's turned up in town. How long are you going to stay for? And what I want to see is us putting in place policy that will encourage them to stay, make them feel comfortable to work in the environment of rural medicine, and confident that they have those skills and they know what to do when the proverbial hits the fan, which it does. And as a rural doctor, you can be one of the few people there, which brings me on to my next point. We focus a lot on the doctors. It's sort of like they're it's almost like the word key predator almost. They're the signifier, the canary in the coal mine. Doctors do their best work when they're part of a multidisciplinary team that's comprised of nurses and allied health practitioners. That can be Aboriginal and Torres Strait Islander health practitioners. It can be nurse practitioners, pharmacists, physiotherapists, psychologists, dietitians, podiatrists. If we as doctors work in a strong team, you don't need as many of us for a start, because we're not doing stuff that other people can do better than we can. And we're providing much better care for our patients. Look, I'll stop there. I can keep on talking.
Thanks, Professor Stewart. Yeah, great. Leaves us a bit of time for some questions. So, look, I'll hand to Senator Hughes to begin the questions.
Thank you, Chair, and thank you, Professor Stewart. You've certainly covered off on a couple of these programs, but just even sort of quite succinctly, maybe you might be able to let us know. We've heard of new programs being suggested today, older programs that have been rolling out previously. What are the tried and true? What is actually working at the moment, and any of the outcomes that we're seeing that are helping to address these issues?
So I need to declare that I was previously employed by James Cook University, but I went there because I could see that they're actually making a difference. What they have proven by preferentially selecting rural origin students from their patch, by having an explicit rural curriculum within their medical education, by linking with postgraduate vocational training, they've shown that if you provide that linked up pipeline from high school to a job, you will have doctors who will stay in rural and remote communities. So those are the things that we absolutely know work. Enrolling rural students, giving them educational experience in the rural communities that you want them to work in, making sure that those positions are well supported and educationally rewarding. You can't just sit someone in the corner of a clinic and say, just watch what happens. Students learn best by doing, and they can contribute to the whole multidisciplinary team. So, and then giving those new graduates jobs to go back to in those kind of communities. They then aren't lured away by the big lights of the city. I can tell you, 35 years ago when I was a junior doctor, I had so many consultants saying, oh, you're clever, you're smart, why don't you become, a paediatrician, an obstetrician, an emergency physician, something special. But I was a rural kid who'd been impressed by the doctors in my small community, and I wanted to do that. I wanted to be that kind of person for my community. So those are the major things that work. We also know that if a doctor is not sure whether they want to go rural or not, You know, we have some doctors who are absolutely committed to becoming some students who are absolutely committed to becoming a rural doctor, and you know, like me, who are hard to divert. But really, the majority of new graduates are not quite sure. They think probably they want to be a rural doctor. We know that with that cohort, the Mabel survey data tells us that if you show them that they can, that there are attractive packages, so that's financial reward and also professional recognition, that helps, that supports. So that's an attraction, both an attraction and a retention. We have what are called workforce incentive payments set up within the sort of Medicare system, so that doctors who have provider numbers can be rewarded for the kind of activity we want to see. I would really like to see that leveraged more to reward practice in rural and remote communities. Recognise and reward after hours care within a hospital, emergency care, obstetrics, anaesthetics, surgical work as part of your job as a rural generalist, and longevity of stay. My husband and I, when we were very junior doctors, went to a small town in southwest Victoria and saying that we'd stay there for 2 years. Within a year, we started noticing the difference that it made, that we knew our patients, knew the system, how much easier it was to work and how much easier it was to convince people to make the changes that we wanted them to make. And we said, oh, this is good, we should stay on for a bit longer. But what we found was that compounded each year, and made the work that we were trying to do more successful. And I'd really like a lot more of our young doctors to experience that. Experience the privilege of being deeply involved in transformational care of patients and communities.
Okay, thank you, Professor Stewart. Just one last question. Is the federal government entirely responsible for addressing this workforce maldistribution?
Oh, no, if it was, it would be so much simpler. So what we have a couple of issues. We have, you know, I don't need to explain to you that the federal government looks after the funding of primary care and community care, and distributes monies to the jurisdictions to run hospitals. Now, at present, most of the junior doctor training occurs within hospitals. So therefore, the jurisdictions are responsible for the training of junior doctors. I've already explained that we are hemorrhaging rurally interested doctors into the cities because we're not giving them enough junior doctor placements in rural and remote Australia. And it's the jurisdictions who can make that big change and ensure that those positions are supported. Now, I'm talking to you from Queensland. Queensland, many years ago, instituted what was known as the Rural Reliever Program, which said, oh, our poor rural doctors are overworked, need some holidays every now and again. We can send doctors out to help them. So they sent out first and second year graduates out to some of the most remote communities in Queensland to work. And I can't tell you the number of Queensland doctors of my vintage who I've spoken to who go, oh, I did a rural reliever once and I just went, I can't do this. Stuck there on my own without support, you know, and they tell horrific stories of really critical clinical incidents where they didn't know what to do and they didn't even know what their support structures were. So, yes, we need junior doctors doing rural and remote working in rural and remote positions, but they need to be well supported so that they have a positive experience and learn about the system rather than just be totally freaked out by it. Because it's the same. We wouldn't dream of putting an intern into a major metropolitan hospital emergency department and saying, oh yeah, look, the toilets are over there and here's a pen. You've got your stethoscope, start seeing patients. We wouldn't do it like that. That's almost what has happened in the past in some rural sites. So we must be very careful that we give introduction and support. Yeah. So yes, the jurisdictions have a large role to play in changing. So I've talked about the junior doctor positions. There's also the issue of recognising the skills and competence of that rural doctors need. If a doctor, if you don't feel that people are acknowledging what you're doing and you're working really hard, it's easy to get burnt out. If you're for it, and you're much more likely to encourage people to come and work with you and join your fraternity, really. So we need to recognise the skills of the rural generalist, reward it. I don't see why, if I deliver a baby for a mother who's had a prolapsed cord, so that's the baby. That's a life-threatening situation for the baby. If I do the caesarean section for that baby, I get paid less than a doctor in a major hospital. We need to recognise the skills of general practitioners who do amazing stuff as a rural generalist. And if we do that, that will help retain those doctors who are there. So it's about attraction and retention. Thanks.
Thank you.
Thank you.
Thanks. Thanks, Professor Stewart. Thanks, Senator Hughes. So, Senator Green, you've got some questions.
Thanks so much. And just, I guess, leading on from that, around the interaction between the primary health network and our state hospitals. Sort of the flip side of that, I wanted to ask you, Mr. Jones, in regards to the impact that hospitals, that the GP shortages or lack of access has on our hospitals. You've mentioned that in your submission. I just thought I've asked a lot of questions about it before. Sometimes it's hard to get that acknowledgement or the data that relates to it. But are we seeing people head to the hospital, to the emergency department because they're not able to go and see a GP?
Thank you, Senator Green. So I think that phenomenon of lack of access in primary care resulting in attendances at unnecessarily or avoidable presentations to the acute system is apparent and certainly evident in regional Australia, exacerbated perhaps from COVID in terms of the changing landscape of how primary care is delivered with the increased demand. We do, as an organisation, as PHNs, we collect data in relation to clinical activity through the primary care system. And we also collect data around practice profiles in terms of changing capacity, in terms of numbers of GPs and the profile information associated with how the practice is structured. It's quite fluid. It's very dynamic, as you'd imagine. It changes regularly. But the reality is it's impacted the shortages of primary care providers in rural areas impacts in two ways on the acute system. I think it means that more people delay getting access to care earlier and results in people attending either delayed or directly to the emergency departments, urgent care centres of the acute system when it could be better serviced in the general practice environment. And in regional areas, often those GPs are also the visiting medical officers at the hospitals as well. So there's an infrastructural capacity issue on the health system as well, with shortages of primary care providers, which is also impacting upon the capacity of the acute services that are directly across the road in reality.
Yep. Thank you for that. And in your submission, you go through a number of case studies of primary health networks and some of the, I guess, the good wins and some of the challenges. Do you collect data on how many GP practices closed down in your PHN areas? Like over a 12-month period?
Yeah, so we have our role in coordinating primary healthcare is specifically not exclusively, but specifically focused on supporting general practice. So we have information around the number of practices, the way the practices are structured. That does change with the recruitment or the departure of GPs, and it does also result in changes in the number of entities, the number of practices, and the way that they're operating. So, Senator, we do collect that information routinely. It's important to enable us to provide the coordinating role that we're funded to deliver.
So perhaps on notice, can you provide for the 31 PHNs that there are nationally? Could you tell us if you had if you have the information now, that would be great. If not, later would be all right. How many GP practices in those 31 PHNs have closed over the last 12 months? And I'm also interested to understand whether you keep an eye on or measure any data in relation to GP practices that have closed their books, for lack of a better term, because what we're finding is, although there's quite a lot of GP practices that are still operating, they are not taking new patients, and so the fact that the practice is there or the GP is operating is being taken into account by department data or even PHN data. But if they're not taking new patients, then they're not open to be able to, for people to then go and access it, as well as if there was someone who's taking new patients. So I'm keen to understand if you've got that data as well.
So, Senator, we do collect data in relation to the number of practices in our respective catchments, and that does change. Some of those changes are associated with practices closing. Some of those are associated with mergers, amalgamations, the corporatisation of practices. Importantly, I suppose, that information is helpful for us in responding to the needs of the community, working with the primary care providers. So I think the information that's currently provided may not have the detail and description of the variety of different factors or elements that constitute the changing number. So, for instance, in our catchment region, we have 191 general practices. That number is likely to change over and has changed, and it's due to a range of different factors, but we report that total quantum through to the department and certainly capture that information. In relation to your question around closing books, again, we capture that information in our practice profile. It perhaps is reflective of an individual organisational approach, and I wouldn't necessarily say every PHN may have certainly have the same processes, but the understanding of the need of the changing environments for ways in which practices are operating, that it would be captured at some level. But again, it is a pretty dynamic environment. It can change according to the recruitment of a GP, for instance, and that number of practices opening books, closing books would be a fluid and evolving situation.
Sure. And then, Mr. Jones, respectfully, we senators, although we're not subject matter experts, are quite capable of having a look at complex data. And so if you do have that information, if you could provide it to the committee, if you need to, if that is data that you provide to the department, you could also let us know and we can ask them for that information. But we are really struggling to, I guess, understand the scope of the problem in certain areas. There might be areas where the number of GP practices have increased, but I suspect over the last 12 months there's been a significant change, and so we would really appreciate understanding that information. I just have one last question for Professor Stewart, and thank you. I know that there was some information you wanted to provide us during the estimates hearing the other week, but unfortunately we had the Minister in front of us, and so it was important to get him on the record on these issues. So thanks for joining us today. My only question in regards to, I guess, the way that the maldistribution, you said, and it really kind of struck me at the beginning, you said, we actually have enough GPs in Australia, we just don't have enough GPs in rural areas, and that this could take, 5 to 6 years to solve. I certainly appreciate that, but it does feel like we're in an acute situation right now. And I'm wondering if you've had any discussions or you've got any suggestions for the committee to consider over the next, 12 to 18 months to try to alleviate this problem as we come out of the pandemic, because I can tell you my community can't wait another 5 to 6 years at the rate it's going. We need to try to find long-term solutions, of course, but we also need to find some short-term solutions to ask the government or governments to act on.
Thank you, Senator Green. Look, I think that a short-term answer, we know that if we have more registrars in a community, they're providing services. They're doctors in training to become whatever specialty, but if we have GP registrars, in some parts of Australia, the GP registrars form a significant part of the health workforce, sometimes up to 35 to 40%. So encouraging junior doctors by giving them those early career internships and postgraduate year 2 work experience in rural and remote, that would make a difference, that you would see coming through in registrar numbers in rural Australia in a year and 2 years. The other thing that might entice, well, that has a reasonable chance of enticing doctors who have the skills to work in rural and remote out into rural and remote communities is to incentivise the kind of work that you need to do in rural. So I'm talking about providing after hours care, providing both community and hospital inpatient care, so that within the workforce incentive program, specifically rewarding that kind of activity, I think that would make a significant and quite rapid impact on the dearth of rural doctors. So those are the. So I'd like to see. I think I know that sometimes people think, well, we'll just make doctors go. The making doctors go. Doctors are very clever people. They know how systems work. They are incredibly clever at working out how not to do something they don't want to do. So in my experience, you can work really hard at getting doctors to do stuff they don't want to, and it doesn't work very well. We need to work out how to encourage them to do the activity we want to see. And I think that is both work in rural and remote, direct reward for working in modified Monash areas 3 to 7, and also rewarding the provision of inpatient care, emergency care, obstetrics, anaesthetics care, and also aged care facility care. Those are the things that would really significantly make a difference. And because what we hear a lot from the general practice community is that running a small business with the number of employees that you need in a general practice is tough going, and it's much tougher in rural communities, and the break-even point is much closer. So financial incentives do make a difference in private general practice. So I'd commend those to you via the Workforce Incentives Program, WIP, we often call it.
Chair, thank you.
Thanks, Senator Green. Senator Patrick, you've just got a follow-up question, I understand.
Thank you. Just it wasn't clear to me whether the PHN Cooperative took on notice to provide Senator Green with his information, the information she requested. Was that the case?
Senator Patrick, that's what I took away from the request, was that I'd be progressing through the PHN Cooperative the collation of the individual capture of information that occurs with each PHN.
Thank you. I just wanted to go to an issue that you raised with Senator Green, just talking about the merging of practices. We see right across various different sectors where entities are merging to get efficiencies by way of scale of economy. Is that what you're seeing, A, in the cities, but B, does that in any way ever affect rural and remote communities? I imagine it wouldn't. Just what's your view on that?
So I think you're certainly seeing that in metro areas, Senator Patrick, that there is practices coming together under a larger entity, and it often driven by the financial imperatives that Professor Stewart spoke of. In regional areas, I think it's also a potential issue or a growing issue in that the prospect of existing providers being able to sell the practice in a succession sense to a next crop of GP coming and willing to move to the area and work for long periods is less and less likely. So then one of the options that I would say is becoming more of a feature is the prospect of selling the practice to an existing corporate primary care provider. And I think I would be encouraging and exploring alternate and additional avenues to build partnerships and collaboration across existing providers rather than that as a last resort avenue, because I think it obviously has an impact upon the structure of the practice, the relationship with the local acute service, and I would think that there's greater opportunities and areas for us to strengthen partnerships between existing providers to build more team-based environments to enable a more attractive career prospect, more opportunities for employment and provision of primary care skills in an environment that is more supportive and financially viable. But the small-scale nature of private primary care makes it very vulnerable to not being viable and having to look for bailout options.
Okay, thank you. That's helpful. That was it. Thank you, Chair. Thank you, Mr. Jones.
Thanks very much. Thank you very much, Mr. Jones and Professor Stewart, for your evidence today. It's been of great value to the committee. And so, Professor Stewart, did you know?
No, that was a wave. Thank you and goodbye, Senator Rice. Thank you.
Right. And for questions that have been taken on notice, if you could get them to the committee secretariat by the close of business on Thursday, the 18th of November, that would be most appreciated. And so the committee will now suspend for a break and will recommence at 2:45. Chair of the committee, and I'm welcoming via video conference representatives from the Department of Health. Thank you for appearing before the committee today. I've also got Senators Green, Hughes, Patrick and Urquhart with us here today. Senator Askew, I think he's currently not with us, but will probably rejoin us again before the end of the session. I remind witnesses that the Senate has resolved that an officer of a department of the Commonwealth or of a state shall not be asked to give opinions on matters of policy and shall be given reasonable opportunity to refer questions asked of the officer to superior officers or to a minister. This resolution prohibits only questions asking for opinion on matters of policy and does not preclude questions asking for explanations of policies or factual questions about when and how policies were adopted. So to start with, could I please ask each of you who's with us today to state your name and the capacity in which you appear for the benefit of the Hansard transcript.
Thank you, Chair. Penny Shakespeare, Deputy Secretary, Health Resourcing.
Matt Williams in Tasmania, First Assistant Secretary, Health Workforce Division.
Martin Rocks, Assistant Secretary, Health Training Branch.
Dr. Susan Wern, Senior Medical Advisor, Health Workforce Division.
Louise Clark, Assistant Secretary, Rural Access Branch, Health Workforce Division.
Teresa Garondi, Acting Assistant Secretary, Health Workforce Reform Branch.
Nick Pasquale, Acting Assistant Secretary, Health Workforce Division.
Thanks, everyone. And you do seem to be a long way away, but hopefully we'll be able to. We can certainly hear you well enough. Just can't see you very well, at least with the little icon on my screen. Now, did you wish to make an opening statement?
Thank you, Chair. Other than acknowledging the traditional owners of the lands we're meeting on today and paying our respects to elders past, present and emerging, we don't wish to make a further opening statement, but happy to take your questions.
Thanks very much. Okay, look, I might ask Senator Green to start off with the questions.
Thanks, Chair. I just want to kick off with asking a few questions about the removal of regional bulk billing incentives. I'm referring to a change that came in 2019, and I just want to understand what was the justification for that removal?
Thank you, Senator. So bulk billing incentives do remain in place in rural areas. There were some locations that lost access to rural bulk billing incentives at that time, which were not rural areas. So they were areas in capital cities and I think some larger regional areas. But I might ask one of my colleagues if they can expand on that.
Sorry, the change in 2018-19 was due to a change in policy based on the geographical classification, and it utilised ABS geographic data.
Right, so this is the change for the way that GPs were paid additional incentives for children and concession card holders. How much did the government save out of that measure? What was the fiscal impact of making that change?
Sorry, we don't have that information here with us, but I'm happy to provide that on notice. Senator will check back at the budget papers from that time.
How many areas were affected? By the change?
I'll just add that up for you. Um, 29.
29 areas. Based on that change, are you sure? That seems like a low number. We might have to come back to that in the next couple of minutes.
Sorry, sure. If I could just clarify areas, the list I'm using here has, it doesn't list suburbs as such, it does for some. So for example, Balconnen or Frankston City, but in others it talks about the information I'm using has Eastern Outer Melbourne. So it's broad catchment areas rather than specific suburbs or towns.
Okay. We'll come back to that one. Did the department conduct or commission any analysis on the likely impact of that decision on the financial viability of affected GP practices prior to the decision being made?
So, Senator, we'll need to check back to see if we commissioned any external analysis of that nature. I imagine that the considerations were around ensuring that the rural incentives were better targeted to real rural locations. So where we had outer metropolitan areas that may have been being treated as rural areas, or we had areas that had changed under ASGS remoteness area classifications over time and were part of larger urban areas as a result. The intention of the changes would have been to make sure that the higher bulk billing incentives were targeted to areas that are more rural, more geographically challenged.
Sure, and I do have more questions. You'll notice that the inquiry is dealing with rural, regional and outer metropolitan areas. So these questions are about the impact of those changes on outer metropolitan areas. And my question was whether you undertook any analysis of the impact of GP practices in those areas. So if you could take that on notice.
Will do.
I'd also like to understand if the department conducted or commissioned any analysis on the likely impact of that decision on people's ability to access a GP in those affected areas. Do you need to take that on notice as well?
Well, we can look through the particular locations. I'm happy to have a look at the impact that that change may have had on access to services before and after the change.
Well, I'm interested in understanding what work you did before the change.
We'll have to take that on notice.
Yeah, and my further questions are, since the change, has the department conducted or commissioned any analysis on the impact on GP practices in those areas, particularly the access that people have to those GPs in those areas?
So the bulk billing incentives are primarily intended to support Australian patients in terms of improving their access to affordable services under Medicare. And we do know that over time, bulk billing rates have increased, but we're happy to have a look for you on notice at the bulk billing rates in the particular areas that may have been impacted by those changes.
This is probably a more direct question that it's you know, obviously if that analysis exists, I'd love to see it, but I just want to know if you've even thought to find out. Have you had a look at whether there's been an impact in those areas? Does the analysis exist?
We are constantly looking at the impact of changes that we make to policies. We're constantly looking at access to services. We have teams of people that are looking at data, Medicare services data, access to GPs, GP FTE data. So yes, we do have spend a lot of time analysing our policies, our programs, and access to the Australian health system by the community.
Is that, sorry, we can't see your name. Is that Ms. Shakespeare, is it?
It is, yes, Penny Shakespeare.
Yeah, so we don't have a lot of time today. My question was very clear. Do you know what the impact has been on that decision on the access of GPs in those areas? And if you don't know, I would like you to be able to say that.
Oh, we would know. I don't have that information here with me now,
Well,
and we're happy, as I said, to provide it on notice to you.
No, just interrupt. Can we please make sure that, because we can't see you very clearly, if before you speak, if you could state your name at the beginning of your statement.
That would be helpful. Now, I'd like to move on to some questions about the Medicare rebate freeze. Similar sort of questions. I'd like to understand, you know, what was the fiscal impact? What was the saving that the government got out of that Medicare rebate freeze?
So the Medicare pauses in indexation. I think there's a fair bit of detail set out in our written submission about this, as it was a particular area of interest to the committee. It's some time ago though now, so indexation has been in place for several years now. It happens on the 1st of July every year. Not for all services. We're not indexing pathology services, but for others. So specific information about the fiscal impact, I think, again, I don't have it here with me, but would need to take that on notice.
And I'd like to know whether the department conducted any analysis before that decision about the likely impact on GP services and access to GPs, because it's certainly been the evidence that we've received through this committee today, but also through submissions, that it had a significant impact on GPs in rural and regional areas.
So again, I think we'll need to take that on notice, because the first pause dates back, I think, to around 2012. So we'll need to look back through records as to whether or not there was assessment of impact done at the time.
Have you conducted any analysis on what was the impact? I mean, we've had a lot of evidence to suggest that it's had a negative impact on GP practices. Have you looked into whether that is the case, and how many GPs were affected by those changes?
So we have data about headcount of GPs, GP full-time equivalent numbers per 100,000 population. So from the period 2014 to the period 2020, which is data I have here with me, there have been increases across the country. So it doesn't look, from the data that we have over that period, that there has been a reduction in GPs, a reduction in GP services. As I said before, bulk billing rates have continued to increase.
Ms. Shakespeare, are you referring to GPs in Australia as a whole? Like the number of GPs? Because that's not really the question, is it? The question is what's happened to GP services in rural and regional areas because of the Medicare rebate freeze.
So if we look across modified Monash categories, so from 2014 through to 2020 in modified Monash 2, the GP headcount has increased from 2,072 to 2,529.6.
So that's the full-time headcount?
Oh, sorry, that's full-time equivalent.
Full-time equivalent. And that counts a GP that would have gone and worked, what, one day in that area? So, someone who's done a locum, or is it permanent?
Full-time equivalent. So my colleague, Dr. Wern, may be able to explain that better than I can.
Susan Wern. Thank you, Senator. Yes, on our analysis of that Ms. Shakespeare is referring to, it would record any work done by somebody who we have recognised to be a general practitioner. So yes, it would include people who were permanently in the workforce and those who are coming in just temporarily.
Yeah, so it would include people doing locums?
Yes, Senator, it would.
Yeah.
So I can keep going.
And it doesn't include, no, because I've seen the data, Ms. Shakespeare. I know, I've had a look at it, and the data you're referring to includes locums. It also, as we discussed in estimates, it doesn't have any indication in that data how many of those GPs have closed their books, does it?
So it looks at the number of full-time equivalent practitioners providing services, non-referred attendances under Medicare to the community. So that could be part-time doctors, full-time doctors, ongoing employed, temporary employed. It's the full range of people providing services made into a full-time equivalent number. So that's how, I guess, we measure the access to services, non-referred attendances under Medicare over time. And it has increased across all modified Monash categories.
And it doesn't include when a GP has closed its books, does it?
So GPs, and we did discuss this a bit last week, can close their books for a number of reasons. They can decide to reopen their books, they can close their practice, they can sell their practice. Practice changes ownership. We have some doctors that join corporate practices and, might close their practice at that point, but they're going to reopen or provide services through a different practice. There are different models of ownership, and, these things are private businesses, and change happen.
And Ms. Shakespeare, I've spent hours on the phone calling GPs who have closed their books. So I know exactly what that feels like. What I'm asking you, does your data reflect, does it include full-time equivalent GPs who would that are only taking new patients, or ones that are not taking new patients? And the answer is no, isn't it? I mean,
It includes services.
That's why services, but that's not including new patients. In terms of the Medicare rebate freeze, do you know, in terms of the financial impact, did it have a greater impact on outer metropolitan, regional or rural practices compared to city practices? Was there a analysis done to see whether the burden was being shared or whether it was being felt more widely by rural and regional practices? Because that is the evidence we've received today.
So we do publish MBS benefits page on a quarterly basis, which I understand is broken down into modified Monash categories as well as broad type of service. So that analysis would have been done, and I think the results are published on a regular basis.
So can you answer that question then, Ms. Shakespeare?
I would be able to go and pull the information about impact on benefits and the benefits that are going to GPs providing services in different modified Monash categories over time for you, if you would like that information.
Yes, we would like that information. Thank you. Just on the issue around district workforce shortages and the distribution priority area, we had some questions about that as well. I'm interested to understand, we asked some questions in estimates, but I'm interested to understand what have been, again, what sort of analysis has the department done to understand what the impact, positive or negative, would have been for those areas where they are now a DPA.
So
Sorry, I'm talking about the change from district of workforce shortage as a terminology to distribution priority area as a system.
Understood. So at the time we moved from the districts of workforce shortage, which we now just have for specialist doctors, not GP specialists. I should clarify, GPs are certainly specialists. Distribution priority areas replace the districts of workforce shortage system for GP services. We consulted with a lot of rural groups in the change to the two systems. So that includes our working group that contributed to the development of the DPA methodology, the College of Rural and Remote Medicine, the Australian Indigenous Doctors Association, the Australian Medical Association, the Monash University School of Rural Health, the National Rural Health Alliance, the National Rural Health Commissioner, the Royal Australian College of General Practitioners, the Royal Flying Doctor Service, the Rural Doctors Association of Australia, Rural Health Workforce Australia, the Rural Health Workforce Agency Victoria, University of Melbourne, Melbourne Institute of Applied Economic and Social Research, University of Newcastle Department of Rural Health, University of Queensland Rural Clinical School, and the Antarctic Division of the Department of Agriculture, Water and the Environment. So those groups were all involved in advising us on the development of the new distribution priorities area methodology to replace the old districts of workforce shortage. And, we're convinced that this would assist us in better targeting those areas that were experiencing shortages in GP access and GP services.
And what has been the impact on areas that were considered district workforce shortage areas, but weren't considered distribution priority areas?
The main change, as I understand it, and my colleagues will jump in and correct me if I'm wrong, is distribution of districts of workforce shortage used to compare areas to the straight average of all Medicare access across Australia, including metropolitan areas. Under the district distribution priority areas, the benchmark for access to overseas trained doctor employment, so doctors who are able to get access to 19AB exemptions, is now the average of access to services in modified Monash Category 2, so regional centres. So in many cases, there was a recognition that average benchmarks in metropolitan areas were not relevant. So we've improved the system. And there were areas that
wasn't my question, though. My question was, what happened to the areas that were district shortage workforce areas, but not district priority areas? So there were some areas that didn't get. Yeah.
So the impact on those areas was that they would not have been able to recruit overseas trained doctors. However, if they had an overseas trained doctor currently working at their practice, they could replace them. We do have exemptions to allow replacement of overseas trained doctors.
So did the number of GPs go up or did it go down?
Over time, the number of GPs has continued to climb.
In those areas that I'm talking about?
We'd have to go away and again have a look at that for you on notice.
Yeah. What data, you said you did have some data there in front of you, and you gave me the Monash, the figures for GPs in MM2, is that right?
That's right. So modified Monash 2, the FTE equivalent, GP full-time equivalent for MM2 from 2014 increased from 2,072.9 to 2020, 2,529.6. I can keep going through those numbers for the other MM categories, or we can provide them.
I'm interested in if you've got them there and you can provide them today, that would be helpful, either now or shortly after the hearing. I'm interested in the MM3 to 7 figures between 2014 and 2021. I understand you only have until 2020, is that right? We're not capturing the last 12 months?
So we're still going with 2021, so we won't have figures completed for 2021 yet, but I am giving you the most recent data we have. So for MM3, 2014, the FTE figure was 1,816.9. In 2020, that was 2,026.9. MM4, 1,125.1 FTE in 2014. In 2020, that was 1,276.9. MM5 in 2014, 1,262.6, increasing to 1,419.4 in 2020. MM6, 212.1 in 2014, going up to 220.2 in 2020. MM7, 133.2 in 2014, increasing to 143.1 in 2020. So I can also give you those numbers as a proportion of the population, so broken down per 100,000 population.
Sorry, do you have a breakdown of those numbers? What is the proportion between international medical graduates and how many of them are locally trained doctors?
I don't have that number on the sheet in front of me, but I'm fairly certain we can get that for you.
Okay, thanks. Do you keep data on the average wait time to see a GP?
So we're still looking into that for you from last week. I think our primary health networks do collect information on practice opening hours and things like that. So we might be able to get some information from PHNs, but I'm still looking into that for you, Senator.
But to be clear, the department doesn't keep that data. You have to ask for it from PHNs.
Well, it might be that somewhere else holds that in the department, the people that look at the PHN reports and manage their grants. We don't have those people.
So if I asked you what the average wait time was to see a GP in Emerald, Queensland, you don't have that information?
Well, I would like to consult with my colleagues in the primary healthcare division because I know that they've also been funding Emerald practices as GP respiratory clinics with specific funding to see patients during the pandemic. So we might have some data about that and access to those services in Emerald for you under that separate contract.
But only if there's a PHN in place. What about the areas outside of PHNs?
So there are PHNs operating right across the country. Primary health networks.
Yeah. But if it's not, you're saying that you might have some information from Emerald because there's a specific area of work occurring.
So
is that information that all the PHNs hold for every area?
So that was our GP respiratory clinic contracted providers. So we have one in Emerald where we've been funding access to GP services during the pandemic for people with respiratory symptoms in particular. So we might have some data under that contract, which is separate to the PHNs.
Yeah, so my question again was, do you have that data for all areas across the country? You said there's PHNs operating all across the country. Do you know how long it takes to see a GP in Launceston in Tasmania?
So as I said, Senator, we're still checking into what information the PHNs might have and might be providing to the part of the department that manages their contracts.
One last question, Chair. I know there's a lot of senators and maybe I might get some time at the end. Can I just on this issue of data as well, does the department collect any financial data on GP practices across Australia in terms of their viability or financial circumstances? We've obviously been given some evidence today and through the submissions about the viability of GP practices in rural and regional areas and how a lot of GPs are struggling at the moment.
So I'm not sure if in our primary care division, there might be some information about viability of practices that, again, we get through primary health networks. Those are our funded organisations that are looking at the delivery of sustainable and coordinated primary care services in communities.
So you'll have to take that on notice as well.
So we can provide you with a lot of information about workforce programs, Medicare benefits. Those are the programs that we've got a lot of information here today. But if you want information about the viability of particular GP practices, yes, I think we'll need to take that on notice.
Yeah, and we had this conversation in estimates as well, Ms. Shakespeare. I find it really hard to understand how the government can be making and the department can be advising the government in making policy decisions if you don't know how many GPs are in financial situations that they're under pressure, if you don't know what the wait times are, if you don't know how many patients or how many GPs are turning away new patients, and you say this is all information that you don't have at hand today, but if you have it, if it exists, could you please provide it to the committee?
So we do have, high-level data about increases in Medicare benefits that we're paying to GPs across Australia, and in particular areas of Australia. We have information about how much GPs are paid by Medicare, what their reported taxable income is, but we don't look at particular business models and whether, because there are a range of different business structures that operate across general practice. We have large corporates, and we would be able to get you information about how those large corporate practices that may report their profits are operating. But there are also a lot of small businesses, independent solo practices. Now, we don't collect information on all of the tens of thousands of separate businesses at the department level for the purposes of Medicare or health workforce programs. We might have information about particular practice viability issues that's collected through our primary health networks. But that's the sort of information we will have to go and ask about for you.
Thanks, Chair. I'll leave it there for the moment.
Thanks, Senator Green. Senator Hughes.
Thank you, Chair. I was just wondering if you could update us on how many more doctors and nurses are working in country areas as a result of the government's stronger rural health strategy.
I might ask Mr. Williams to talk about the Stronger Rural Health Strategy.
Apologies, I was trying to find the mute. Matt Williams, First Assistant Secretary, Health Workforce Division. Since the Stronger Rural Health Strategy has come online and the significant investments the government has made in rural health, we have achieved a growth in GPs in rural areas of over 750. And in terms of nurses, over 1,000 additional nurses in rural areas, regional and rural areas in Australia, as a result, since we've introduced the significant programs for the Stronger Rural Health Strategy.
Which MMSs are you including when you make those, put those statistics to us? Sorry, Senator Hughes.
That's a broad capturing from MM2 to 7. I can go into more detail on the at a lower level if you'd like, Senator.
No, I just wanted to understand what you were saying to us. That's all. Thank you.
Thanks, Senator Patrick.
Chair,
so are there any other outcomes that we're seeing from various workforce pipeline initiatives of the government?
Yes, Senator. So some significant changes, positive changes since the Stronger Rural Health Strategy. So as I mentioned, additional number of GPs, over 750, more than 1,000 additional nurses in rural and regional areas. GP services per capita, which is a really good measure in terms of how people are receiving their services, has gone from 6.3 to 6.4 in 2009. We've had a reduction in overseas trained doctors entering the primary health system, but at the same time, an increase in the number of those overseas trained doctors that go to rural and regional areas. So in 2018, 135% of the total of overseas trained doctors went to rural and regional areas. It's now over 60% as a result of the measures we've put in place with the Visas for GPs program. I can put on notice an additional list of successes and achievements that have come online since the Stronger Rural Health Strategy, and the government obviously continues to invest in existing programs and the development of new programs. One of the important points I think to make is that most of the significant investments have long lead times too as well. So some of the significant investments in terms of the training of the next generation of doctors in rural and regional areas, changes to the general practice training program, and the specialist support we do for the programs we have for specialists to train in regional and rural areas. They have longer lead times, and we're starting to see some of the impacts of that as well. So happy to put on notice some of the additional benefits that we have noticed, Senator.
That would be great. So the government's recently announced a 3-year extension to the Rural Health Multidisciplinary Training Program. That program's been around since 2016. How many students have participated in that program since then?
Yes, Senator, that's a really good question. So,
Senator, it's Martin Rocks from Assistant Secretary of Health Training Branch. Just as an overview from the, we've had between 2016 and 2020, we've had a total number of medical CSP graduates being 14,222 coming through the Rural Health Multidisciplinary Training Program, and that under those, that is a total of around 35 or almost 36% of all Commonwealth supported medical places undertaking a year of clinical training and study through the RHMT program. The other component of where they're since 2016 is the total number of entering CSP students coming into the RHMT program. We had 14,000 in total. That is 14,493, and in 2020 data, the number of entering students coming of rural origin coming in, CSP students coming in, represents 35.2% of the total Commonwealth supported places cohort, and that's a rise from 30.7% in 2016.
Okay. And with regards to the University Departments of Rural Health, what do these actually do, and how many students do those schools support?
So with the UDRH is the non-medical, so the allied health and nursing component of the RHMT program. We've got, in terms of the numbers, I can get some updated 2020 data on notice, but I've got 2019. We have 16,500 nursing and allied health rural placements were delivered in 2019 through the UDRH network, and that is equating over to 79,000 placement weeks for nursing and allied health services. It's also worth noting that with the previous, the 2021 budget that was in October, we've just undertaken to provide further, government's invested further in the UDRH program, and that's to following the evaluation of the program, and that's to note to provide an additional UDRH in an identified area of need following the findings from the evaluation. Also to open competitive processes to universities to stretch training in more remote areas, so looking at 3 to 7, and then also looking at projects where UDRHs can partner with aged care providers to deliver training at aged care facilities. We've had those grant opportunities have closed and are currently under assessment by the department.
Okay, thank you. We heard earlier today in the hearings around regional training hubs. How are those hubs being supported? How are they supporting rural training and ensuring that we're increasing that pipeline of future rural doctors?
So the hubs are, Senator, the hubs are also part of the RHMT program, and there's roughly around approximately 26 of those working nationally. The intent of the hubs are to provide on the ground networking and support and joining up of arrangements between the undergraduate and junior doctor placements and looking at strengthening and networking ties through the regions. Predominantly at the moment, there's a lot of work being done, particularly in the the non-GP specialist training space, but we see opportunity moving forward for those in the context of GP specialties and enhancing the network and collaboration to ensure continuous opportunities and experiences through the regional and rural training pipelines.
So on that, how many junior doctors are participating in the Rural Junior Doctor Training Innovation Fund, and what sort of opportunities are participants getting to experience, through that rural medical network and work?
Okay, so Senator, we've got two streams presently to the Rural Junior Doctor Fund. We've got the original Training Innovation Fund, and in 2021 there will be 264 rotations. And as an extension to the Stronger Rural Health Strategy, we also, the government also announced an extension to include rural generalist junior doctor training exposure. And we've got 268 placements occurring in 2021 under that program. Moving forward, there was a budget announcement to extend, and I'm aware that there's been some of the organisations and members and participants who've contributed this morning spoke of the importance of expanding the junior doctor pathway. The budget will move. The budget announcement, which will commence from 1 January 2023, will merge these two programs, and from the current baseline of 440 rotations to 800 by 2025.
Okay. Just to finish up my last question, I know I'm going to get wound up very soon. We've had a bit of a talk today around looking at ways to do things differently, innovatively. So, probably an appropriate name for a program, the Innovative Models of Care program. Are there any positive signs, particularly with regards to workforce outcomes that we're seeing early on?
Senator, we've Martin Roxer Health Training Branch. We've got, in terms of, there's two parts to the innovative models of care, but the one pertaining to training is around employment models, and we've got a Murrumbidgee, an arrangement which may have been spoken about earlier today, the Murrumbidgee Employment Trial, and that's under a 19(2) exemption with the Murrumbidgee Local Health District. And we're looking at the training of five RGs across the region. The intent of that is to actually provide some employment that registrars coming into that program have continuity of employment in terms of accrual of benefits and other aspects of their employment conditions through being employed through the Murrumbidgee LHD, and it's to look at one of the challenges raised going through training for registrars in coming in and out of different workplaces and employment agreements and conditions, and to look to what we can do to harmonise those so that there's a seamless experience, and importantly keeping registrars training in a region.
Just so I understand it, sorry, is that also working with, allied health professionals, pharmacists, bringing together sort of all the different elements?
So under the model, I might hand over just around the innovative models, but no, this one is a direct around working in general practice and the hospital setting in an arrangement with Murrumbidgee, the Murrumbidgee Health District.
It's Penny Shakespeare again. We do have other innovative models that are being either worked up or trialled at the moment that are looking at how you can better connect services across a local area for aged care, disability, as well as primary care and acute care. So we do have a few of those trials, and the Rural Health Commissioner, I didn't hear her evidence, I'm sorry, before, but may have spoken about some of those. As she has a grants program to help people develop those models. In terms of innovative approaches with pharmacists, there are also pieces of work happening through different primary health networks as well, looking at how different health professionals, including pharmacists, can be better integrated into the care team. So we're happy to also provide information about some of those projects.
Perfect.
Senator, it's Matt Williams. I can provide some additional detail on four of those innovative models if you like, but happy to take it on notice as well.
Yeah, no, that would be great. Thank you very much.
Thanks. And yes, if you could take it on notice, that would help us with timing now. So look, I will now move on to Senator Patrick.
Thank you very much, Chair. Just wanted to go to a couple of questions. I'll go back to Mr. Williams. You said that your statistics were for MM 2 to 7. Over what period was the increase? That 2014 to 20?
No, Senator, sorry, that was the increase over the period of the Stronger Rural Health Strategy, so since 2018-19.
Okay, thank you. Now, I just want to understand, just to go back to a couple of questions that came up earlier in the proceedings. There was a claim that training fees were being utilised, or the training fees that really were aimed at training for people going into regional and rural and remote areas. A figure of $2 billion was quoted, and it was said that half of it was going to, in effect, going to other metropolitan jurisdictions in the end, because providers were not held to account, weren't really tracking, or the Department of Health wasn't really ensuring that the money dedicated was going to rural areas. Does anyone want to comment on that if they saw that evidence?
Penny Shakespeare, Senator. Yes, I think I did see that earlier, and I think it was about specialist training program, but I could be wrong. So I think the department, the government is across a range of programs trying to tighten up our focus to make sure that rural areas are benefiting more from the investment that we do make. So Rural Health Multidisciplinary Training Program that my colleague mentioned earlier, that's a very large investment. I think it's around $200 million a year. A lot of the training has been occurring in larger regional centres, but the government's made some changes and invested a little more money in the last budget, I think it was earlier this year, to make sure that we're getting more of the rural health multidisciplinary training rotations in MM3 to 7. And that was as a result of an evaluation, quite a comprehensive evaluation we had of the RHMT. The specialist training program we're also looking at reforming, particularly as a result of the National Medical Workforce Strategy, which we're in the last stages of finalising. It's going through all health ministers for approval at the moment. But, you know, we need to make sure that we are genuinely targeting Commonwealth funding for specialist training. Most specialist training is funded and the responsibility of the state and territory governments through the public hospital system. But where we do have Commonwealth funding supporting specialist training, that is really targeted to areas of most need. So we are, at the moment, we've got a grant opportunity out there for those specialist colleges that actually want to make changes to their program delivery so that they can deliver more training in rural areas, and that might be through more flexible supervision, through remote supervision. We are definitely trying to address all of these issues right across our programs, and you know, that also goes back to the discussion we had earlier on around rural bulk billing incentives. We have tightened those up so that the rural bulk billing incentives aren't going to metropolitan areas. So it's an ongoing piece of work across a lot of programs.
Okay, thank you. Just in the way in which you look at costs, it's clear that you're using the MBS data quite extensively in terms of looking at things like or establishing GP FTEs per 1,000 people. Do you do that for cost? Is the standard denominator the MMSs? Oh, sorry, the MM divisions?
So we we have a lot of great administrative data through Medicare, and it goes back a long time. As you know, it dates back to the 1980s. We look at both services provided under Medicare and benefits paid under Medicare, and we, you know, can look at those separately for different types of services, for different types of specialty. For nurses that now bill under MBS and allied health, we can look at it by modified Monash area. We don't routinely break it down into electorates, but sometimes we get asked to do that by the senators. So, you know, it can be cut quite a few different ways.
All right. So I guess where I'm getting from is just trying to wonder what the number is for someone in each of the modified Monash areas. Whether or not, for example, the PBS numbers are categorised by numbers or health workforce costs, or primary healthcare networks are costed by that same denominator, being a modified Monash region.
So we are, over time, again, applying the modified Monash system to more and more of our health programs and approaches. So it was developed, I'm stretching my memory here, but I think we introduced it in 2015 based on a lot of work with rural stakeholders and experts in what were the factors that attracted doctors in particular, but health workers to rural areas. So again, over time, over the last 5 years, we will be using modified Monash as an overlay to our data as that system has been refined.
To the extent possible, can you provide to the committee a cost per patient, noting obviously using GP FTEs per 1,000, but if you can divide that by 1,000, just the costs associated with each per patient average over the modified Monash regions, and just include what data is in there, whether it's the MBS data, whether it's veteran health data, whether it's pharmaceutical data. So I'm not trying to ask you to do anything more than what is available, but I'd like to know what you might include in that.
Yep, we can certainly do that for you, Senator.
Okay, and specifically for South Australia, you've got these new GP catchments that you talked about in your submission. Again, I wonder if you could just tell me per GP catchment how many full-time GPs, so I'm not after specialists, just want to stick with GPs for the moment, are in each catchment area, either as a full-time doctor or as a part-time doctor. Is it possible to provide those numbers?
It will be.
Yes.
So are you more interested in FTE or headcount though?
In some sense, most people don't relate to FTE. They relate to, I've got a doctor that lives in my community. So I'm not really interested in locums that fly in and fly out. I just want to really get a feel for permanent doctors that are in each of the catchment areas. And look, I'm happy for you to, provide, if someone only works 4 days a week but still, is effectively the town doctor, I think that qualifies. But you could simply annotate any information you provided me with the criteria that you used.
And Senator, you're interested in the catchments in South Australia or all of them across Australia?
No, just South Australia. Other senators may ask for that data.
Okay.
My focus is on South Australia. The other thing and look, I thank you very much for for the submission you gave. It was quite comprehensive, but also for the answer you did eventually give me in relation to the modified Monash areas in South Australia. The reason I guess I was querying Mr. Williams is that I can see, if I look at the data, I look at it at a national level of a GP FTE per 1,000 people, and this is a question on notice SQ21 000944. If I look at that data, what I would say is that it was clear that around 2014-15 there was a bit of a jump, but then things have remained relatively static. And indeed, last year we saw generally a decrease in the GP FTE per million people. And I just wonder if you could comment on that. You might have heard me asking the regional workforce agency, what's happened there, whether or not we're getting value for money, because it just seems to me that it's relatively static. There are some ups and downs in there, but not necessarily trending upwards.
Yes, Senator, you're correct. There are, over time in South Australia, and this is, I guess, what belies the larger statistics and targets, etc., is over time there has been an increase in GP FTE for the state, but there are anomalies. That increase has not been consistent across the country nor within a particular state. And some regions in South Australia have increased substantially and others have plateaued and some have decreased. As you mentioned before, we do have a number of programs and partners on the ground to try and determine what specific factors to that area are impacting a particular town or region. And over time, we hope that those programs we can bring to bear to ameliorate some of the issues, but as this entire inquiry is showing, that it is very complex, and that rural and regional areas have some specific challenges and are different across states. So you're right, Senator, in your observation that it's not consistent at state level, nor is it consistent at the level. And those increases, there are anomalies.
Okay, and maybe just finally, it's been in the news that Dr. Scott Lewis has left Woodner, and one of the difficulties that he expresses is problems with the state health system. And whilst I respect issues of comity between state and federal, in the end, it is the federal government that is largely funding, a doctor in Woodner, and I wonder whether or not the department might contact Dr. Lewis, almost doing an exit interview to try and find out what it is that was going on that was difficult, that caused him to ultimately up stumps and leave. Again, noting it's Commonwealth funding, and I know now that in order to replace him, you guys are going to have to spend a lot of money. One of the comments he made to me was that you'll happily spend money on locums, but not on potentially improving conditions for existing doctors. So I just wonder if you might be willing to at least speak to Dr. Lewis, because it's a significant shock to in and around Woodner to lose a long-standing doctor, knowing that that it's going to be really hard to replace him.
So it's Penny Shakespeare again, Senator. We do often talk to practices that have decided to close in individual areas, and with the rural workforce agencies or PHNs, work with them to see what has happened and what we can learn from that. We've certainly done work recently. I just think back over the last 12 months, there were GP closure at Katherine. We did some work at Bombala. Happy to do work there as well. I do just want to let you know about the locum support. We do provide funding under the Rural Locum Assistance Program. It's to let our rural doctors take leave, so they can have holidays, or they can go and do CP, continuing professional development training, that sort of thing. And there are certainly grants available through our Rural Workforce Agency, the Rural Workforce program, whether they can provide grants to individual doctors that might keep them there, whether it's additional training, additional financial incentives. So there are some programs currently available, but I might ask Dr. Wern actually to add to this.
Yeah. Thanks, Susan Wern, Health Workforce Division. Thanks, Senator. Yes, would be happy to speak with Dr. Lewis, but I think the issue that you raised regarding the benefits paid to locums versus the benefits paid to ongoing staff was something that we heard repeatedly when we were doing the consultations for the National Medical Workforce Strategy, and that's one of the recommendations in the strategy. Because it's a state funding issue rather than Commonwealth, we'll need to do that sensitively, but the concern was raised that it seems to be separate buckets of funding, and therefore it's difficult for even those who are employing locums to know what the opposite side of it would be. So it's different people doing different things. So a big piece of work that I suspect will produce some interesting results.
Okay. Well, thank you for that. And I'll just finally, just extending on that, Dr. Lewis indicated that part of his frustration is plans being made in Adelaide by people who are not cognizant of the real issues in rural areas. And again, whilst Dr. Lewis has raised those concerns. I'm aware that there are other doctors that feel similarly, and it would be beneficial, in my view, to talk to him not just about the locum issue, but the frustrations that he had with the state government. Again, I respect principles of comedy, but this is state money sitting alongside federal money, and maybe some difficult conversations need to be had in order to get the best outcome.
Thank you, Senator. We're very happy to engage with our colleagues at SA Health, and I know that the Minister for Regional Health has very recently talked to his counterpart, the Minister for Health in South Australia, about the issues too.
And if anyone needs his phone number from your department, I'm happy to provide it through my office. I'm sure you probably get it anyway, but there's an offer. Thank you, Chair.
Thanks, Senator Patrick. Senator O'Neill.
Thank you, Chair. Just confirming you can hear me.
Yes.
Thank you very much. And thank you to all the officials from the Department of Health for being here today. Can I first ask for any of the data that you can provide in the form that you're providing it to Senator Patrick for the state of South Australia to be provided to the committee also? I'm particularly asking for the state of New South Wales. I'll leave it to other senators to discern which states this might be relevant to, but I certainly want to know the data for New South Wales and break down and figure out where the workforce is and what you know about where the workforce is, because it seems to be a very big problem. Can I also thank you for your detailed submission, but can I firstly indicate that it reads like an alternative and parallel universe by comparison to some of the evidence that I've received in my duty seat visits across New South Wales and in some of the responses that I've had online during the course of the inquiry today. If I could just, can I put to you, this is what I was told today. What's your response to this? Have you spoken to any new GPs recently about their rural placements? No time for compulsory study, endless on call for after hours at the local hospital. This means they can't develop any community or social life. Their appointment book is being triple booked. No wonder they head back to the city as fast as they can. And that's not an isolated comment about how grossly mismatched the workforce is to the needs of rural Australia. That's my first question.
So, Senator, I'm not quite sure what the question was, but you're asking us to comment on whether or not people have good or bad experiences in their, was that a GP training rotation or was that junior doctor or medical school?
That was a GP training rotation.
So the Australian General Practice Training Program is currently under reform. We are working with the Royal Australian College of General Practice and the Australian College of Rural and Remote Medicine to make sure that that program is delivered in a way that's going to increase the primary care workforce for the community. We've had reduction in interest over the last few years in GP training, and we want to make sure that it's a high quality, safe and enjoyable experience for all of our GP registrars. And we've been putting in an enormous amount of work with the current training providers, with the colleges, with the Supervisors Association, the Registrars Association and other interested stakeholders in how we can improve GP training. So it's something that we're looking at the moment, Senator.
Senator.
And I'm sure that you are looking very carefully at, and I'll take a further response as well, but I've been taking evidence in committees for health from both the House of Reps and in the Senate now for nearly 11 years. And the consultation that's constantly spoken about is simply at odds with the experiences that people from regional and rural Australia continue to put on the record. It's almost like, watching while Rome burns. There's the consultation's going on, the planning's going on, the data collection's going on, and in the meantime, people are dying at a higher rate in regional Australia and rural Australia and GP businesses, the small business model that existed, basically just collapsed in 2014 with removal of the rebate or the suspension of indexation around the rebate under the leadership of Mr. Abbott. That the whole thing seems to be in permanent state of crisis. And I'm just wondering if this is the next effort of a rebuild after the destruction that happened with the pulling of the PGPPP program. Do you have a response to that? Because I hope I'm conveying the level of frustration that I experience in meeting with the community as a senator.
So, Senator, the pre-vocational general practice placement program is aimed at a different group of doctors. So the earlier example you provided us was a GP registrar
GPs
training.
in training, yes.
So the junior doctor training, which was funded under the PGPPP, was a different group of doctors, and I'm not sure we can link the experiences of people under the GP registrar training to the cessation of a particular program that was aimed at junior doctors, which are, largely based in hospitals doing their intern year mandatorily and junior doctor training after that. But we also have a new junior doctor training program in place now too, and my colleague Mr. Rocks went through that in some detail earlier
today, and that was the 800 versus the 4,000. And with respect to Ms. Shakespeare, like, you'll do a wonderful defence of the department and the current action of the government at this point of time. But the people who need access to GPs don't care whether you're talking about program A, B, C, or Delta. They don't care. They just want to have properly trained people who are committed to that community, who have sufficient financial benefit and interest in bringing their high-level skills to be part of the community. And they don't care what program you're talking about, and they will be less inclined to be worried about, connections of the impact of this program with that program. And I understand that's your job, but surely the outcome of your job overall must be the provision of service access at a high quality level in an equitable way across the entire country. And rural contexts simply are not getting what they believe they have a right to. So what's new? What are you going to fix? How are you going to fix this massive problem?
So, we again need to continually look back to what the data is showing us. And, I understand I've also been working in this space for a long time, and I've been hearing for a long time that we have a crisis. I think the data shows that probably our crisis is a little less acute than it used to be. But that's not to say that there aren't particular issues, and we work very hard to resolve particular issues when they come up. We have programs that are aimed at addressing because, data at a national level or a state level or even a modified Monash category level doesn't help you, as you say, if there is a particular town that's just lost its doctor. But we have targeted programs, including the funding, which is about $27 million a year, for the rural workforce agencies to help those communities in crisis get access to a doctor that can provide Medicare services.
And that provision, if I'm not, please correct me if I'm wrong, but the provision of that service has been increasingly by very expensive locums who are flying in and flying out of communities.
No. So
how much is that being provided by locums? Because if I can ask you to think about the questions that Senator Green asked you, and when you provide that data to her, can you provide it with the extraction of locums? Because I want to get a sense of the scale of how many locums are floating around in this system that are being counted to FTE and or headcount.
I'm sure we can have a look at whether or not we can quantify that for the Medicare billings that we use. I think a lot of the locum issues, as my colleague Dr. Wern mentioned before, are to do with state public hospital service provision, and that certainly came out in our discussions around the National Medical Workforce Strategy. But locums are just one solution that can be used where we've got a community that needs help getting access to a doctor. And we will work with the rural workforce agencies and the primary health networks to find other longer term sustainable solutions. And we've been able to do that in particular locations. And I'm happy to provide case studies to you on notice. So, you know, we've got strategies and approaches that we can take that are funded, that have local on-the-ground expert knowledge to help us. So it's not just people sitting in Canberra or sitting in Adelaide who are making the decisions about how services are going to be provided to a community. But we do have strategies that can successfully resolve problems in particular communities.
So where you have been notified of a loss of a doctor or a crisis in health access in a community, such as, you know, I know Senator Green's been talking about people in Emerald waiting for 3 months for access to a doctor. You know, I live on the Central Coast, which is, you know, in some parts less than 100 kilometres from Sydney, and I've got mothers with new babies who can't get into a doctor because the books are closed, who are travelling for 60 kilometres to get to a doctor. That's the scale of the problem I'm talking about. You know, whether it's close to the city or really remote from the city, it's problematic everywhere. So do you have a map of where the crisis exists, where the crises exist, where you have successfully replaced a doctor with a locum and then gone back to actually put a GP, a proper GP, functioning GP practice in place that meets the local needs and is integrating well with the local hospital? Because all of those bits need to be connected for proper provision of health service in regional and remote Australia. And so often in towns that I go to, like in Cobar, Coonabarabran, Bourke, Brewarrina, Walgett, Deniliquin, I meet with local GPs who are so frustrated, many of them now aging, desperately concerned that for all the talk of the federal government, for all the efforts of the departments of health, both state and federal, and for all the announcements of money for different buckets, that the entire system is so robbed of connectivity and so poorly planned and integrated that the whole country is teetering on the brink of a failure of access to GPs. And I think that anxiety has only been heightened by the COVID crisis.
So, Senator, the pandemic has certainly made it harder for us to increase the numbers of doctors at the rates that we were seeing before the pandemic. I think the biggest impact there was because our borders were closed, and not just because Australia's borders were closed, also because there was very little international flights, particularly into Australia. We weren't seeing the same level of doctors, overseas trained doctors, and overseas trained nurses and other health professionals as well coming to Australia. Now that the borders are open, I'm expecting that will improve. I think your general question, though, is about can we provide you information about how we have worked with communities to solve particular problems, and we're really happy to do that. And I think if we get some information from, I think in your case, you'd probably be most interested in the work that the New South Wales Rural Doctors Network does, the Rural Workforce Agency in New South Wales, about how they've resolved particular local solutions with access to primary care services. We can also provide you information about some of the innovative models of care that we're now funding in New South Wales communities and how those
Ms. Shakespeare, I am interested in those, but a vignette of a particular problem that was resolved with a huge amount of effort, as much as that gives me hope for particular communities, does not give me hope for an entire structure that seems to be on its knees. Well, in terms of access and guaranteed access to quality services, and a GP who's not being worked to the bone in regional and rural communities. I see it everywhere I go. And what I'm frustrated about is that the response of the departments is kind of a form of denial of the reality that I keep confronting. And that's why I want to put it on the record as a senator, because that's what people are saying to me, that they cannot get a hearing of what their lived reality is. And it's not just in isolated towns. It's not just a pocket. It's across the entire system.
So again, I don't think that we're in denial. We can present you the data that we have at the system level. And in New South Wales, like other jurisdictions, you know, except Northern Territory, there's generally been increases in GPs and GP services. But
are those increases
as I was just
including
saying,
locums?
Senator O'Neill, we need to finish up. So let's
sorry.
the department finish.
But we acknowledge that there are particular issues, and that's why we would need to provide you with information about how we resolve those individual issues. It's not denying that they don't exist. We just need to take a targeted approach rather than a system-wide approach to resolve those issues.
Do those numbers you're citing me include locums?
Senator O'Neill.
Thank you, Chair. Do the numbers you're citing me include locums? Because they are not a local GP, right? They're a FIFO worker with no commitment to the community or a tangential one. Do the numbers you are quoting me include locums?
Yes, locums provide Medicare services.
And they're being multiply counted in many, many places. And that is a distortion of the fact. And that means the facts that are going on the record in terms of numbers do not meet the reality of people getting to a GP. And that is why we're having this inquiry, because there is a big problem trying to get in to see a GP in regional and rural Australia.
And Senator O'Neill, well, look, I think that's a good place to end our session today. So look, thank you very much, the department, for your evidence today. So the committee is requesting that answers to question on notice be provided to the Secretariat by the close of business on Thursday, the 18th of November. So that now concludes today's hearing. So on behalf of the committee, I'd like to thank all those who have made submissions to the inquiry and made their representatives available today. I'd like to thank Broadcasting, Hansard and the Secretariat staff for all their assistance today. The committee now stands adjourned. Thanks, everyone.